So without further ado, Miles Levine, thanks for joining us.
Hello, everyone. It's quite a crowd. It's 66 people in here. That's amazing. I'm Miles, and I'm really honored to be here. I am from Northern California. As Russ said, I sit on the board for the Northern California Epilepsy Foundation, and I have epilepsy myself. I was diagnosed around age 4. And I have absence seizures and grand mal seizures, and I'm sort of a medical mystery. I've seen countless epileptologists. I've seen somewhere near 100 different physicians of all different shapes and sizes trying to figure me out, and no one knows. I've failed 11 medications, and so you could call my epilepsy medically resistant. And my experience has always been that I joke that in school I got bullied for other reasons. And I sort of went into school in my elementary school years with just this kind of naivete of I'm going to be treated normally. This isn't gonna bother people. And so I would tell people, my brain does this crazy thing, my brain shocks itself. Isn't that crazy? And people would go, whoa. And it didn't really impede me too much in the early years. And then as I started, I was a teenager, and then I'm 26 now. I'm in my early 20s. The differences between my life and other people's lives really started to show themselves. Not being able to drive, having to say no to lots of coming of age type experiences, and sort of having this general sense of being left behind. But I was not aware of the brutality of epilepsy stigma until I was about 15 or 16. When I was encouraged to work at a camp for kids with epilepsy in my area. And at first I really didn't want to go. I wanted nothing to do with it. And I was convinced to do it. And I went, and a kid my age told me that he had never made a friend before. And that really shook me to my core. I had no idea how it could happen that so many of these kids, they thought they had this rare disease. They thought they were the only ones who had it. And they'd find out that epilepsy is in fact relatively common, and that they were worthy of being treated like regular people. And that they could go so far into their teenage years without having that experience really bothered me. And I started participating more with the Epilepsy Foundation of Northern California and doing a lot of public speaking and things like that. And I'd make the camp video and that kind of thing. And the next thing that really struck me was I found myself in a room a lot with a lot of people who were really excited about epilepsy awareness. The problem is that all of those people were already there because they cared about epilepsy. So we'd get together and we would say, wow, we really need to raise money for research. And wow, epilepsy stigma is horrible. I got kicked out of my family at a young age. My school is rejecting my child, and all of these horrible things. We really wish we could do something about epilepsy stigma. But the people contributing to epilepsy stigma are not in the room. They're contributing to epilepsy stigma because they have no idea about epilepsy. They have no point of reference for epilepsy. When was the last time you or I or anyone else went to an awareness rally for a condition that we know nothing about? It just doesn't happen. Like, you can't blame people. And all stigma is a horrible thing, but it's a simple beast. It's a lizard brain reaction to not having enough information. It's a fight or flight response, being scared that something's happening, or you've met someone that you don't understand. And the good thing about stigma, if I can go that far, is that there's a simple solution, which is that people have to have the opportunity to care. The problem is that while these events, these like walks to end epilepsy or these fundraisers, they're great for those purposes, they're not particularly great for awareness. So there's a solution. And what really struck me was as a filmmaker, noticing that we exist in a time where in the world of entertainment, people are going out of their way to seek stories they haven't seen before. So while we can't really get random people who know nothing about epilepsy awareness to show up at an awareness rally, those people are sitting down on their couch every night looking through Netflix for something that seems new. We have to go where people already want to hang out, if that makes sense. So what I did is I went to my Epilepsy Foundation and I said, I want to make a short film and let's just see what happens. And I'm going to put on screen what I believe is an authentic, empathetic point of reference for what epilepsy means to me. And then regular people, quote unquote, regular people will watch it, and without having to meet a real physical person with epilepsy in real life, they will experience what it's like to care about someone with epilepsy. And they're going to go back to their community a lot less likely to contribute to stigma. And so today we're going to watch the film, but I'm very, very excited about the response. The film played some 40 different film festivals around the country. And these were not like disability events. They were the general public seeking this project out. Some of these events were Oscar qualifying events. And the stars of the film they're Disney Channel stars, and they're tremendous actors. And because of the nature of that, we had kids reaching out, and I'm going to show you images of this later, drawing fan art, asking questions, and they haven't even seen the film yet, asking questions like, I think my classmate might have epilepsy. How can I ask them questions about it and be respectful? What should I know about epilepsy? One girl reached out and said, I want to give a speech at my school about epilepsy. Can I have some resources? And in really meaningful cases, we had people watch the film and say, you know, I gave up on seeking epilepsy treatment and I'm going to go see a doctor now. And we've had people use the film as a coming out, unwilling or too afraid to share with people that they have epilepsy, but being able to have others confront it in such a way that they didn't have to speak up. And so the short's been this really great tool. And it's been very meaningful to me, and I'm looking forward to sharing it with you. And we can talk some more about it. So the first thing I'm going to do is I'm going to share a little behind the scenes thing. That's sort of a little bit of the spiel I already gave you, but it shows you a little bit about the making of, and then we'll watch the film. Does that sound good? All right, I'm going to share my screen. All right. Oh, that's not the right one. Oh. Okay, here we go. And then I'm going to share my audio. Okay, here we go. Hi, my name is Miles Levin. I'm the writer and director of Under the Lights. Under the Lights is a short film about a character named Sam who has epilepsy, and he's so desperate to feel like a regular kid that he goes to prom knowing the lights will make him have a seizure. We cast 2 incredible Disney Channel stars. We had Emmy-winning producers. This was not an easy film to make. We built our set, a bathroom that fit all the dimensions that we needed and that took months to build. We set up a prom scene that took 2 full days just to put the decorations together. We had a crew of 20 people from Los Angeles, from Sonoma County, who said, I don't care how far I have to drive or how long it's gonna take. I wanna be a part of this.
I was just really taken aback by sort of how original it was, how sweet and genuine and authentic it was. I was so uneducated about epilepsy. I just started becoming so much more curious. It was one of the best experiences I've ever had.
I was blown away. I hope the film brings an ordinariness to an extraordinary situation. I want the film to help the general population understand.
I had so much fun. I don't know what it was. I didn't have any seizures while I was on set, and these days were long. We're gonna start an interest in talking about a demographic that does not get seen on the silver screen. And we want to fight stigma with cinema. And I think we're off to a good start. What was important to me was a few things. One, I recognized that the only time I, as a person with epilepsy, see a seizure on screen as a device used to scare people. And that, I think cinema in many ways has created the stigma. I think part of the reason we have stigma at all is because of movies and television. If you think about it, the only times you see a seizure on screen is largely in a hospital show, or if or sometimes it's attached to the stigma of drug use, or sometimes it's just straight up, someone there's an exorcist and someone has a demon inside of them, a horror movie setting. So I believe we've trained people in many ways to fear epilepsy. So what was important to me was a couple of things. I really wanted to make something where we don't have to watch the seizure to care for the person. It's about the person and not the condition. It was also important to me not to antagonize or to have a bad guy. I didn't want there to be the mean girl who is calling him names or something like that. I wanted to humanize her as well, that I believe most people are decent. Most people are good people. They just don't have the tools. They don't have the information. They want to do the right thing. It's just that their first impression or their first impulse might not be the right one. And so that's what I wanted to do. And so I mentioned a little bit about what has happened with the film, and I want to share a couple things real quick. Let's do the screen share again. So here's some of the fan art. Hopefully everybody can see my screen now. These are just kids. These are just kids who have found the film and they haven't even seen it yet, but they're compelled by the idea of a kid who wants to go to prom, and they empathize with the concept, and they're drawing. Like, this one really moves me. This is Not Stronger Than You, someone wrote. And this stuff comes in daily. And it really, I believe it shows that my theory is correct, at least, that especially children, I think, want to do the right thing. So the world we want to live in, where people just treat each other like human beings, it exists. It exists already. We just have to provide those opportunities for people to give a darn. And that's where we're at. If you're interested in seeing the film, when I'm ready to release it, the best way to do that, or if you'd like to talk with me further, is underthelightsfilm.com. If someone could put that in the chat, that would be great. Underthelightsfilm.com. And you can put your email in on here and right here, and I can make sure to get you the film if there's someone you think really needs to see it. Underlightsfilm.com, and that Instagram I just shared, and it's on Facebook as well, as at Under the Lights Film. The next thing that we're doing is, it feels kind of silly to just, if one thing works, to never do it again, right? And so my dreams are twofold. One, I want to make the feature length Under the Lights movie. That's like the 100-minute publicly available big movie. And one day I'd like to create a grant for filmmakers to find the next filmmaker who wants to tell an epilepsy story. If you look at the LGBT community, for example, they've reached a point where they've committed so much to making sure that their stories are heard that they can no longer be ignored. There's actually, the Academy actually has guidelines now that if you want to be considered for Best Picture, there has to be diversity in different aspects of your production. And so I believe that the very best way that I can serve my community is through this pursuit of epilepsy awareness through cinema. A feature-length film, if it's done well, creates an environment where, for kind of the first time, the press wants to come to epilepsy. And instead of epilepsy, our community begging and pleading our news channels and newspapers to just put in one column about us. And movies live forever. And so this is my effort. I'm really excited about the feature film. I wrote the screenplay, and I was maybe I don't usually give myself enough credit, but the most competitive screenwriting competition in the world is called the Nichol Fellowship. And I think there's a leaf blower. I hope that's not distracting. It's called the Nichol Fellowship. And it's run by the same people who do the Oscars. And the screenplay placed in the top 1% worldwide of 8,200 scripts. So there is interest outside of our little community of 1 in 26 people who want to see us heard. And that gives me great hope for the future. And so, all I really need we have the team in place, and I'm just trying to raise the money and such, but I'm just here in Sonoma County, just trying to do my best. So if this piece, I do need to take a moment to say, if this piece moved you, and if you believe in my mission and you'd like to get in touch and you have ideas about how to get this out there, or, how to get this movie made, I'd really like to hear from you.
Great. Thank you so much, Miles. That was, I assume you've been looking at the chat box, but all of the feedback about the film was just relaying how impactful and inspiring that was. So we do have a couple of questions. So let's ask those. So one of the first questions is, what type of seizures do you have, Miles?
Yeah, so I have absence. They call it myoclonic absence seizures. So that's, staring spells and the shakes. And that's enough. I have grand mal seizures as well. Luckily, that's subsided some in recent years, but it's still a big concern for me. Interestingly, I think it's the absence seizures that have a bigger impact on my life, because I can't drive. I have to deal with the cost of Uber to go anywhere. There's places like, Uber will take me to that I can't come back from. It means I have to live in certain places and not others. It affected my education in some ways. And those are my conditions. It's also affected me physically. My shoulders dislocate really easy, and I can't play sports or do a lot of physical activities anymore, from injuries from having seizures and things like that. Yeah.
Great. And as a follow-up question to that, the same person asked, do you have your seizures at night or day, or both?
Both. The grand mal seizures seem to, for some reason, to be right smack in the middle of the night, but I'll probably have some blips while I'm sitting here talking to you, and I'll be glad to point them out. Absence wise,
Right. So as we wait for, another person asked, how frequent are your seizures, and like maybe how has that changed, your seizure control changed over time? And
yeah, it's varied a lot. It's varied a lot. My seizures are affected. A lot of the sort of normal triggers of, sleep, eating well, eating often. My metabolism just makes no sense. I gotta just eat nonstop and shovel food in my mouth. And I have to go to bed on time. I cannot be out late. I can't have stressful days back to back. The only way I can work a job is if it's the right job, you know, and the right environment. Everything needs accommodating. There's a lot of opportunities I've had to say no to that I think would have been pretty life-changing. But something that I hold close is, and something I think I've become good at, is finding a way to surround myself with people who not just know my needs, but value me enough to meet them, you know. So not stick around groups that are a bad choice for me. And learning to talk about epilepsy with confidence is an ongoing challenge, but I tend to find that it makes a world of difference. I have tried everything, you know, the ketogenic diet, all kinds of things. Honestly, I think many of the medications I've been on are made my epilepsy a lot worse through side effects and my body not processing certain compounds. Something I would recommend to people, and this is not, I'm not telling people like what drugs to try or anything like that, but something that was useful to me was having my genetics read. I suddenly found out that, oh my goodness, all of these drugs that I took had something in them that I couldn't process. We could have avoided years and years and years of suffering, you know? So it's this roller coaster ride, where eventually I couldn't bear to be in a doctor's office anymore.
Right. Someone, you mentioned the ketogenic diet. Someone asked if you've tried the VNS or any other neurostimulation devices or surgery, or any other treatments.
The VNS was not a fit for me and my particular needs, but I know it helps a lot of people. You know, we did things like biofeedback, and we tried, I mean, I could go through a really long list, but right now the best thing is to make mature decisions for myself. I cannot afford to put off my meals. I cannot afford to be out late, and to build a life for myself that I enjoy, that makes me feel good and not left behind, to do things that give me confidence, has really been, I think, the magic bullet. There are things that I will just always need help with, and that's okay.
Great. So one question that I have for you is what has been your approach in raising awareness to the challenge of kind of portraying the whole spectrum of epilepsy, where on one hand we're trying to convey that people with epilepsy are just like everyone else and can do everything that anyone else can do, but on the other hand, that epilepsy for some people can be devastating and can be impactful. How have you tried to balance that through this film and through other public awareness efforts?
Yeah, something I point out is that what's hard about representing epilepsy, uniquely epilepsy, is that it is so broad and presents itself in so many ways that if you had a character that presented all of epilepsy, all the different kinds of seizures, all like as many experiences as possible, you would ultimately end up representing no one, I think. And so a choice has to be made of what kind of epilepsy patient are we dealing with? And then to make the film about not necessarily the symptoms, but about the way it feels, at least to me. That's the only point of reference I have to honestly portray as what I think it means to have a disability. And for me, I believe it's the experience of knowing what it's like to be left behind, and knowing what it's like to have a moment where you have a, maybe it might be brief, but I believe that everybody has this, of that fantasy saying, how far would I go? What would I do to have that thing that everyone else seems to take for granted, that I would kill to experience? You know, for me, sitting in the driver's seat with my hand on the ignition, knowing full well I'm not going to drive that car, tears me up. it's that kind of thing that people who don't have disabilities know what it's like to feel. Everyone knows what it's like to feel ignored. Everyone knows what it's like to feel left behind. And everyone knows what it's like to want something that they can't have. And so to present a disability through that lens, I believe allows not just a variety of epilepsy patients to feel like, oh, okay, that feels true to me, but it allows everyone else to give a darn, I think, about this person, even if hopefully they'll never have a seizure themselves. Something that I think is really well said that Carlos, president of my foundation, says is, epilepsy is awful, but even for someone who has seizures all the time, the amount of time spent having seizures in your whole life is actually a pretty small chunk of the pie. Doesn't mean it's not awful, doesn't mean it's not true suffering. But the rest of the time, what makes epilepsy hard is being left out, being misunderstood, and just dealing with the people, right? That's what never goes away. Even if we find the cure tomorrow, we're always going to be dealing with the people. And I think that that's the fight we can do right now, because the cure might be, I don't want to hurt anyone's feelings, right? But a cure that works for everyone in our huge vastness of the spectrum of epilepsy, it could be a long way away, but we can affect the way people treat us today.
Right. Someone asked what you would like to add to the full-length feature film. Obviously, no spoilers or anything, but what are there particular elements you want to explore in the feature film?
Like I just said, I think the social and emotional aspects of epilepsy are the untold story. And it's not just the patient that has epilepsy, it's the family. And, I know from living with my parents, seeing it affect them, seeing them have lives that are touched by this and things that they don't get to do anymore because their son has epilepsy. And I want to tell that story, or in the script, it tells that story. What's it like to be a parent of someone with epilepsy and to want so bad for them to have the things they want and to let them have as many grains of independence as you can possibly give them, but often not being able to, having to say no to your child when they just want to be like everyone else. That's a really awful, horrible experience. And we focus a lot on the patient, and that's okay, but those people have epilepsy stories too. What's it like to be in a classroom worried about what other people think? What's it like to be a friend who wants to be a friend, but maybe doesn't totally understand? I'm trying to cover all of those things. And I feel confident that that's what we've done. And it will get people on a much bigger scale asking questions, not just about the symptoms, but about what they can do to help.
Okay. Well, just looking at the time, were you going to share that link, or was that something?
The website?
For viewing the film for.
Oh, right.
Sorry.
Sure. So something I'm going to do is, if you had technical issues with the film, I'm going to share a link with you to the film. Now, the film has not been released, and I'm going to be really frank with you right now. I'm really going out on a limb here, because if the film ends up on a website somewhere or someone shares it, I no longer get to release the film. Our ability to make the feature film is impacted, and it sort of all goes to hell. So, so I'm asking you, if you'd like to see the film, you had trouble watching it, please watch it on this link, and please don't share it. And I'm going to have an immense amount of faith in you guys. And again, if you want to reach out, underthelightsfilm.com. So here comes the link.
Yeah, and just be sure to put it so that blue rectangle says everyone, not host.
Yes.
Yeah.
Oh, I haven't been sharing. Okay, I'm going to put everything in here now because I haven't pressed the everyone button. Okay, so this is my email. This is the website, underthelightsfilm.com, where you can put in your email. And this is the link, and it has a password, and the password's helmet with a capital H. And here that comes. I got that. I got it wrong here. Thanks for your patience here, Russ. All right. All right, and here comes the link with that password. All right.
Well, we so appreciate you sharing that and sharing your story and your film with us today. Great way to kick off this conference. And again, we really appreciate your the great work that you've done to raise awareness and combat stigma through this film. And we're all rooting for you for that full-length feature film. So
thank you. If anyone has any ideas on how to support that and help me make that happen, I can't do it without you. Doesn't happen in a silo.
Thank you, Miles, for a wonderful presentation.
Absolutely. Thanks for having me. This was really fun.
Yep. So welcome to the session, The State of Epilepsy Care, Progress and Opportunities. This is sponsored by Beaumont. Once again, I'm Russ Derry, Director of Education for the Epilepsy Foundation of Michigan. And we're pleased to have as our presenters, Dr. Nour Baki, who is an epileptologist from Beaumont Health, and Dr. Cesar Serrano Almeida, a pediatric neurosurgeon from Beaumont Children's. So Dr. Baki, you can go ahead and get us started.
Thank you so much for having me. I'm really excited to be here. It's my first time speaking at this conference, and I'm really honored and pleased to be here. Let me do my screen share. So just the outline of what I'm going to be talking about today, I'm going to be talking about what treatments we have currently, the newer anti-seizure medication that have been on the market for the past few years, and new rescue medication. We're also going to be talking about drug-resistant epilepsy and the treatment, and Dr. Serrano will also be talking about surgeries in that regard after I'm done with my portion, and I will talk about future treatments and things that we're working on right now. All right, so currently we have a lot of medications available. Over the past 30 years, we've been having a surge of new medications coming in the market for the treatment of epilepsy. Now we have about more than 30 drugs available for treatment of epilepsy. However, despite that, only a third of people with epilepsy achieve seizure freedom. So not that much different from years before when there weren't as many drugs available. However, the clinical outcome has improved, and we're going to talk about this in a bit. I keep getting messages about my video, so I'm not really sure if things are working now, but sorry. I keep pressing start, but it doesn't seem to be starting. So the first medication that was available was phenobarbital that came in 1912. And then in the 1930s, we saw phenytoin come in the market. And between the 30s and the 80s, we saw a few more, carbamazepine, valproic acid, and ethosuximide. And after 1985 is when we see a surge of new medications coming in the market. The nice thing about the new anti-seizure medication is that they have a safety advantage, less side effect, less monitoring of blood count and liver function and all that. So in overall, the newer medication seems to be better tolerated. And all of these medications have different pharmacokinetics, efficacy, and adverse effect profile. And that helps us as a physician to better tailor treatment based on individual needs. Sorry. So yeah, over the past 50 years, because of these new medications and us learning more about different epilepsy syndromes and different seizure types, we're able to tailor treatment based on your type of epilepsy and also comorbidities, the types of medication you're on, to make sure that the medication that we put you on doesn't interact with other medication. And also because we have different medications with different mechanisms of action, we're able to add medications. If one medication doesn't work, we can add something else with a different mechanism of action and potentially have more chance of leading to seizure freedom. We also, because of we know more about the different epilepsy syndromes, we can, predict whether the type of epilepsy you have, you could aggro it or not, and whether we're able to discontinue medications in the long run. But also a big important advance in terms of when it comes to introduction of the second generation anti-seizure medications is the reduction in teratogenic risk. So the Europe registry, which is a European pregnancy registry, investigated all that, and they noticed that from 2000 to 2013, there have been a clear-cut decrease in the prevalence of major congenital malformation. Actually, there's been about a 27% decrease in the prevalence of major congenital malformation from 2010 to 2013 compared to 2000 to 2005. And that's a strong indication that we're, with the introduction of new seizure medications, we're using valproic acid less often in our young women patients because we know that at some point they're going to want to start a family, and we try to avoid this medication in that population. So as you see, valproic had a significantly higher level of major congenital malformation compared to the newer medications like levetiracetam, Keppra, Lamictal, and oxcarbazepine, Trileptal, which has a significantly lower prevalence of those malformations. So the newer medications that we have over the past 5 years, those are the newest medications on the market for epilepsy: Briviact, Epidiolex, Xcopri, Afinitor, and Fintepla, and we're going to talk about it briefly. So Briviact is actually is sort of like a sister medication of Keppra. It's the same, I guess, molecule, just structurally modified, and the aim of that was to improve its pharmacological profile, and it works on the same synaptic vesicle 2A that Keppra does, but it has a better affinity. And people who have failed Keppra sometimes find that Briviact actually helps better. So if you fail Keppra, doesn't mean that necessarily you won't respond to Briviact. So that's another advantage for Briviact, is that it does have the less side effect of irritability and mood changes, which we know Keppra does have. Xcopri is a carbamide derivative, which is also structurally related to previously developed drugs. It works on voltage-gated sodium channels and GABA receptors, but it does not work on, it's not a benzodiazepine. And it has, so far the data is pretty remarkable. And personally, I have seen, a few patients become seizure-free after starting Xcopri. So something definitely to consider in people who have refractory seizures. Epidiolex, which is cannabidiol, and it's approved for seizures associated with Dravet syndrome, Lennox-Gastaut, and tuberous sclerosis complex. But we can also, we use it also for other types of epilepsy, like focal epilepsy. And it is one of the active principles contained in the cannabis plant, but unlike the THC, it doesn't have the psychoactive effects. And in the way it works, we don't really know, but we think that it does have an independent anti-seizure activity. But if people are taking clobazam or amphi with that, it can increase the concentration of clobazam, and potentially that's the reason why it could be, we see an improvement in seizure control. Fenfluramine was introduced initially for seizures associated with Dravet syndrome, and it had a pretty nice seizure suppressing effect in that syndrome. But currently it's being also studied in Lennox-Gastaut. It's not approved for it yet, but the data is pretty promising for that as well. And I know in the past that it was actually a medication used for appetite suppression. And there were some concern about cardiovascular effects at the time, which is why it was taken off the market. But however, at the dose used for seizure protection and the studies, there were no evidence of significant cardiovascular toxicity. Everolimus or Afinitor is an inhibitor of the mTOR, and it's used for focal seizures associated with tuberous sclerosis complex. And it's also effective in reducing tumor growth in people who have TSC, and it also helps with seizure control. And it seems like the effect is gradual. So the longer they're on, the more they see a reduction in their seizures. We also have been seeing new medications over the past few years for rescue medications. Until 2018, the only medication that was available for out-of-hospital use was the diazepam rectal gel or Diastat. And in 2019, we've seen 2 additional medications coming in the market that are FDA approved. One is an intranasal midazolam or nazolam, which is approved for 12 years and older. So can be used for younger kids. So for the very young kids, we still have to use the Diastat, but for 12 years and older, we can start using these the nazolam, and it's been shown to be more effective than the Diastat actually, and it's easier to use as well. The other one that's on the market is Valtoco, which is an intranasal diazepam. This one is approved for 6 years of age, so can be used in younger patients. Again, the intranasal offers more rapid and direct absorption, so more rapid onset, and also it is easier to use, especially with the older kids when they're at school. They don't have to undress the child. It's just easier, quicker administration. And there are some medications that are not FDA approved yet, but that are under development is diazepam buccal film, which is compact, easily administered as well. It's placed inside the cheek. It rapidly dissolves, and it seems to be as effective as the rectal gel, the Diastat. The other one that's under development is the inhaled formulation of alprazolam, which delivers the drug deep into the lung. And it also, the studies have been shown that it strongly suppresses epileptiform activity within 2 minutes. So now I wanted to talk a bit about drug-resistant epilepsy, because as we talked about, despite the fact that a lot of new medication have come into the market over the past 30 years, still a third of patients with epilepsy have seizures refractory to pharmacotherapy. And we estimate that about 40% of people with epilepsy have drug-resistant epilepsy. And the mortality rate is 5 to 10 times higher than that of the general population, which is why it's important to identify. And the International League Against Epilepsy defines drug-resistant epilepsy as failure of adequate trials of 2 tolerated and appropriately chosen and used anti-seizure drug schedules, either at monotherapies or in combination, to achieve sustained seizure freedom. So I want you to keep that definition in mind for what we're going to talk about in a little bit. So there is a famous study by Brody that showed that 49.5% of enrolled patients remain seizure-free, meaning no seizures for at least a year on their first anti-seizure drug. But when you introduce a second medication, it drops down significantly to 13.3%, and after the third to 3.7%, fourth 1%, fifth 0.4%, and then you see as you go down the list, after 8 drugs, it goes to 0. So really, if you fail, if after 2 seizure medication you're still having seizures, the likelihood of becoming seizure-free on medication only becomes lower. And refractory epilepsy is associated with increased morbidity and mortality, psychosocial consequences, cognitive problems, and reduced quality of life. And that's because ongoing seizures can lead to cognitive issues, but also when you add more medications, the medication side effect of drowsiness can also affect quality of life. And also the medications that are used for epilepsy often cause mood changes, so more likelihood of developing that. restricted quality of life because patients cannot drive, they cannot, often hold the job that they want. So the factors that have been shown to be predictive of a poor prognosis is the initial response to pharmacotherapy. So if you do respond to the first medication you put on, it's a very good indicator that you're going to do well. Not that if you fail one, that it's necessarily that says you're going to develop drug-resistant epilepsy, but if you don't respond initially to the first medication, that can be a predictive of a poor prognosis. The underlying etiology as well. We found that the people who have symptomatic epilepsy with structural brain abnormality tend to be more resistant than people who have idiopathic or presumably genetic epilepsy. And also the patient history of seizure frequency prior to initiating treatment, sorry. So besides medications, we do for drug-resistant surgery is something that's very underutilized at this time, and neurostimulation or neuromodulation. I'm not going to talk in detail about this because Dr. Serrano is going to talk in detail about this after I'm done. Ketogenic diet is used in children with refractory epilepsy, and it does have sometimes a significant effect depending on the type of epilepsy they have, but it's not something that usually is used in adults because of the long-term adverse effect, and it's very hard to adhere to it. But sometimes we do recommend a modified Atkins diet. And lifestyle changes, obviously knowing what triggers your seizures. There are some people who have specific triggers, but common triggers are sleep deprivation, alcohol, and stress. So it is estimated that in the United States, less than 1% of patients with drug-resistant epilepsy are referred to an epilepsy center, which is a very astonishing number, because and it's very unclear why that is. But even though a study found that it takes on average 9 years to become drug-resistant, it doesn't really explain why there's such a significant delay. Sometimes the delay from onset of epilepsy can be 18 to 22 years, which is very, very late. And possible reasons why that is maybe there's not a good understanding of what is considered a drug-resistant epilepsy, which is why I ask you to really hold on to that definition I told you about earlier, because really if you fail 2 medications, really there's no you shouldn't be delayed to go see an epilepsy specialist or go to an epilepsy center where they have more available extensive testing to help identify what type of epilepsy you have, where your seizures are coming from, and to give you more options. I think a lot of time patients are worried about surgery, and they're reluctant to go to an epilepsy center, being afraid that they're going to do surgery for sure. Even if you don't necessarily want to do surgery right now, it's good to get to an epilepsy center to get the ball rolling in the future if you want to do surgery. And when we do a pre-surgical evaluation and we do all this testing, it doesn't necessarily mean that you will have surgery. We're just trying to identify if you're a candidate. And in the meantime, because that process takes a long time, we do continue to try different medications. And sometimes during that process, we're able to find a medication that works for our patients. And obviously, the ideal situation would be that we're able to control your seizures with medications without side effect. But when that's not possible, surgery could be a very good option. And there's so many different types available currently. It doesn't have to be an invasive surgery if you're not really willing to do that. And Dr. Serrano will also talk about neurostimulation, which is, like RNS, DBS, VNS, which are much less invasive. So future perspectives, in the recent year, we've seen an increase in application of technological tools, smartphones, helping us in lots of ways. It's sometimes hard for people to remind themselves of taking medication. So I know a lot of my patients, sometimes they have apps with reminders to take their medication, to record their seizures, so that when they come in, they have, they can tell me more precisely, you know, how often they've been having seizures. But also we've been seeing a lot of those smartwatches that try to record the seizures. And the reason why those can be helpful is a lot of time patients and their families, they come in and they're not able to quantify specifically how many seizures they've been having, because sometimes they are subtle or they're not always around them to notice the seizures. And that often, when they come to the office, it becomes difficult to decide what to do, whether to increase medications or not. And maybe we could be under treating. Maybe you're having seizures you're not aware of, and we're under treating you. And the opposite can happen too, where, you know, sometimes patients can report symptoms that, you know, seem possible as seizures, but they are not, and then maybe we are under treating. So now we have some devices that could, you know, be helpful, and some that have medical approval is the Empatica Embrace Watch, which was FDA approved in 2018 for adult and 2019 for children older than 6. It's a wrist-worn device, and it helps detect mostly generalized tonic-clonic seizures. And when one happens, it alerts through a smartphone app, the alert app, caregivers that you'll have designated. They will call the caregivers and let them know that you're having a seizure, so they can come to your assistant. And the system also records and stores data so that you can bring it to your doctor and, you know, to assess the amount of time that you have been having seizures. It's about $249, and it does require a monthly subscription, which the cost varies depending on the features you use and the number of caregivers you want to notify. And that's how the app looks like. It's pretty nice, and I have some patients who have it and really like it. The other one that's FDA approved is the Brain Sentinel SPAAC, which is a lightweight box that's attached to an adhesive pad, and then it's attached to the belly of the bicep muscle, and it records electromyography signals. And again, it's mainly used to detect generalized tonic-clonic seizures. And same thing, when their seizures happen, it sends an alarm to alert caregivers. The Night Watch is not FDA approved yet, but has some approval in the European Union. It's an armband with a lightweight box, and also it detects a change in heart rate and motion, so mainly for generalized tonic-clonic seizures. The EpiCare Free or EpiCare Mobile, it's not FDA approved yet, again, but it does have some medical approval in the European Union. Again, it's a small lightweight box, but it's attached to a wrist wrap, and it's intended to detect generalized tonic-clonic seizure based on motion patterns. Some devices that don't have medical approval yet, the AmFit, which is a thin sheet placed under the bed mattress, and it incorporates a transducer, and it measures repetitive motion of, again, mostly for people who have generalized tonic-clonic seizures. And then we have the EpiHunter, which is a single channel wearable EEG recording, and it's attached. It's a small amplifier in a lightweight box attached to a headband, and it's mostly for people with absence seizure, mainly used for kids to, as you know, people who have absence seizures, it's very hard to tell sometimes when they're happening because they're so quick and they don't have all their symptoms with it, and they come back to baseline right away after. So it would look like that image on the right with that little girl. And oops, sorry. And the med page is under the mattress microphone system, which intends to record the sound of seizure-related movement during the night. And then we have finally the smartwatch Inspire, which also is intended to detect repetitive motion for people who have generalized tonic-clonic seizures. So as you can tell, it's mostly for people who have this to detect tonic-clonic seizure, which is good, but we still need devices maybe that would be helpful in detecting more subtle focal impaired awareness seizures, which we don't really have right now. So one area where advances have been greatest is the genetics of epilepsy and discovery of gene mutations responsible for a large population of patients with developmental and epileptic encephalopathies. One example of precision therapy is the ketogenic diet we talked about earlier to control seizures associated with glucose transporter type 1 deficiency syndrome. And in this syndrome, when you do the ketogenic diet, it can significantly reduce seizures. Another example is the drug everolimus for the treatment of seizures associated with tuberous sclerosis complex. It's still in early days, but hopefully as years go by, we'll learn more about the different genetic mutations and the different diseases and find more effective treatment for these. Biomarker guided therapy is also a hot topic in epilepsy research right now. And it would be nice to identify biomarkers predictive of seizure recurrence. A lot of time, people come in with the first seizures. We don't know sometimes whether to start medications or not. I mean, we do have some algorithm to help us decide whether or not to start medication. But if we were to have biomarkers that could tell us whether you would likely develop epilepsy or not, that would help us in terms of whether decision to start or withhold anti-seizure medication therapy. It could also be used to improve diagnostic accuracy, predict seizure response to specific treatments. Sometimes patients come into my clinic saying, oh, I know this person who did very well on this medication, can I try it? And they try it, but they don't do as well. And it's unclear why some respond to some medications and some don't. So if you could have, if we could have a guide to know whether, a medication could work for you, we could that way know which medication you would respond to. And also drug effects. Some people have experienced side effects and some don't. So if we would be able to identify which drug specifically would give you the least side effect, that also would be great. And also assess the probability of seizure occurrence after treatment withdrawal. A lot of times, patients have been seizure-free for a long time, and they ask if they can wean off medications, and it's sometimes a very difficult decision. So if we could have, something to help us predict whether you're not going to develop seizures after you off medications, or whether you're a high likelihood of developing seizures after weaning you off medications, that also would be a great advancement. Also, there's new drugs that are, we're trying to find new drugs for treatment of epilepsy, but switching the paradigm a little bit, where instead of treating the seizure, which is really the medication is suppressing the seizure, but it's not really necessarily treating the disease of epilepsy itself. So I think right now we're trying to find medication that specifically will be anti-epileptogenic rather than anti-seizure. So such treatment could potentially be used to prevent epilepsy or to actually halt its progression. So those are the things that I wanted to talk about today. And I think I'm thinking we're going to do the questions after Dr. Serrano does his part, correct?
Correct.
Okay.
Perfect.
Okay, excellent. My name is Cesar Serrano. I am a pediatric neurosurgeon working at Beaumont Children's Hospital. And I will be reviewing about the role of surgery in patients with epilepsy, doing more emphasis in pediatric patients, which is my main practice at this point. Disclosure, I have no disclosure for this talk. What we will be talking first, we will be reviewing the concept that Dr. Baki already mentioned, drug-resistant epilepsy. We will also recognizing when the patient with epilepsy should be referred to an epilepsy surgery group or center. And then we will be reviewing the different tests that we use during the pre-surgical evaluation of those patients. And finally, the surgical options, the surgery that we have been doing for many years, and also the new options for surgical treatment. Well, epilepsy is a very common chronic neurological disorder. The prevalence of epilepsy worldwide has been reported 6 to 7 per 1,000 people. And the new cases or incidents is around 60 per 100,000 per year. It's more common in the extreme of lives, more common in kids during the first year of life, and also in adult patients older than 85 years of age. In this particular group of patients, the elderly population is more common due to the more frequent incidence of brain tumors, stroke, neurodegenerative disorders at that age, and that is exactly the reason why there is that peak at that age. It's a bimodal distribution. It's also more common in low-income countries and seems to be related because of the higher incidence of brain infections, also traumatic brain injury. In general, in terms of the prognosis of epilepsy, around 70% of the patients can be treated with medications, but there is always a group of patients that despite of medications, they don't have control of the seizure. It is 30% of patients. Actually, surgery could be an option for this group of patients when medications are not working. This is what already Dr. Baki mentioned, a publication in New England Journal of Medicine about the impact of anti-seizure medications in patients with new onset seizures. They had like is coming from UK, this study, more than 500 patients with new diagnosis of epilepsy. And they start first one medication for them, and they obtain a 47% of those patients had control of seizures with the first medication. The most important impact of medication is actually that point with the first one. Then they add a second medications for those patients who did not have control, and they obtain an additional 13% of control in seizures. But increasing more to 3 or 4 medications, the chances to have seizure control was relatively low. And this is all the entire group of patients that they don't have any control of seizures with medications. And this part is very important because we know that if the patient is already having 2 medications, adding more, the chances of improvement is pretty low. While there are some patients, not everybody, some patients with some particular type of epilepsy where surgery can obtain 70 to 80% of seizure control. This number, 70 to 80, is absolutely significantly better than adding more medication. That's exactly the reason why we think that surgery is an option for some patients. Then there was, after this paper, a group of experts of the International League Against Epilepsy, and they defined the concept of drug-resistant epilepsy. That is exactly what Dr. Baki already mentioned. that those patients who already have had 2 medications, the correct medications, the maximal doses, with no response to the treatment, they are considered patients with refractory epilepsy or drug-resistant epilepsy. At that point, once that patient is identified, really, that's the point that the patient really needs to be referred to an epilepsy surgery center, at least to have an evaluation to see if surgery could offer something for those patients. And this is a landmark paper for people involved in the treatment of epilepsy. Is the first randomized clinical trial comparing surgery versus medication for the treatment of temporal lobe epilepsy. And this is the study, actually was done in Canada. That's Dr. Weeb, the first author. And they have 2 groups of patients. One patient went for temporal, anterior temporal lobectomy, and the second group of patients only medication. 1 year after surgery, the surgical group obtained 58% of control of seizures, while with medications only 8%. That was an absolutely statistically significant difference that showed that patients with temporal lobe epilepsy, particularly mesial temporal sclerosis, surgery is a valid option that could be done also in safe manner. And this slide is mainly to show some differences between the epilepsy in adults and pediatric patients. Pediatric patients, they have some particular symptoms that we only see in kids, like the Lennox-Gastaut syndrome, Dravet. Those are very particular for pediatric patients. Something that is also different between adults and pediatrics is the semiology of seizures. In adults patients, the semiology, that means the manifestations during the seizure that the patient has, tend to be very stable, very similar always. And that is not always the case in pediatric patients. There are sometimes kids that they start as an infant having infantile spasms, that the initial evaluation of those patients can indicate that it's probably more like a generalized type of seizure of epilepsy. But years after, the semiology changes, and from the infantile spasm, they start to do more focal type of epilepsy. Sometimes those were patients with an initial focal cortical dysplasia that actually the semiology of the seizures change, and finally a focal type of epilepsy that amenable for surgical treatment can be identified. Pediatric patient is also more difficult, the interpretation of the brain MRI. And one of the reasons is the incomplete myelination in those patients. For this reason, makes sense in pediatric patients to repeat brain MRIs. The same patient that we were talking with the initial infantile spasm, at the beginning with an MRI in the first year of life, the lack of myelination does not allow to identify lesions. Later on, years after, we can start see focal cortical dysplasias that in the first MRI was not identified. That's why there is more need for repeating images in pediatric patients with epilepsy compared to adult patients. Also in kids, the age is sometimes a limiting factor during the preoperative workup. Some tests that we cannot perform in kids because they don't cooperate for those tests. Sometimes even in very, very young kids, a complete neuropsychology test cannot be done. Sometimes some particular type of surgeries like awake craniotomies It's so difficult to do in pediatric patients. Also, when they are very young, with not too much of verbal language, they don't tell us too much about the detail and how the seizures are. That's why age is also a limiting factor during that preoperative evaluation of the patients. There is another thing that we see only in pediatric patients, is that seizures can affect significantly the cognitive function of that brain that is in development. That doesn't happen in adults. That's why sometimes patients with a multiple seizure, they stop making progress in development. Even they have regression, because they actually can develop some type of mental retardation that we call epileptic encephalopathies. That's why seizures and epilepsy also have that part affecting kids that we don't have in adults. And that is another reason why early surgery really is in young patients, especially in the first 2 years of life, is very important to offer the best cognitive outcome of that patient as well. In adult patients, we mainly see, it's very common, temporal lobe epilepsy, mesial temporal sclerosis. There are other conditions, but those is the predominant. In kids, there is a more diverse type of etiology. There are many syndromes, many conditions that they are very particular of pediatric patients. Brain plasticity is other thing that is exclusive of pediatric patients. And actually the brain plasticity even protects the kid. And the kid, after surgical resections, because of the plasticity, has a higher chance to recover function. And that we don't see that, of course, in adult patients. Similar about differences in pediatric epilepsy, adult epilepsy. We talk about these conditions, more genetic metabolic disorders, ion channel mutations, autoimmune encephalitis. In pediatric patients, there are some conditions like the perinatal strokes, the Rasmussen encephalitis, tuberous sclerosis complex, Sturge-Weber disease. Those are unique for pediatric patients. In adult patients, the most common is mesial temporal sclerosis. And as I mentioned previously, brain tumors, stroke, infection, trauma, also immune-mediated pathologies. When we evaluate patients for epilepsy surgery, for us, the most important thing is trying to identify where the seizures are coming from. Exactly what we describe as the epileptogenic zone is the minimum amount of cortex that must be resected to give seizure freedom for the patient. This is the goal, trying to see if there is a focal epilepsy and trying to identify that epileptogenic zone and evaluate if that epileptogenic zone is functional. In that way, we know if resection can be done in a safe fashion. In general, the process of doing epilepsy surgery in patients first is identify that patient with drug-resistant epilepsy. At that point, the patient should be evaluated in an epilepsy surgery center. The main goal for us is trying to identify if we are facing an focal epilepsy, because it's the patient that has the higher chance of seizure control. Define the epileptogenic zone and evaluate if it's safe to remove. But for being able to do that, we need a big team. Is essential in epilepsy. It's not that one person is doing everything. Absolutely not. We need a team of neurologists with experience in epilepsy, or epileptologists, neurosurgeons, neuroradiologists, expert in images like MEG, or experts in nuclear medicine studies, neuropsychologists, nurse practitioners, social workers. It's a big team. And for the tests that we do in all of these patients, surface EEG, the video EEG, the high resolution MRI, and neuropsychology evaluation, those are always like the core, the base of the evaluation. Sometimes we have two other non-invasive studies like nuclear medicine, PET, SPECT, and also MEC is another option. But sometimes, despite of doing all of those investigations, we still cannot identify clearly the epileptogenic zone, and we have to do intracranial EEG. And is one of the situations where the surgeon participates in the management of these patients is when we have to do that intracranial EEG. I'm sorry, having problems to advance. Okay, let's see now. And we have been doing this for many years in North America with the use of grids and strips. Those are these cylastics things with many electrodes that they are placed on the top of the surface of the brain. That's the way that we have been doing for many years. But in this particular part, there is an important change doing now more the use of what we call depth electrodes of stereo EEG. For putting these big grids, we have to do a craniotomy. It's quite invasive, more uncomfortable for the patients, a higher risk of having problems like CSF leaks or infections, more pain after the surgery. Well, now what we are doing is to put these depth electrodes, and it's what we call the stereo EEG. Here, like a comparison in terms of that picture, what the grid does is to put the electrodes on the surface of the brain. Subdural grids are very, the good thing is that the cortical mapping is actually very good with subdural grids. But one of the things that the subdural grids have is limitation to evaluate deep parts of the brain. You can compare here on this image, the depth electrode going to the center, to the more medial part, deeper part of the temporal lobe. This one is an electrode actually in the hippocampus. And we can see here how we can now monitor deep part of the brain. That's why stereo EEG is a minimally invasive way that allows us to now evaluate parts of the brain that before the grids were not able to do it. There are two big types of surgeries. One is the curative surgeries or resective surgeries, and other type of surgeries for those patients who are not a candidate for a resective surgery is what we call palliative techniques. All of these palliative surgeries, what they look for is to reduce the frequency of seizure, not the cure of the patient. And in that group, we include the corpus callosotomy, and we include all the neuromodulation new techniques like the vagal nerve stimulator, the RNS or responsive neurostimulation, and the DBS or deep brain stimulation. Pretty much similar curative, we can resect that epileptogenic zone, doing resection of the area or lesionectomy, sometimes doing bigger resections like lobectomies. There are some series talking about seizure freedom of 75 to 80% in patients with mesial temporal sclerosis or temporal lobe epilepsy after having resection. There is also another curative procedure in pediatric patients that is the hemispherotomy. I will show some picture about that. And the palliative procedure, the corpus callosotomy, the open palliative procedure, and the new vagal nerve stimulation is actually not new, more RNS and DBS. Those are techniques for neuromodulation. Temporal lobe surgery, as I mentioned, is the most common epilepsy surgery for adults. This is particularly for adults. And very, very good rates, 75 to 80% of patients with MTS are seizure-free after surgery. Different techniques have been used this is from the paper of the randomized clinical trial of temporal lobe surgery, anterior temporal lobectomy. Also, some people have done a more selective resection and only taking off the amygdala and hippocampus, keeping more of the cortical or the neocortex of the temporal lobe. Laser ablation has also been used for ablation of the hippocampus. Radiosurgery has also been employed, but tends to be takes time, at least like 2 years, to have effects in terms of the seizure control. Beside of the temporal lobe surgeries and resections, we also do resections in other areas of the brain different to the temporal lobe. We call extratemporal lobe epilepsy, frontal resections, parietal, occipital resections. These surgeries in this part of the brain, they don't have as good results as the resection in the temporal lobe. Seizure freedom 50 to 60%. This is a surgery that is particular of pediatric neurosurgery and is the hemispherectomy. Is surgery with excellent results. It's kind of scary to see and talk about this, but the seizure control in pediatric patients with a particular type of hemispheric syndromes is 75 to 85%. Particularly in pediatric patients where seizures are coming from just one hemisphere. We call that hemispheric syndromes. We include kids with perinatal strokes, the Rasmussen encephalitis, the Sturge-Weber syndrome as well. The surgery has changed over time. Initially, we remove most of the brain. Is what we call an anatomical hemispherectomy. Then this technique was called the functional hemispherectomy with a reduction of the Rolandic cortex and the temporal lobe, but preserving the rest of the brain. That was actually developed by Rasmussen in Canada. And now what we actually do more than these other two surgeries is to do more disconnection of the brain, keeping most of the brain inside. It's more disconnection than resection, what we are doing now.
Dr. Serrano, I'm so sorry to have to do this, but we are out of time.
Okay.
I really want to thank both Dr. Baki and Dr. Serrano Almeida for an excellent presentation. Thank you all for joining this breakout session entitled Employment Strategies in a Changing Economy. We're very pleased to have as our panelists Allison Nichol, who is the Director of Legal Advocacy for the Epilepsy Foundation's National Office, Dr. Evan Tank, an epileptologist with the Spectrum Health Comprehensive Epilepsy Center, Jovan Bayne, who's a vocational rehab counselor at the Oak Park Office of Michigan Rehabilitation Services, and Adriza Cesar, who's a site manager for the Oak Park Office of Michigan Rehabilitation Services. So thank you all for your participation and for joining us this evening. So can each of you start by sharing a bit about your experience with this topic? Allison, do you want to get started?
Sure. First of all, thank you for having me, and I look forward to a thoughtful discussion about this very important subject. I am a lifetime disability rights lawyer. I actually tried the first case under the Americans with Disabilities Act in the early 90s, and then went to the Justice Department Civil Rights Division, where I spent, more than 20 years enforcing the ADA, helping to write and oversee the writing of the regulations and technical assistance. And then I retired out of the federal government at the beginning of the Trump administration and was privileged to join the Epilepsy Foundation, where I am the Director of Legal Advocacy, which means that I run the Gene A. Carpenter Legal Defense Fund.
Great. Well, thanks again for joining us. Dr. Tank.
Yeah, so I'm an adult epileptologist. I work strictly in a clinical setting. So I deal with this at a almost a daily basis in my patients who have concerns about employment. It's a very frequent topic of conversation in my office, so I have a bit of direct experience, at least from a physician's end, in navigating that.
Great. And Jovan.
Okay, I am a vocational rehabilitation counselor with Michigan Rehabilitation Services. In that role, I help people with disabilities to prepare for employment, obtain employment, and maintain employment. I've been working in this field for about 3 years now. And before that, as a social worker for about 8 years in the hospital setting and outpatient setting, helping those individuals obtain those resources needed or supports needed to maintain employment, helping them to get the supports they need to support themselves and their families. So this has been something that has really been a topic that I've been working with as a social worker for a long time, but more specifically in this field for the last 3 years.
Great. And Adriza.
Hi, good evening, everyone. My name is Adriza Cesar, and I am the site manager of the Oak Park, Michigan Rehabilitation Service. I am trained as a vocational rehabilitation counselor. I've been in the field for over 17 years, and I have serviced individuals with various disabilities, including epilepsy, many various physical disabilities, cognitive disabilities, mental disabilities. I've been trained as a rehabilitation counselor from Michigan State University. Go green, go white. And I'm excited to be here with you all to share in this discussion with everyone.
Great, great. So I'm going to approach this topic by discussing some of the most common barriers to employment for people with epilepsy and exploring some possible strategies for reducing or avoiding these barriers and successfully finding and maintaining employment. So let's start by talking about seizures as a barrier to employment. Dr. Tank, can you talk about how a person's seizure frequency and seizure types can impact either their ability to work or the type of work that they can do?
Yeah, absolutely. I guess to start off on a negative note and then build positively from there, we all realize that there are certain jobs and types of duties that are, I guess, more or less a non-starter if you have seizures. So things like a pilot, electrician, those sorts of things. However, the thing that I tell my patients is there are many jobs that people with epilepsy can do, even if they don't have well-controlled seizures. So office work, service industry, sometimes certain manufacturing jobs, a lot of different avenues, maybe not as many as people who have extremely well-controlled seizures or don't have epilepsy, but there are many different opportunities, I would say. One of the difficulties that my patients who, I guess do come from one of those potentially dangerous jobs, and I have to tell them that maybe that's something that they shouldn't be doing anymore. One of the challenges they face is, they're not sure what to do with that education, with that skill that they have, and if they really have to abandon all that training. There are a lot of different strategies that we use to work around that. For instance, I have a young man who is a maintenance worker at an apartment complex. This is his job. And I asked him, just about his daily duties and, what sorts of things might be a threat to him. He says sometimes he has to use reciprocating saws. Sometimes he has to use an electric screwdriver. And I talked to him about maybe if there were any other way to continue in that job by, changing some of those ways he does that work. And he says, yes, I could use a manual drywall saw instead of the reciprocating saw. I could use a manual screwdriver. So that's one way that we approach things is, can you do your same job in a more safe manner? Sometimes people working in industry where some of the jobs are perhaps a little bit dangerous if you're having seizures, and some are not. So we'll on occasion have really understanding employers and an opportunity to move to a different area in that same job. So if you're working on an assembly line where there's a lot of automated equipment around and so forth, I've had patients who say, yeah, that's what I do. There's this big metal thing that spins around and I don't understand what the job is, but it certainly sounds dangerous. They say, you know what, I can talk to my boss and see if I can move to the loading docks and pack our small boxes into larger boxes to go onto the truck, something that's removed from that danger. So sometimes just moving to a different area in the same place where you're working. I guess the primary difficulty, I think the primary determinant of how difficult it is just how frequent the seizures are. So people who have daily or multiple times weekly, they'll have seizures versus having seizures maybe just a couple times a year is at least a big difference in how understanding sometimes employers are and whether or not that's right. It's something we'll talk about later. But you know, in the immediate sense, people tend to get a much harder time if they're having more frequent seizures and need more time off work. And the seizures themselves are not always the biggest problem, as most people here know. Seizures sometimes are very brief and not necessarily an inherent disruption in and of themselves for a great period of time. But afterwards, of course, patients will have sometimes prolonged post-ictal symptoms. They'll be very sleepy or confused, lethargic afterwards. And you know, if that's happening 2 or 3 work days out of a week, that's a big problem for people. So seizure frequency is a big problem, and seizure types, as you alluded to, Russ, are also a major determinant of how difficult it is going to be to find and sustain employment. So people who have focal aware seizures, which we call auras, where they're not actually losing consciousness. Certainly those things are unpleasant, but if you're able to maintain awareness throughout your seizure, it is much less likely to be a significant disruptor versus if you're having a focal impaired awareness seizure, what we call a complex partial seizure, and you're actually losing awareness and you're much more likely to have those post-ictal symptoms as well. So seizure type is certainly something that plays a large role. And people with generalized epilepsies, you know, if you have occasional absence seizures, with absence seizures, you very rarely have a post-ictal state. The seizure itself may only be several seconds long. So that's, as long as it's not something that's happening numerous times throughout the day, that's often not as big a barrier. A similar thing is true with myoclonic seizures. But if you're having, you know, generalized tonic-clonic seizures, that's a big problem. So seizure types are important, and many patients with epilepsy will have multiple different seizure types, and some types maybe are controlled well and some types are not controlled as well. And if I, as your physician or whomever you see, is able to really do what we can to minimize the more dangerous or more disruptive ones, that's a meaningful goal, because it allows not just employment, but other, you know, activities that are just important and integral to daily life. So those are I guess a lot of the things that I have to talk about to people on a daily basis when we talk about employment.
Great. Well, thank you for that. Would agree on all those points. So Allison, can you talk about the direct threat and undue burden clauses of the Americans with Disabilities Act, and how these may be invoked by employers in relation to seizures? And then lastly, how thoughtful accommodations and neurologist letters can help to nullify those arguments.
Sure, absolutely. First of all, I would just say that Dr. Tank just, you know, very nicely demonstrated the hallmark principle of the Americans with Disabilities Act, particularly the employment provisions, which is that every person with epilepsy is a person of one. Their medical care is individualized. How epilepsy affects them, also very individualized. Their type of seizure, very individualized. And one of the great things that the ADA brought to us was the notion of an individualized assessment, that you could not make a decision merely backed on, with a few tiny exceptions, which I'll talk about in a minute, but you couldn't have these broad standards of no people with epilepsy need apply, or that we would never hire someone with epilepsy, kind of built on this myths, fears, and stereotypes about epilepsy itself, and the idea that it's somehow a monolith and the same among all. So I thought that was really nicely done. There are some jobs, as Dr. Tank noted, and I will also, where they are so safety sensitive that it may, in fact, be a direct threat to hire the person. Direct threat under the federal law, and for those who don't know, the Americans with Disabilities Act is the primary federal civil rights law that protects people with disabilities, which includes people with epilepsy. Even if you're seizure-free, you're still protected by the law from discrimination across the board, including in employment. If you're a federal employee, you're governed by something called the Rehabilitation Act, but the principles under each are the same. So there is a defense that employers can employ. There are actually a couple of first being undue burden, and the second, as you said, being direct threat. So direct threat, as it's set out in the statute, is a very high burden. It requires, as I just discussed, a specific individualized assessment of that person's epilepsy, of their seizures, of their current medical situation, in order for an employer to be able to successfully say, I cannot hire you because you're a direct threat, or I have to let you go because you're a direct threat. And so that's a defense that can be invoked. Sometimes firefighters, police officers, people carry firearms, maybe EMTs. You know, there are some people with some forms of epilepsy for whom those jobs are probably going to be unavailable. Over-the-road truck driver is another. Interstate truck driver, not so much. But the federal standards are pretty draconian when it comes to epilepsy. And that's a more kind of across the board standard. The other is what's called an undue burden. There are a couple of different kinds. The first is financial. That's almost never invoked under the ADA because most reasonable accommodations are very minor, and it's really not a question of spending money. As Dr. Tank said, you know, one of the things you want to look at is if I suddenly become, my seizures after 20 years become active again, and I work as a heavy equipment operator, can you reassign me to a different job successfully? So that does not, the question there is, does that disrupt the business? And in most cases, it does not. So for most people in most jobs, I think the direct threat analysis really doesn't come into play, but it is there for employers, as it should be, because there are going to be some jobs where it's going to be very problematic for a danger to the person themselves or to their co-workers. So the only thing, and I'll just close out with this, even if you can't accommodate someone in their current job and make that job less unsafe, like putting a cover on something or a number of other kind of ways in which you can make that work, you do have a duty to reassign that person. Reassign that person to another job that's open, vacant. You first look for a job that's as close in salary and title to the one the person already has. And only if you can't find something like that the person can do safely, are you allowed to kind of drop down a rank or two and find something else. So I think that's probably a good stopping point for me.
Okay, great. And we can certainly talk about, I'm sure, the idea of specific types of accommodations that might be used will come up throughout this conversation. So Jovan and Adriza, in some cases, epilepsy can be diagnosed in someone who's been in the workforce for a while, as we've kind of discussed, and it necessitates a transition to a different type of work. Like if you're a roofer or a truck driver, for example, who's diagnosed with epilepsy. So what are some of the vocational services available through Michigan Rehabilitation Services that can help with this type of transition?
I can take that. So just as Allison mentioned and Dr. Tank mentioned, it's really individualized. It depends on that person, what those services might be. But just to really try to understand the individual MRS, we work with a 6-step process that starts with the application. Even from there is a vocational needs assessment that begins right then. In the application and intake, we start learning more about the individual, asking them what their experience is with their disability, how has it impacted their lives, how has it impacted employment, and then from there, determining eligibility, gathering that information, whether it is from not only from the individual, but from their physicians, from any specialists, any assessments that we may have to ask the individual to obtain, like a physical capacity assessment or a vocational and psychological assessment, to gather that information to determine their eligibility for services. Even having them do a trial work assessment, that could be included in that. But once determined to be eligible for those services, we start exploring the jobs together, identifying what the local job market looks like and work conditions that might be a good fit for them with that information that we've obtained that matches their unique characteristics. So we take that information to identify a job goal and develop a plan that includes the job goal and the services needed to achieve that job goal. So that those services really vary depending on the individual, but it could include some additional training, whether it's on the job training or going to school for training, any kind of accommodation services they might need, or assistive technology, job placement assistance, or retention services to help them maintain employment. But once we have that in the plan and that plan is developed, the next step is actually working with the person, continuing that partnership to make sure that they're obtaining the services, they are benefiting from the services, and working the plan together so that they obtain employment and maintain it for at least 90 days. We continue with that individual to make sure that they have addressed their vocational needs, and making sure along the way, did we identify any vocational needs that maybe we didn't know at the beginning, but not until they started working on the job. So we do all of that before successfully closing their case. And even after their case is closed, if they need additional services like retention services or job coaching assistance, we connect them with our community partners to provide those services. So in a nutshell, I mean, it's hard to say exactly what that individual would need, but that every case is individualized, and each service that we provide has to support that job goal.
Great. Adriza, did you have anything to add to that?
Oh, Jovan said it great. It is very individualized, and it's all about putting a plan in place. And I'm glad that Allison talked about the ADA and reasonable accommodations, and Dr. Tank gave some background into different types of seizures and what types of accommodations or work would be best for them based on the type of their seizure. So you all did a great job with the first section, because Jovan really wrapped it up as far as the vocational piece of it.
Okay, great. So Dr. Tank, beyond seizures, what are some of the most common symptoms, side effects, and associated conditions that can act as barriers to employment for people with epilepsy? And what are some examples of either medical interventions or accommodations that can help to address some of those barriers?
Yeah, that's often just as much of a challenge as the seizures themselves. I guess to break it down into different components, medication side effects, particularly with anti-seizure medications, can be significant in a lot of people. A number of patients I've had have told me that they have difficulty at work because of, for instance, drowsiness, dizziness, blurred vision, sometimes even mood-related symptoms as side effects of medication. The most elegant solution that we always look for is trying to fine-tune the medications and find a way to either dose them differently or do some kind of extended release medication, or maybe try some other sort of medication to minimize those side effects. Maybe can't always eliminate them, but to make them as insignificant as possible, so people are able to function as well as they need to at work. And oftentimes we have some success with that. I have a patient who has generalized epilepsy and also really bad migraine. She works in a factory, and she kept coming in to tell me, my seizures are fine, my headaches are okay, but I can't think on this medication. She was on topiramate, and cognitive side effects are a very common side effect of that medication. So with some adjustment to that medication, we were able to still control her seizures, get her onto something a little bit more headache specific to help with the headaches, and the cognitive symptoms eased up, and her work life got a lot better. So sometimes it's just a matter of making adjustments like that to take care of the side effects part of it. Beyond the side effects, there are also other related things that go along with epilepsy. So epilepsy is just not seizures alone. There are other symptoms as well that are very common, and psychiatric symptoms are a well-known part of epilepsy. So for instance, more than a quarter of patients with epilepsy have depression. Sometimes it's very severe depression. Some people have very debilitating anxiety or other psychiatric symptoms. And again, sometimes that is exacerbated, worsened by some of our seizure medications. So some adjustment there can sometimes help. And sometimes there are always medical treatments we can try to treat depression, anxiety, other psychiatric symptoms. And we sometimes have good success with that. And then there are non-medical treatments, counseling and meditation and mindfulness and exercise and things that have been proven to help with some of the more psychological components of epilepsy and get people feeling better so they can function better. Talked about cognitive problems, memory problems are not just medication side effects. Sometimes they're part of epilepsy itself. That part is harder to treat. What is helpful though is something like a vocational assessment or neuropsychological testing. And for those who don't know, neuropsychological testing involves seeing a specialized psychologist and doing fairly extensive memory and cognitive testing, with the idea that everybody has different parts of cognition, parts of memory that they're better at and some that they're worse at. And this type of testing really tries hard to individually look at those things so you can see what sort of things you have difficulty with, what sort of things you're better at. And that can help you, realize different fields where you may be more successful than others. There's a young lady I helped to take care of who was training to be a graphic designer, and she had neuropsychological testing, and the neuropsychological testing revealed that she had really bad visual, spatial, perceptual difficulties. And I think that meant something to her to recognize that and see that maybe that was going to be a problem for her. She ended up changing course and is pursuing a career in the medical field. So there are different ways that we can manage some of these side effects, and there are different ways that we can say, hey, we maybe need some strategies to compensate for some difficulties here, or maybe try something different. So there are a few different fronts that we can attack all those other components of epilepsy that make working difficult sometimes.
Great examples. And Allison, do you have any examples of particular accommodations or other strategies to deal with some of these other barriers, epilepsy-related barriers to employment?
Yes, absolutely. And that was those are great examples from Dr. Tank. I have to say that, I talk to people every day on our helpline, and this is really the number one question: employment. Either getting employment, but more often than that, maintaining employment. So, I think the number one issue is that there's just a lack of knowledge on the part of hiring managers. There's a lack of knowledge on the part of supervisors and coworkers about epilepsy. And so what normally happens is someone has their first seizure in the workplace, and everybody freaks out and puts a person in an ambulance. And then a couple of days later, they're terminated. Without much assessment at all about what happened. And so I really encourage people to go, if they have concerns about having a seizure in the workplace and their safety. I advise people to use the reasonable accommodation process for that. You have no duty to disclose your epilepsy during the hiring process, or frankly, while you're working, unless there's something happens. But if you have those concerns, one of the ways you can deal with that is to have a seizure action plan and use the reasonable accommodation for that process. One of the things that happens to people in the workplace when they have their first seizure is employers want to send them by ambulance every time they have a seizure. And most people don't need that. They need a quiet place and some time, some amount of time to recover. And those ambulances over time can really add up. They're very expensive. They're generally not covered by insurance. So that's one reasonable accommodation I see that people should think about. But in terms of doing, 90% of jobs, I mean, I think we just saw, I've been fighting for people with disabilities, including epilepsy, to be able to work from home, for 30 years. And for 30 years, employers have said, oh, we can't have anybody work from home. That's the craziest thing I ever heard. And then we all woke up and everybody who could on Tuesday was working from home without much fanfare at all. So I think circumstances have shown all of us that maybe a little thinking a little more thoughtfully. I always say that the thinking is cheap, and we should do that first. And I think that's true for all accommodations. I see people for whom obviously some people can't work the night shift. Most people want a steady shift. They don't want to have to work all 3 shifts in rotation. I think that's a common reasonable accommodation. If you're changing medications, you may need a later start time or more frequent breaks at work than other people get. I also think that's a reasonable accommodation. The kind of effects of epilepsy and medications that Dr. Tank was talking about that involve memory and cognition. I mean, some of the reasonable accommodations, are we being invaded from Mars? One of the reasonable accommodations we can ask for people is, wow, now I've lost my train of thought. One of the reasonable accommodations we can ask for, is, I got off track. What was I just saying?
We were talking about some of the other effects of epilepsy besides.
Oh, okay. Thank you very much. Exactly. So people with memory problems, one of the things is you can ask, well, you can't ask to change your supervisor. You can ask for a change in the method in which you are being supervised. So maybe you need things in writing more often. Maybe you need to be told things more often if you're having those kind of memory problems. There's also a great organization called the Job Accommodation Network. And we'll put that, you'll get that link. The Job Accommodation Network is a great place to go to kind of get ideas about how to do this. There are many mnemonic devices, reminder devices technology has brought to all people with disabilities, incredible things that will help with all of the kinds of things that Dr. Tank was just discussing that are either a byproduct of the epilepsy or of the of the medications or medication shifts. So those are all the kinds of things that I see. I will just say one thing: if you work in a union shop, that might be problematic. If, for instance, you want to change and shift and you're in a union shop, that can impact your ability to get that as a reasonable accommodation. But most of the people I talk to and walk through with Jan, they easily can be accommodated in the workplace. It's just the employer needs to get on board with retaining people and understanding that they actually have this obligation under the ADA. You can't just terminate someone for having a seizure in the workplace. Can't do it. It's illegal.
Right. And are there specific vocational rehab services that can help with some of these barriers, Adriza and Jovan?
Well, there are. MRS could actually assist with obtaining the psychological evaluation, that neuropsychological evaluation that Dr. Tank was talking about. That also could include a vocational test battery to help identify any needs or any specific services or accommodations that would help the individual to perform their job function, or help them with the training, help them identify, as Allison was saying, specific ways of maybe training the person, assisting the person in the workplace, and also maybe a physical capacity assessment, job coaching, job retention services, specific job development services, with an employment specialist, or even a referral to a community specialist or agency that might help the individual to identify those strategies and tools to address particular barriers and be successful. So we might refer them to our business network division. In that division, we have specialists who will go out to the work site and perform work site evaluations to see what the workplace looks like and how that might be better, or how we can make it better for the individual, removing those barriers or at least reducing those barriers so that they can be more successful in the workplace, even if it's working from home, doing a home assessment to see what things, what accommodations could be there, or equipment or assistive technology could assist the person in performing their job functions. So, and then also I think I mentioned the long-term services too. So if they needed that someone to continually check in for retention services to make sure they're doing the job well. If they run into any other encounters that maybe weren't there in the beginning, or things change with the job function, or what the employer is asking of them, that there's someone always there to identify those barriers, we can set them up with our community partners for those long-term supports that they might need.
Great. Adriza, you had something to add?
Yes, I just wanted to piggyback off of what Allison said. Allison, I was reading your mind, because as you were talking about accommodations, I immediately placed in the chat askjan.org. And then if you live here in the local Great Lakes area, the Great Lakes ADA is another great resource for accommodation. So I was right there with you, Allison, as far as accommodations and whatnot, because that's a great site. And we always refer individuals to the Ask Jan. And you have to, and this is in Jovan's question as well, as far as what other resources and accommodations can help people. We have to get back away from that archaic thinking of individuals with epilepsy should not work, or if you see someone with epilepsy, you should treat them this particular way or call the ambulance immediately. It's really educating that employer, and that's why we work with our partner business network division, so that we can educate them, the employers, the them I'm referring to, and their employers. And we do disability awareness training. Jovan talked about all of this to help that individual, and we give them the key information on disclosure. Disclosure is very important, and when to disclose, if they feel comfortable disclosing. It's all part of the process when they're working with a voc rehab counselor such as Jovan. So I just definitely wanted to piggyback off of what Allison said about the askjan.org, and Jovan mentioning about the accommodations and the long-term support we can assist individuals with.
And if I could just add too, that was great. And I'm a big fan of Great Lakes as well. Great folks up there. Just want to add a couple of other resources if I could for just a second. We have the Epilepsy Foundation now have put out 3 videos just related to employment. We got a grant from the Robert Wood Johnson Foundation, and they're very short. They're a couple of minutes apiece, but one of them will lead you through the reasonable accommodation process and will encapsulate a lot of the ideas that we just shared here. So that's one thing. The other is when you go through the accommodation process, you go to your employer, your foreman, your supervisor, you have to request the accommodation, and they're going to turn around and they're going to ask you for some documentation to support the fact that you have epilepsy and how that is affecting your ability to do the job, and why the accommodation is the right one for you. And so we have a written technical assistance document, and again, we'll give you the links. And it's actually a document that I developed, and you would hand it to Dr. Tank, because most doctors are not anywhere near as knowledgeable about this stuff as he is. I will tell you that. And it explains actually to the doctor what kind of documentation you need in support of your reasonable accommodation request. And so for people who are brand new to this process, it's based on what the EOC recommends. I just wanted to get it out there in the world. I think it can be enormously helpful, because I think people, they kind of really struggle with that. Well, what does that mean? So I just wanted to make sure people had those TA documents.
Great. Yeah, and Andrea just posted those in the chat room, so that's a great resource for people. So Allison, this could be a whole session in itself, but another common barrier to employment is stigma, misunderstanding, and discrimination by employers. And can you talk a little bit about the different points in the employment process where discrimination can occur, some of the employer concerns and misconceptions that lead to discrimination, and then what people with epilepsy can do to prevent or respond to suspected discrimination?
Sure, absolutely. And, it's a great question. I will say that I think people need to understand that, stigma kills people. Discrimination kills people. It gives them worse health outcomes. It gives us worse community health outcomes, right? A 55-year-old man who loses his job of 25 years is going to be devastated, and because of the way we do our insurance in this country, for the most part, even with the ACA, people get their insurance at work. So imagine being that guy. That's the guy I talk to every day, and it's devastating to him, and that affects their mental health and it affects your physical health. And so it's something we all have to join together to work on collectively, because it's a collective bad thing for all of us, and it could be a collective good if we could prevent this from happening. There are really 3 phases to the employment process, and the ADA gave us one of the great gifts of the ADA is this. Historically, people with epilepsy were not hired into jobs because they had to disclose. When I was growing up, my generation was growing up, you actually filled out a paper application, and you had to put down all your medical conditions, any medications you were taking, your age, your gender, are you pregnant? And so we've worked our way through a lot of these civil rights issues. When you are interviewing for a job, when you are applying for a job, where you're in that stage, where there's been no offer yet extended and no hiring decision made, you do not have to disclose your epilepsy. You can't be asked about it. You can't be asked about your medications. You can't be asked if you took excessive leave time. You can't ask if you've ever filed a workers' compensation complaint, or anything that might lead to the fact that you are a person with epilepsy being revealed. And I know people have concerns about taking a job and then having a seizure. And I think I spoke earlier, and I won't go through it again, but let's leave that for after you've got the job. Let's get the job first, right? Let's be judged on our merits, on our resume, on whether we can do the job, and leave aside disclosure for later through the reasonable accommodation process. So that's the first, and then that's just sort of inviolate. For jobs for which you have to take a medical examination, firefighter, there aren't that many. Firefighter, police officer, EMT, maybe some others. During that process, obviously, they can ask you about your medical conditions, because that's the whole point of what they're doing. What they can't do, so you would have to disclose you have epilepsy during that period of time. But what they can't do is then pull the job offer, unless they can demonstrate that because of that epilepsy, you're no longer qualified to do the job. So that's one place where they can ask you. So then let's say you don't have to go through that process. They make you an offer and you get hired, and then so now you're on board. All right. So can they ask you about your epilepsy? Absolutely not. They absolutely cannot ask you about your epilepsy except in 2 situations. Obviously, if you come forward and you need a reasonable accommodation, you have to disclose that you have epilepsy or a neurological condition. I think they probably have a right to know that it's epilepsy, and why you need the change or the accommodation. Okay, so that's one. And for most people, that's really the only one that ever happens. For most people, even that doesn't happen, right? They never have to disclose because they don't need a reasonable accommodation. But it could be that somebody has an accident on the job related to the fact that they had a seizure. And so that then becomes known to the employer. And then the question arises, of course, is this a safety issue? is your ability to do your job somehow in peril. And that's another situation where you could be asked to take an examination of some kind, or be in some conversation where you might have to disclose that you have epilepsy. But those are two very, very small categories. Employers, as a general, cannot ask you. Is one of the great things that the anonymity is one of the great things the ADA brought to all people with disabilities. And that's why it's not so much the front end anymore of getting employment that is plaguing people with epilepsy. It's the maintaining part where something happens on the job, right? That doesn't answer the more personal question of, do you want to disclose? There's a lot of value in being out and being your authentic self. I hear this a lot, especially from younger folks. And I understand that. That's a personal decision. That's not for me to decide. I will tell you, I think we live in a culture where, oh, everybody at work is a family and we all love each other. And I can't begin to tell you how quickly that falls apart when someone has a seizure and people don't like it. When someone gets a promotion, somebody else expected to get, or anything else. So I think you have to be very careful and very circumspect about that. But again, it's not my decision. I can only tell you that the law does not require you to disclose.
And just briefly, can you talk a little bit about instances where discrimination is suspected, just about the process of filing an EEOC charge?
Oh, sure, absolutely. And we actually, one of the 3 videos that we did for the grant is that very question. Well, I think I got fired, and I think it's because I have epilepsy. What do I do? Every state has a kind of a state equivalent to the EEOC. The Equal Employment Opportunity Commission, for those who don't know, is a federal agency, and their job is to investigate and process complaints of discrimination under all the federal civil rights laws, including the ADA. Now, if you're a federal employee, you go through a slightly different process, and that's an internal process. So what you want to do is you want to go as quickly as you can after you've been discharged, and talk to your internal people about the agency process. Everybody else would go through to the Equal Employment Opportunity Commission. EEOC.gov is their website. You can go on their website. In the upper right hand, you'll find a search box. Type in file a complaint. They have both local and regional offices all over the country, in every state. And so you will get on their calendar. First of all, it'll tell you which office you should be going to based on where it happened. It's where it happened, not where you live. So if you live in Illinois, but you worked in Indiana, you want to go to the Indiana office to file the complaint. So you will file a complaint. You will first get an appointment. Right now, I think they're still fully working from home, so you won't even have to go to the office. An investigator will call you, will take your information over the phone, and will gather any documents you have that your employer has given you. If you've been, for instance, negotiating a reasonable accommodation over time and there are emails back and forth, you want to save all that stuff. Not something that you shouldn't take away, but things that have come to you that are okay to give to EEOC. They will then take that charge, and within 10 days of the day it's finished, they will send it to the employer. And then, of course, your employer has a right to file a response, but EEOC will then conduct this kind of broad investigation. They'll talk to you, they'll interview other people you think should be talked about. It should be talked to who maybe witnessed whatever happened, and people that were involved in the accommodation process on the employer side, and then they'll reach a finding. And they can find either that they find cause to believe that it was what happened to you is a violation of the ADA, or they may find that there is an insufficient amount of evidence, in which case you receive a letter saying, you still retain the right to file in federal court, and you will have a very short period of time to do that. So as you're going through the EEOC process, I tell people try to get a feel as you're going along about which way you think this is going to go. Because if they hand you a letter at the end that says, okay, now you have 90 days to get to federal court, that's really hard for people, right? They don't have lawyers. Getting a lawyer in that amount of time and knowing enough about the case, giving you an opinion, that all takes time. So try and engage as you're going along. You have either 180 days or 300 days from the date that you know about the discrimination in order to file with the EOC. So there are time limits. There also will be a state agency if you prefer to go that route. They have a work sharing agreement with the EOC. You may be able to file there. There's also going to be a time limit, excuse me, for that. This process can take a very, very long time. I mean, it is taking people 4 or 5 months now just to get an appointment with an investigator. That's how overwhelmed the system is and how understaffed the EOC is. So I don't want to discourage you. You have an absolute right to do it, but you have to prepare yourself for a long process.
Right. Okay. So a couple, Jovan and Adriza, if you could just briefly talk about a couple of transition points. One, when young people who are transitioning from high school and entering into the workforce, what are some services that can help with that transition? And then also people who have been on Social Security disability benefits for a long time and then want to rejoin the workforce after being on disability for a long time. What are some services that you're aware of that can assist with those transitions?
Okay, well, we start start that conversation of planning for employment with individuals as young as 14 years old. So for students and young adults entering the workforce, MRS provides, school-based services starting in the 9th grade called pre-employment transition services. So there's 5 pillars of those services. There's job exploration, activities, work-based learning experiences, counseling on post-secondary education programs, workplace readiness activities, and self-advocacy and peer mentoring activities. All of those activities are geared toward transitioning successfully to the workplace, into the workplace. They might include some social skills training, summer work-based learning experiences. It could be job shadows, work site tours, community-based work assessments. We also have, we provide training at MCTI, which is Michigan Career and Technical Institute. And that is the 2nd largest comprehensive rehabilitation training center in the US. It offers 13 different training programs, such as culinary arts, graphic communications, information technology, the list goes on. But to keep it brief, it offers all of these blend of support services, highly individualized to those that particular student's needs to make sure that they're successful in the training program. We also consider any information that's provided by the schools from their IEP, their individualized education program or 504 plans to make sure that we are providing the services that they need to be successful or identifying a job goal that will be a good fit for them. For someone who has Social Security or has applied for it or has been out of the workforce returning to employment, we offer benefits counseling, individualized benefits counseling, and they speak with a counselor who is certified and trained in that area to help them understand the impact of employment on their Social Security benefits, and also any programs that they might qualify for while they're working to help them, and how long those programs last, so that they know exactly what they need to be earning or how many hours to work, so they can be working with a vocational rehabilitation counselor and that counselor as well.
Okay, great. Lastly, just wanted to talk about, there's been so many short-term and long-term changes in our economy. And that's provided some new barriers and new opportunities for people with epilepsy seeking employment. And that can include automation, reductions in manual labor and manufacturing jobs, increased demand for technical, social, and analytical skills, increased opportunity for remote work stemming from the pandemic, as we referenced earlier. And most recently, we've seen labor shortages and demands from workers for living wages and benefits. So does anyone have any thoughts as to how this changing economy, how you think it will impact people with epilepsy that they want to share?
I think Allison kind of touched on it earlier about, getting the job first and finding out what that person can do, rethinking the way the work environment looks. People can work differently. And this is what, this changing economy has shown us, especially with the pandemic. It's helped us to understand that now the employers and the candidates for employment are able to redefine what that work environment looks like, whether it is working remotely, having a hybrid work schedule, or just more flexibility with their work schedule, or those accommodations, and how to have those conversations of what is needed to really perform that job. But this is a prime opportunity to, to continue that conversation and keep it going and redefining what that means.
Okay.
And then also, I would like to add, thank you, Jovan. I would like to add, being here in the state of Michigan, the governor has an initiative, 60 by 30. And part of that 60 by 30 is to get the workforce, reimagine the workforce and make it a more modern workforce, and to solve the future challenges. And the goal is to increase the number of working age adults with the skill certificate or college degree from 49% to 60% by 2030. It's really about closing the skills gap. And where does Michigan Rehab Service come in? Many people think of us as just jobs, but Michigan Rehab Services, we're in the Office of Employment and Training. So we do work with many individuals, as Jovan mentioned earlier, in preparing for employment. And then also Oakland has another ambitious initiative, and that's 80% of the Oakland Michiganders will have post-secondary certificate training by 2030. So there are many opportunities available for individuals with disabilities to advance in their training.
Great. And just given the time, and since we do have our next session coming up, we do have to wrap it up now. So, and if people do have questions, please do email those to us. We can absolutely answer those questions ourselves, or forward them to our panelists and get responses. So just unfortunately not enough time in these sessions to cover everything that we wanted to cover. So thank you to all of our panelists for an excellent discussion on employment. And as we mentioned, we could talk for hours about this. It's such a complex topic. So
all right, we will get started. Everyone, welcome to this session, Psychological Trauma as a Cause and Consequence of Seizures. We're so grateful to be here. This topic is so important. And today we're very grateful. It is sponsored by Michigan Medicine. So we thank Michigan Medicine for sponsoring this really important topic. My name is Renee Roederer. I am the support specialist for the Epilepsy Foundation of Michigan. And for this session, we are pleased to have as our panelists, Dr. Scott Winder, psychiatrist from Michigan Medicine, Dr. Nicholas Beimer, epileptologist from Michigan Medicine, and Sabrina Banks, a person who we'll get to know who has non-epileptic seizures. We want to thank all of you for joining tonight too, and we know that this topic is going to be very relevant in a variety of ways. So please, as you feel comfortable, let us know how this is connecting with you in the chat throughout our time together. So thank you for being here. And, once more, I just want to say a little bit more about what a joy it is to have our presenters tonight. I'd like to welcome Sabrina Banks. She's a motivational speaker. She lives with psychogenic non-epileptic seizures. And as I've mentioned already, Dr. Nicholas Beimer is an epileptologist at Michigan Medicine. Dr. Scott Winder is a psychiatrist from Michigan Medicine. And I'm going to be having a dual hat today. I'm going to be moderating this session as the support specialist for the Epilepsy Foundation, but also offer some of my own experiences as someone who has lived with both epilepsy and complex PTSD. So I'm really glad to welcome all of you here. And to begin, I would like to invite all our panelists to introduce themselves briefly. When you tell us a bit about what makes this topic so important to you personally. Sabrina, I'm wondering if we could start with you. You just unmute yourself.
Yeah, I thought you'd never ask. No, just kidding. This topic, of course, is very important to me because, I battle with these seizures quite often. And when I say quite often, they've decreased to monthly now. And this has been something I've been wanting to be the voice for years with, with the hospitals, with people who have witnessed these kind of seizures, as well as people with epilepsy. So I am just beyond grateful. I don't know if you guys could tell, but I've been smiling nonstop since everything started. So yeah.
I'm so honored to have you. Thank you. And Dr. Beimer, what makes this topic so important to you personally?
Yeah, thanks, Renee, for inviting me too. I think for me, I identify as just a human being first, is what I would say. I was raised in a household where I was sort of taught to care about other people. That's probably why I became a doctor, but I found this along the way, to be honest. In training as a neurologist, I thought that we didn't do very good at, the care of people living with PNES, and I wanted to change that. And so that's kind of part of why I do what I do. And so I'm grateful to be able to help at least be a small part of that too.
I'm so glad to hear that. Thank you. And Dr. Winder, how about you?
Thanks for having us, Renee. And it's a pleasure to be next to Sabrina and Nick here. Like Nick, that's what brought me to medicine, was just a desire to take care of people. And I don't think there was a group of people during my training who affected me more than people who would have these serious and incapacitating physical symptoms, and yet who the origins were psychological. So it was very interesting and fascinating as a young student and clinician and doctor to think about that. But then, like Nick, I was just really disappointed at how poorly we took care of them. And it was in conversations with Nick when we were both fellows that we got the idea to try and do something different at Michigan to take better care of people. So we're moved and inspired by people like Sabrina every week that we get to see patients like this. So it's such a pleasure to be here with you all.
Thank you for that. I'm so glad that the two of you are working together on this, and that we're all working together on this too. And this topic is very important to me, and I wouldn't be at the Epilepsy Foundation had these themes not been a part of my life. I too am a trauma survivor, and I grew up with epilepsy and had a pretty traumatic experience of it that also developed into PTSD. And I can certainly speak to those experiences as well. Well, I really appreciate the title for this session because I think it names a lot in a really short amount of words. Experiences of trauma can cause seizures, and experiences of seizures can cause trauma. So that is absolutely true. And I want to talk about both aspects of this title tonight. And of course, we remember that this is always more than a title. These are lived experiences. And in the midst of that too, I would say to everyone present to pay attention to the needs of your own bodies during this discussion, because we know this can even bring up difficult memories, difficult sensations or reactions. And if you need to take breaks or take deep breaths, that's okay to do that. And please know, we will also be discussing how people can get help, treatment, community care, and all around all of these kinds of experiences. So that's important. So I'm wondering if we could begin with the first part of this dual title, Psychological Trauma Can Cause Seizures. And I'm curious, how would you define traumatic stress and post-traumatic stress in the sense of what happens in the brain and the body? And how can these cause PNES, which stands for psychogenic non-epileptic seizures in some survivors of trauma? Dr. Beimer, could we begin with you on this one?
Yeah, I'd be happy to. And then I'm going to rely upon my colleague, Dr. Winder, to help me out too. So from my perspective as a neurologist, I mean, I think about traumatic stress, post-traumatic stress in general, as far as like, is this something that we're dealing with in the here and now? In terms of the trauma, is it stress that's occurring in relationship to something happening at the present time? Or is it something that we're experiencing, perhaps after a traumatic event or a series of traumatic events that occur? That's at least the way I think about those distinctions. And if I think about kind of what happens in the brain and the body, as a neurologist, I think about chemicals. I think about, the connection of brain cells and neurons to each other, and everything that we experience, right? Like our sight and our vision, our hearing, it's all kind of sort of transformed by that process that we start to think and know a little bit about, but we definitely don't know all of it. But clearly, how we react and respond to things, there can be chemical changes in the brain. There can be physical changes in how the neurons are connected and they talk with each other in response to both those sort of traumatic things happening at the time, and also in response to, sort of those traumatic things in the future after the fact. And so I think about kind of how that happens both in the short and in the long term. Maybe it would be good to ask Dr. Winder also how we make.
Yeah, Dr. Winder, would you please chime in on that? Thank you.
Yeah, so diagnoses in mental health are just lists of criteria. Neurologists are lucky because they have worked out some of the biological contributors to a lot of what they deal with, and it makes us psychiatrists very jealous. But all we have for PTSD, as real as it is, it's not going to make it any more real when we figure out what the mechanisms are in the brain. But it is defined by the DSM-5 in the United States and North America as being a set of symptoms that are intrusive and cause a person to be very avoidant in response to a serious event, something like sexual assault or a mass conflict or some sort of displacement, physical injury, medical illness, childhood trauma. It also causes a lot of negative cognition and mood changes, and it causes a person to be very aroused, very, very vigilant and on edge. And there's lots of things that it does in the brain, but they're non-specific. We have not been able to work out quite well as to why this happens, but Dr. Beimer's right. It's a tail. It's a syndrome that persists even though a person isn't in a stressful situation right now. They have changes in how they perceive the world around them that can just be profoundly affecting in terms of how they interpret their world, the people in it, and themselves.
Yeah, thank you for that. And Sabrina, how would you speak to these questions from your own experience?
From my own experience, and very similar to Dr. Scott and Dr. Nicholas, it is a mental and a physical. They both play a huge role. And I would say that, I'm sorry, I kind of got lost. I say that because I've learned throughout the several therapists that I've seen that our body and our mind, as a matter of fact, as an example, our bodies can't tell the difference between good stress and bad stress at times. And because of that, we can still have these seizures or panic attacks and things like that. And when it comes to different forms of trauma, as Dr. Scott mentioned, we can be very, very hesitant, or, I don't want to use the word, I'll say cautious, very cautious and things like that because of our past experiences and the things that we've learned outside and inside of the medical field.
I really appreciate your all's perspectives. And I also find myself thinking about just a quote that I encountered recently from Dr. Bessel van der Kolk, who was talking about trauma comes back as a reaction, not always a memory. Of course, sometimes it does involve traumatic memory too, but all of these reactions can be a part of PTSD and complex PTSD. Like, we hear about fight or flight, also freeze or fawn, dissociation, depression, anxiety, numbness, overwhelm, people pleasing can be a traumatic reaction, overwork, somatization, where you begin to feel things in the body, like including PNES, hypervigilance, avoidance, insomnia, inability to get out of bed, difficulty being with others, or difficulty being alone. All of these can be post-traumatic reactions, and they all deserve care. And so that's so, so important. Thank you. And as I think about PNES, again, for those who may be listening and might be new to that terminology, that stands for psychogenic non-epileptic seizures. It's different than what happens in a sense during a seizure, which is a disturbance of electricity happening in the brain. But it presents in an involuntary way, but it is caused by psychological trauma and stress being expressed in the body. A lot of people don't understand PNES, and sometimes that's even true when someone goes to the emergency room or urgent care, or even in some doctors' offices. And I just wonder if any of you would be willing to speak to that, and how do we make this more known? Sabrina, I saw your hand, so let's start with you.
Yes, there are so many people that are unaware of the PNES, the difference between non-epileptic as well as epileptic seizures. There's been so many times that I've been out in public and I felt the seizure coming, or, unfortunately the seizure came, and I would have to say, these are non-epileptic seizures. There isn't, they're not life-threatening. As long as I don't just protect my head, I'll say the same things that people with epilepsy will say, the same triggers and everything. But the difference is there's two different people that I may come across. There's those that, unfortunately, which is the most difficult, is the stigma behind it. And if I get rushed to the hospital or something, or the police come, once they find out they're non-epileptic seizures, or they found out the medication that I'm taking, it's like they don't take it serious anymore. It's like, it's thrown out the window. And then you have the other people, I love my family so much, just well as friends, but they're like, are you sure, you wasn't having these seizures before? Are you sure it's non-epileptic? And it's like, yeah, I know what it's from. I've seen so many psychologists and psychiatrists. That's what it is. So having to deal with those that don't take it serious, those that do, and those that react in such a way, like in panic mode, that can also play a huge role in our life.
Absolutely. And I think also for many people who have psychogenic non-epileptic seizures, who end up in the emergency room and people don't know what that is, get told a lot, like, you're faking or you're exaggerating. And that, of course, adds to the trauma of that experience. That can also be true with people who have epilepsy, but we see this a lot with PNES. And I was just wondering if Dr. Beimer or Dr. Winder, if you'd like to speak to this. Yeah, go ahead.
Yeah, I'll speak to that for sure. I mean, I want to address that very fact, which, is brought up in the chat by Heather, for example, which is that there's this unfortunate misunderstanding that exists that psychogenic non-epileptic seizures, PNES, are not real in some way. It's no less real than it is for someone that has epilepsy, that experiences seizures that are not within their control. It's no less real than someone that has anxiety or panic that occurs, because of a trigger or because of no clear reason that happens at the time. Some of that misunderstanding, I think, is rooted in some of the terminology that's old and that we don't use anymore. And in particular, that term is pseudo seizure, right? So we don't use that anymore because pseudo, that sort of prefix, the meaning is false. And so it's misunderstood to think that a false seizure means a fake seizure. There's that kind of disconnection in what the intended meaning was from what it actually got interpreted as many people misunderstand it. And so I think that's part of that misunderstanding that exists, and it's perpetuated this stigma too associated with it, that a lot of health professionals, unfortunately, even though they're, I think most health professionals are well-meaning people that want to take care of, others, but even amongst, health professionals, we're not perfect. And I think that there's misunderstandings out there, both, that's trained into them incorrectly, and also what they think they understand about the diagnosis. So that's part of, also what I think is important, that we all work together to try to educate. Sometimes you yourself as the patient knows more about your own condition than sometimes the health professionals that you're seeing. And that's just a reality, right? That's sometimes true.
Thank you, Dr. Winder.
No, I agree. It takes courageous people like Sabrina to bring awareness to this. I think that her voice is, and her counterparts in the patient population are the most powerful to destigmatize this, but it does fall to doctors like us to try and change culture and perception within the hospital. Doctors, I guess we can say this, that we're doctors, are really arrogant, many of us, in that we have a hard time listening to people who aren't doctors. That's a good thing sometimes, and it's a really bad thing sometimes. And I am proud of being a doctor and a physician, and I'm also mindful of some of the ways that we think. So sometimes Dr. Beimer and I just need to have our statistics, like non-epileptic seizure patients have the same or worse mortality as people who have epilepsy. You say that to a doctor, you get their attention. Another thing you can say to a doctor to really get their attention is if you follow PNES patients and epilepsy patients out several years, you can't tell the difference if you're blinded as to the level of morbidity and disability that they have. And so these are tools that Dr. Beimer and I use within the health system to try and bring awareness to this. We talk to medical students and residents, and we're nice guys, I think, but we're pretty forceful too, to stand up for people who may not be able to get the care they need or be perceived in a fair way within the health system. So that's some of a look I think that Nick and I try and do behind the scenes within Michigan medicine and in the community.
Nice forces of nature. I'm here for that. That's great. Well, stress can be a major trigger in people who have epilepsy as well. And even if people don't have non-epileptic seizures, traumatic experiences and post-traumatic stress can increase the frequency and severity of seizures in people with epilepsy. So I'm curious, how do you see this in your life and practice, and how would you encourage people to care for this stress? Can we start with you, Dr. Winder?
Sure. I mean, this is the holy grail of being a shrink, is to try and help people to be more aware of their stress and to reduce it. So it's a huge question. To briefly just give a flyover, Renee, I guess I would say that looking in places like a person's relationships, how they communicate and what kind of companionship they have, how do they get their interpersonal needs met? If relationships are rocky and disconnected and chaotic, this brings a lot of stress. How does a person live? Their lifestyle changes and their choices they make into where they are and who they're with. How do they detect their emotions? Are they aware of what they feel? Do they have insight into what they feel and where it might come from? And then how do they cope and soothe themselves? Does a person human beings need control. One of the terrible things about trauma is that it's horror, shock, helplessness, the definition of not having control. And so for people who are traumatized and who have PNES, it's important to help people reestablish what they can control, and to help people who may be pleasers, like you were talking about, Renee, to not base our sense of control and efficacy on other influences or people that we can't control. And the way that this happens for so many people is in therapy. Therapy is a powerful way. It's like sitting in front of a mirror, that we get a view of ourselves and our thinking our behaviors, our memories, our beliefs that we can't see on our own, just like when we look at ourselves in a mirror. There's just no replacement. It's different than just talking to your friends and family. People say that, oh, I don't need a therapist because I can just talk to my friends and family. It's very different. And so therapy is just a kind of a sacred place, a very effective and rigorous place where people can do some of this work and be able to manage their stress in more adaptive ways.
Yeah, I love that. And to just, we're always about crushing stigma. That's true about mental health stigma too. And, it's so beneficial to work with a therapist, and there's no need for that to be shameful or stigmatized at all. And it can be so helpful. Now, Dr. Beimer, I'm sure you talk about stress with all of your patients probably every day. So what are some things that you say or that may come up frequently, and how to ease stress?
Yeah, I hear it all the time. Stress is part of the normal human experience, actually, right? We all have it, and it wouldn't be typical if you didn't. So in fact, I would say that for the people that I take care of living with epilepsy, they say, in fact, the most common thing that triggers their seizures, their epileptic seizures, is stress, in fact. And if we think about kind of how does that happen, in the reverse direction that we've been talking a little bit so far about, if you think about a part of the brain or the nervous system that regulates sort of mood and emotion, we think about that system as maybe being activated more, for example, in someone who's enduring a stressful experience. And it's not all that different from someone that has, for example, reflex seizures or reflex epilepsy. You can have certain things that trigger seizures. There's, things like seeing certain patterns, flashing lights as an example. And in fact, if you activate that part of the nervous system, you might, in effect, trigger that same network or pathway that can lead to an epileptic seizure. So it goes both ways, exactly as the title of our talk is saying. So thinking about it from that perspective, I mean, if you can pay attention, to your own sort of moods and thoughts and experiences, logging them, keeping track of it with a journal, keeping track of it in a log of symptoms over the course of time, that can help you pay attention to, is there a relationship there? Sometimes I think we don't do a very good job as human beings paying attention to ourselves, both emotionally and physically, right? We kind of just try to get along and do the best that we can. And then, when you go to see your doctor in the office and, they ask you like, well, did you have your seizure on that day when you were having more stress? It's really hard to think about that a few weeks ago or a month ago when you maybe didn't pay attention and write it down at that time. So keeping track of that's very helpful, in the future. And then, paying attention to those associations, those triggers, getting support from your family and friends, as you go through that process, have them help you pay attention to those things if you have difficulty doing so yourself. And then, of course, we could, go and talk about other strategies, relaxation methods, focusing on your wellness overall, trying to work on ways to deal with those stresses that both come from within and our environment around us. And then realizing sometimes that like you can't always do anything to maybe stop the stress that happened in the first place, but maybe you can react in a way that channels some kind of negative emotion or reaction to it in a more positive light, use that negative energy and put it in towards something good. So lots of different ideas and ways to respond potentially.
I love that. Thank you. That's really helpful. Sabrina, what is helpful? I know both with yourself in calming your stress, but also I know that you're a mentor, you're a motivational speaker. How do you encourage people to ease their stress?
I like to, first and foremost, when I say motivational speaker, it's more so survivor speaker. But my dad was like, look, if you're a survivor speaker, you motivate others. So, but excuse me, I will go on an example of yesterday. Right now, I'm trying to do so much. Like, for instance, there's so many women that, you know, as a mother and as a wife, excuse me, they're working, you know, they're taking care of their children, and they're, you know, cleaning the house, cooking, and they're doing so many things and still have time to work out and stuff like that. Yesterday, I've been trying to do these things, and then yesterday I was so exhausted and I felt the seizure coming, and it was like, even though I gave kudos to them, I beat myself up like, why can't I do that? You know, what's wrong? Why can't I do it? And it, you know, I journaled a little bit, and it helped me realize, like, hey, we're different, and I just have to accept things day by day. I have to accept things day by day and stay on a significant, not significant, a consistent routine when it comes to things. And there has been issues with therapists. I've seen several therapists that actually I've seen a total of 7 since I've had my seizures since 2016, and more than that, but they've left me feeling even more depressed than I was when I started, because either they didn't have any experience in it, or they didn't give me much hope. You know, so it's sad to say, but it's true that sometimes we have to depend on ourselves, whether it's you know, mentally and spiritually. We have to do things such as meditating and yoga and journaling. And I know some people who deal with mental health issues, they're like, yeah, I've heard that so many times, you know. And it took me forever, but meditation actually, it helps. You know, meditation helps. Staying on a strict routine, that'll help. Like you guys mentioned, logging in the seizures, but I've also learned about delayed stress. Some things may not come until, you know, weeks later, like dealing with loss of a loved one, plus a whole lot of different stressors. That seizure may not come right away. Sometimes those seizures may linger, and then out of nowhere, bam, you're having a lot of seizures. So acceptance of, you know, sometimes being the only one, continue to build yourself up, or acceptance of knowing that there are more people like you, even though you feel alone. You know, there's other people that's dealing with the same things, and to continue pressing forward no matter what it is.
No matter what, yeah, continuing to press forward. And as you said, to know that you're not alone. And I think what we are absolutely seeking to do at the Epilepsy Foundation of Michigan all the time is not only be an organization, but be a community, you know, for people to come and meet others with epilepsy and with PNES, and all of the experiences that surround it. So thank you all so much for sharing that. You know, as people talk about easing stress and developing some of these habits, I just want to also mention that at the Epilepsy Foundation of Michigan, several times a year, we offer an 8-week program that's free and phone-based. You don't have to go anywhere to do it, called Project Uplift, that helps people have some tools to put these things into practice. And if that's something that you're interested in, you can contact us and we'd love to chat with you. I'd also like to take some time and ponder the second part of this title, because we know that seizures can cause an experience of trauma. That's true. Living with epilepsy and PNES, it can lead to trauma and forms of post-traumatic stress. This can also be true for caregiving family members. And I know we have some of those folks here with us today, or friends, neighbors. We've heard many times from our community members that one of the most difficult aspects of living with seizures is living with the uncertainty that it causes. So some people go into fight or flight mode when there's a trigger, including caregivers, a sound or a movement that's similar to the start of a seizure, or maybe having watched a seizure, people then begin to feel hypervigilant, on edge, or having sudden intrusive memories of previous seizures that they've experienced or witnessed. And while that can get better over time, for many people, this doesn't fade entirely from the background of their lived experience. So I'm wondering if you can speak to these experiences. How do seizures cause psychological trauma? And for some, post-traumatic stress disorder. And I'm also wondering, and maybe Dr. Winder, you can speak into this, the difference between PTSD and CPTSD, C standing for complex, meaning that traumatic events are more chronic or longer lasting. So actually, can we start with you, Dr. Winder?
Sure. Yeah, I think Dr. Beimer will have a good view as to what can happen, and I'll defer that part of the question to him because he's a good describer of what can happen to people in the course of epilepsy or non-epileptic seizures that can be highly traumatic. PTSD comes from the hospital. We know this not just in the neurology population, but in the surgical population, the transplant population. So it's an excellent point, Renee. I will hand that off to Nick. In terms of complex PTSD, this is a little bit of a controversial idea. What I mean is that this idea was proposed in the 1990s, and what this idea has been in the recent decades is that there is a unique kind of extreme stress, that a particular kind of trauma stretches over the course of a patient's life, particularly originating in childhood, and that is extremely severe in terms of what happened to the person and how it compromises their development, how they define themselves, how it affects their personality. Many people with PTSD don't necessarily have that depth of injury, a psychological injury. Many people who have prolonged trauma or the amount of trauma that they've gone through seems to correlate with these deep, deep injuries as to what makes us who we are. So some features of complex PTSD that are described in the literature are things like affective dysregulation, which is just fancy words for people whose emotions are very volatile and difficult to control, who have disturbances in how they can pay attention or how they even can remember not only what happened to them, but just in general, if their memory is more severely affected. Do they injure their body intentionally? Do they have a profound hopelessness that we might see in a very severe case of major depression? We talked about personality changes. And there's a really profound one, which I think is really tragic when we see it, which is the loss of previously held beliefs. When a person believes something and has a culture and a sense of self, and then that gets damaged and taken, eroded, broken by an experience. I mean, what comes to mind is Elie Wiesel's book, Night. This was a Jewish gentleman, he's since passed away, but one of the most famous Holocaust survivors. And if anybody wants to read about trauma, certainly World War II and the Holocaust, but his description of this, I think, won the Pulitzer Prize, and the book is called Night. But this is a great example of somebody whose previously held beliefs were decimated by what he saw in the concentration camp. So it overlaps with depression, it overlaps with other personality disorders, and it does need additional treatment, this complex PTSD, perhaps even more than what we would normally do for quote unquote regular, there's no such thing as regular PTSD, but you know what I mean, maybe the tier or step below complex PTSD.
Thank you for that. And, I just think for a lot of people living with epilepsy and PNES, just that sense of trauma or sense of uncertainty can just travel over so much time. And then of course, impact, sense of identity or sense of beliefs of what's possible and all of that too. And I really, really appreciate you speaking into that. And Dr. Beimer, just wondering if you could speak into some of these things too, what you experience with families as well who are caring for their loved ones.
Yeah, I mean, it almost seems in some ways obvious when we're saying the words out loud about like what this repetitive trauma can do, and like, is it not traumatizing, right, to experience something really life-changing in terms of, sort of having a seizure? It affects us in terms of our ability to drive. It affects our ability to interact with the world sometimes. It leads to trips to the doctor's office and to the emergency department. These things are all in and of themselves traumatic, and difficult to experience. It's scary, right? I'm a doctor and I'm scared sometimes by, the blood draws that I have to get, or the procedures that we have to go through. That's a pretty universal experience. And so I think that we all recognize that, sometimes the in the process of helping people, you know, the things that we do to try to help care for people in the health system, we also recognize that sometimes that comes with risk. And that risk can be that it's uncomfortable, or the risk can be that there's possibly a chance that something bad could happen from a treatment or an evaluation, in the end hope that it will actually overall help one person. And so that process, the idea that you could be harmed, you know, by going to a hospital, that we know that that happens, right? It's unfortunate that it does. And so I think that it makes a lot of sense then to say that just in the normal process of getting care for seizures, no matter what type, epileptic or non-epileptic, that process can be difficult and traumatic in and of itself. And could that lead to this same process, you know, sort of that we've been talking about so far? I'd say absolutely.
Yeah, thank you so much for that. And Sabrina, I'd love to hear, you know, your thoughts on this too. Sabrina, I'll invite you. Sabrina, can you hear me? Also, I think you're muted.
Yeah, I muted and then I unmuted myself. I mean, I muted myself, unmuted, and then muted.
We've all done it in this era, of course.
Yeah. Complex PTSD and PTSD. I'm sorry, could you
Yeah, or
repeat
just
that?
you know, that sense of what it's like to live with uncertainty, you know, maybe speaking into that, or you know, how seizures themselves can cause trauma, not only, you know, having trauma cause seizures. It's, you know.
Okay, yeah, got you.
Sure.
I have complex PTSD from the things that I have went through from childhood until, you know, up until, you know, a few years ago or a while ago. So I can completely agree when you guys say that the trauma can, you know, can happen with non-epileptic seizures as well as epileptic seizures, because since I've had the seizures, I'll say back in September, it was a really, really rough month for me. And I had agoraphobia for a while. I'm not sure if many people know what agoraphobia is, but agoraphobia is when you are afraid to leave the house without someone. You know, you're afraid to leave by yourself. And right now it's still at that point because I had so many seizures, you know, so many seizures like every day, and there was new symptoms that came about with it. Now, there are some things like you guys mentioned with the trust and fear, and I had wrote a few things down, like the forms of stress. And what I've learned is the trauma, what I think the seizures are is the trauma forcing its way out. Many therapists said I threw my problems up under the rug so much where it was like, the rug was like, okay, I can't take it anymore, you know? And so that's what the trauma has been, that's what it has done. Yeah, I'm going to keep going, but I'm starting to not feel the best, and I hate that now.
No, it's okay. You take whatever space and you need, and we're all here to care for each other. That's what we're all doing. And thank you for your, you know, wise words. That's caring for all of us right now too, and we're with you as you feel this. Yeah, I relate to pieces of that as well. And I developed complex post-traumatic stress disorder too, and the survivor of a number of traumas. And one of those was my epilepsy itself, which was a really deep trauma in my life in childhood. And it's so meaningful to me to be doing this work now. There was a long period in my life, I couldn't even say the word epilepsy without the most intense emotional flashback in my body. And now I say it every day, and I do this work every day. And it is so meaningful to be able to do that. I definitely want us to spend some time talking about treatments and care for trauma and PTSD around epilepsy, and just generally, you know, what are some things that can be helpful? And Sabrina, I see you, so I want to invite you. can get you mute. Okay, no, okay, we're with you. Yeah, let's talk about some treatments and maybe some people here have experienced some of these forms of help too. And Dr. Winder, would you mind speaking to that?
Sure. Treatment in mental health is always kind of multimodal. There's always a lot of things that we want to try. We always want to avoid the idea of a magic tool or some sort of one thing that we can do that will make things better. And we use, Dr. Beimer and I in clinic, we use a lot of analogies, and we talk about the importance of having like a toolbox. You would never expect a surgeon or a chef or a mechanic to be able to do their work with only a few tools. They need more tools to be able to accomplish a large task. But as humans, Dr. Beimer and I, we're sympathetic to the idea that people have a big problem. They want one thing that's going to make a big difference. And so Dr. Beimer can be a good salesman, and he helps kind of sell us all on this idea that we need a lot of different interventions because that is human nature. So what are some of the tools in the toolbox? Well, certain medicines that work in the brain on serotonin can be helpful. We tend to treat for maybe 6 to 12 months. There are studies that say if you take people off of these medicines, that they might have their PTSD symptoms come back. Sometimes using what are called second generation antipsychotics, which can be used to treat things like bipolar disorder or schizophrenia, but they also have been used as single treatments or as add-on treatments in PTSD with some signal in the studies that they are helpful. Prazosin is an anti-adrenaline medicine that we take before bed to control blood pressure. It can shut down nightmares. Try to avoid things like sedatives. Therapy is crucial. We talked about that. Different types of therapies. I think Erica mentioned EMDR in the chat, which is eye movement desensitization and reprocessing therapy, which is an evidence-based therapy. Prolonged exposure, which is kind of a scary thing, the idea of talking about and writing about my trauma over and over and over and over and over and over and over again to desensitize my brain. And then CBT, which is learning about sort of the distorted ways I might interpret what's happening that are being colored or forced on me by what I've been through in my memories, learning new ways to deal with maybe maladaptive or unproductive ways of thinking and behaving, learning new behaviors. This is powerful, powerful stuff, in addition to all the stress stuff that I already said about relationships and insight. And so I don't mean to make it sound like a hodgepodge. You know, we would all walk into maybe a chef's kitchen and be like, oh my God, like, how do you know what any of this does? And sometimes I think when people hear a shrink talk, it's kind of like, well, what does any of that stuff mean? But I think one of the services that a good psychologists and social workers and therapists provide is to bring all of those big tools down and help us select a few that we can begin to work on and guide us through the process. The only reason I'm throwing everything at everybody is just to kind of give a big view. But those are some of the things that that doctors and therapists think a lot about with PTSD.
Yeah, Dr. Beimer, anything you'd like to add?
I mean, Dr. Winder covered all of it so well. I would say from a neurologist's perspective, I think about the other comorbidities, meaning like the other stuff that people that have PTSD and non-epileptic seizures and epilepsy can have that kind of maybe are somewhat related to these conditions, but not directly as a consequence. So for example, when we see people that have these symptoms, we also screen for other conditions that might not be recognized too. So for example, substance abuse or dependence, we worry about, how we use chemicals, that are legal and acceptable, alcohol and marijuana and other things like that, to sort of, make us feel certain ways. And we worry about the effects that those can have on the body. We also think about, medical conditions that can occur along with, these conditions as well. So for example, our sleep can be dramatically affected by this. Like we've talked about, nightmares is one point. Another point is like, what if we don't sleep well and we get unrestful sleep? Or maybe we're a snorer and, we have maybe a condition called obstructive sleep apnea that can be related to a physical or mechanical problem with the airway that's more common in people who, for example, have issues with weight and might be associated with this condition in a higher degree than the average person. So we think about those other medical causes that can go alongside. So we want to make sure to not forget those things in addition.
That's so good. Yeah, thank you so much, both of you, for that insight and those ways of getting help. One thing I'd like to encourage people to think about also, if you are seeking a therapist, if you've never seen a therapist and you think that would be helpful for you, there are some ways to find one. I really love a website called Psychology Today that allows you to search for a therapist in your area, and you can see some things that they specialize in. You can see what insurance plans they take, whether they will do a sliding scale or not if you don't have insurance or if they don't take your insurance. You can also do some searches for, like, I'd like to find a therapist that has a background and expertise in trauma or chronic illness is one of the other search criteria you can use on Psychology Today. So I encourage you to look up that. Other, somatic forms of treatment might be sensory motor therapy is another one. Neurofeedback is something others have used. Of course, mindfulness and meditation, as Sabrina mentioned so well, can be helpful. So all of these, they're great tools. They're great entry points. So now
there's one more, TRE.
Yes, please tell us about that.
Yeah, trauma release exercises that has, I was doing that for a while, and it helped me tremendously. I hadn't had a seizure for like 3 months, and it really helped. A lot of people are unaware of it. What it does is how those who have PNES, our bodies voluntarily or involuntarily shake and everything. TRE makes your body voluntarily shake, and you can stop at any time. So it's like, it helps you release that trauma, it helps you release that trauma, but it also shows you that you're in control.
Friends, we have a few minutes for questions, and we don't have a Q&A box here in this format, but we do have this chat. So I'm wondering, you can ask a question to all of us collectively or to any one of our panelists. So feel free to just put that in the chat. We'll start there. What questions do you have? We have about 5 minutes for those.
Renee, this is Brianna. I'm not sure if you can see this on your end, but you actually do have a couple questions in the Whova chat platform.
Would you voice those and we'll go from there? Thank you.
Sure. First one is, how do you know if a person has PTSD?
Great question.
You want to take that one?
Sure. Yeah. So this is kind of the reality is it's just the clinical opinion of the person sitting across from you. There are not any more objective measures yet of PTSD. So the DSM-5 in the United States or the ICD-10 outside are just lists of criteria. So it's a clinician thoughtfully, hopefully, and thoroughly sorting a person's experiences and deciding if certain criteria are met, and then the diagnosis is given. But that's different than neurology, because they can take pictures of these, the brain with these gorgeous pictures with magnets and radiation to understand the structure of a person's illness, and they can say with more certainty what a person has. But a lot of the psychiatric diagnoses like PTSD are quite reliable, even though they are just lists of criteria, but that's how it happens.
Thank you. Dr. Beimer, anything you want to add?
No, nothing else I'd add to that.
Okay, great, thanks. Brianna, would you like to just keep voicing questions for us? Thank you.
Sure. The other one that I'm seeing here, to kind of paraphrase, I would say, is there any notable differences in the seizure first aid between a psychogenic non-epileptic seizure and an epileptic seizure?
What a great question. Dr. Beimer, would you like to speak to that?
Yeah, definitely. So I would say that the first aid, of course, making sure someone is safe, getting them into a recovery position that we talk about, making sure that they're out of harm's way. These are obviously the basic things for both types of events. I would say that what happens after the initial phase of that first stage that we would talk about would be where things kind of diverge or differ a little bit. So, we talk about in epilepsy, the definition of like status epilepticus, which is just a continual seizure that's happening. And there are time points at which, it might require emergency treatment with rescue medications and when, need to call 911, for example. And that can be a little specific for the person. It might be different person to person depending upon their epilepsy. If we compare that to people that have PNES, we know, in fact, that by definition, the individual event itself, as long as one is out of harm's way physically, is not medically dangerous in the same way that epileptic seizures can be. And so we want to be mindful about the risks of going, in fact, to an emergency department when we may not need to for a non-epileptic seizure. So they can last longer, for example, on average, than epileptic seizures can. And so that's one thing to be aware of. If we have atypical features, meaning to say if someone's having something happen to them that's not like what's known to be their non-epileptic seizures, either the symptoms themselves or how long they're lasting, which is maybe typical for that individual person, then of course, maybe they do need to have more urgent evaluation. It's hard, and I hesitate to put specific time points or numbers on anything because everyone's different. And I would say, talk to your doctor about, what they would recommend for you. Those are kind of the main points and how they differ.
Yeah, tremendous answers. And thank you all so much. We are just about out of time. This is a topic, whether we're looking at it from the angle of PNES or trauma caused by epilepsy or trauma being expressed as stress, which, impacts epilepsy and seizures. This is such a crucial conversation. And I think one that we hope to continue at the Epilepsy Foundation of Michigan. So I want to thank all our panelists for a fascinating presentation, and thank you to Michigan Medicine for sponsoring this session, and Drs. Beimer and Winder. I love that you've all work together in the ways that you do, and that you've brought that deep wisdom to us. I also want to thank everyone in our chat box who not only asked good questions, but shared from their experience. And it is your lived wisdom and experience that also fuels our work, both in the ways that we want to advocate, but also as you bring your gifts and your talents and your life experiences, we're all building that community together. So as you look at the chat box, in fact, our president, Brianna Romines, has placed the survey of evaluation form for this session. So we want to invite you to open that now and complete it. And then, of course, we've got one more session to go. This has been a really lovely experience. And our very last session of the day is going to be our networking session. We're going to be able to talk to each other a bit more. And it is sponsored by Henry Ford Comprehensive Epilepsy Center. So to participate in that networking session, please go to your conference agenda icon, either in the Whova platform and click on the networking session title. And if necessary, the live stream on your phone app. Or if you're not joining us through Whova, you can just click the Zoom link that you were provided for the networking session. You can find that in your participant guide. We also encourage everyone to visit our exhibitors' virtual booths before signing off tonight. That's part of why we got this great Whova app to help us do that. And this conference is absolutely made possible due to the support of our sponsors, those who are setting up these exhibitions for us. So please be sure to check them out. And thank you for joining us. We will see you in the networking session. Thank you again, Dr. Nicholas Beimer, Dr. Scott Winder, Sabrina Banks. Thank you so much. Have a great night, everyone. We'll see you in networking.
Today's first session is entitled Side Effects and Complications, What to Expect and How to Correct, and is sponsored by Henry Ford Comprehensive Epilepsy Center. We're honored to have Dr. Omar Danoun, who's an epileptologist from the Henry Ford Comprehensive Epilepsy Center, to present for us today, as well as Nancy Serrano, who's a person with epilepsy, who'll share a bit about her story and her experience with this topic. So Dr. Danoun, whenever you're ready.
Hi, good morning, everyone, and thanks for having me with you today, this morning. And yeah, it's a pleasure to talk about epilepsy. And it's one of the interesting subjects that I love to talk about, which is the complications of the treatments for epilepsy. So we treat epilepsy every day, and we deal with some, like we enjoy the seizure freedom, the improvement in the seizures, and all of that, but we sometimes deal with some other complications and side effects. So today we'll discuss all of that. So our objectives really today is to talk about the medical treatment of epilepsy and what their side effects, and how we can mitigate those side effects and medications, because there are lots of ways that you can improve those side effects. And we talk also about epilepsy surgery, the resective surgery, and neuromodulations. And at the end, we'll give you some tips that you can discuss with your doctor so that you can modulate and improve those side effects. All right, so anti-seizure drugs, it's a proliferative subject. We have so many drugs coming to the market every single year. And this graph stops at 2018, and we have multiple drugs coming out every year. So we have lots and lots of drugs. So which one to choose and how to choose it is a deep process and discussion. So we have multiple keys how the brain works and how we can modulate the brain activity. So there are multiple mechanisms of action. So mechanism of action means like how the drug can help seizures and epilepsy. And if we understand the mechanism of action, we understand which key the brain works at. So this is a subject for, so the action potential, the electricity comes to the nerve and then moves to the next nerve, and there are sensing objects there. And we can modulate that by attacking multiple areas in the action potential and around the nerve. So those are all the areas that I want you to think about. When we are treating epilepsy, we are targeting those things. So that's why sometimes we have multiple drugs and we have multiple combinations, because everyone is a key to a different lock. All right, so now when we have medications, things are sometimes chaotic and we have so many targets and we're having many things. So what we need to do is we need to organize things. So how can we organize things? We need to think about the side effects in a different categories and profiles. So side effects can be short-term side effects or can be long-term side effects. Sometimes when you take the medicine, you can have some reaction to it, and sometimes it can present later on in life. Sometimes side effects are mild. There are a little bit of discomfort here and there, and sometimes they're moderate and sometimes even severe or life-threatening. Sometimes they are reversible. You stop the medicine or decrease the dose, things will go away. But sometimes they are irreversible, means they cause permanent damage and changes. Sometimes they are dose dependent, means that at a lower dose, you have some side effects. When you increase the dose, the side effects can increase as well. And sometimes we call it idiosyncratic. So idiosyncratic means that the side effect is related to the drug itself, and we don't expect it to be anything like related to the dose or time. It can happen at any dose, at any time. And sometimes it's organ specific, means that some medications will affect the brain more. Some medications will affect the liver. Some medications will affect the kidneys or the bone marrow or whatever organ they might interact with. And we have medication that they talk to each other and interact with each other. So when we make decisions about treatment, we should put all of those things in mind when we are deciding to which medicine to choose for which patient. So when we talk about some side effect profiles that we can see in patients and medications, so some side effects like angioedema, like swelling of the throat, can happen with brivaracetam. Stevens-Johnson, some skin reaction can happen with most of the anti-epileptic drugs, but mostly for lamotrigine and carbamazepine, especially in Asian ancestry. And weight gain. So this is like one of the worst side effects that we have. Many medications can cause weight gain, and the notorious ones are valproic acid. The Depakote is a champion of weight gain, gabapentin, pregabalin, and even brivaracetam. So all those medications can cause weight gain. So, but they are on the opposite side, some medication cause weight loss. So the weight loss medications are zonisamide, topiramate, and felbamate. So I want you to kind of like just run through the park, like what medicine can cause what side effects, so that when we think about that categories, like to choose which one is right for us. Some medication can affect the vision, and it is unique for vigabatrin, ezogabine, and topiramate, and amenorrhea, means stop the period, and that can be in everolimus and Depakote, valproic acid. There are some medications that decrease sweating. Do you believe it or not? So if you have a hot day, your body will not produce as much sweat, and then you have to be careful, and you should know about this side effect so that you be hydrated, you cover yourself better, and avoid extreme heat. And some medication can cause hair loss, which is pretty notorious for valproic acid, the Depakote. And some of them can cause thinking problem, cognitive decline, like topiramate, zonisamide, and valproate. And some of them can increase the cholesterol and triglycerides, like everolimus, and cause kidney stones, such as topiramate and zonisamide. So, here we have kind of to think about what medicine, what our body has, so that we can choose the best medicine for you. And one of the most important things I love to talk about, and this is very relevant for every single patient, is the mood side effects. We are treating the brain. Epilepsy is a neuron and network condition, so as depression and other psychiatric conditions. So for patients who have epilepsy, especially the refractory one, they often have epilepsy with depression, anxiety. So we should really know which medicine that can worsen the psychiatric manifestations, which the medicine can cause depression, anxiety, and PTSD symptoms. So the notorious ones that I want you all to think about and always avoid and discuss with your doctor are the levetiracetam. So levetiracetam, the Keppra, perampanel, and phenobarbital, those medications are notorious for causing depression, anxiety, and some psychiatric issues. So always you want to avoid those medications. And if you have history of anxiety, depression before, tell your doctor about that and try to avoid it, because sometimes they just have a knee-jerk reaction. Anyone with seizures, they will start them on Keppra at the beginning, and that sometimes is the wrong approach. And you should always think about depression, anxiety before you start the medicine. And on the opposite side of the spectrum, we have medications that are happy medication, we call them. So like valproic acid, lamotrigine, those are mood stabilizers, those are antidepressants. They reverse the effect of anxiety and depression, and they can help with that, so as carbamazepine and eslicarbazepine. So as you can see that we have medications on the both streams. Some medication can worsen the anxiety and depression. Some medications can be neutral and be good. So we also think about the bone health. So bone health is that when you have effect on the bones from the medication. So medication can cause bone issues and can decrease the bone density. So usually epilepsy by itself is at increased risk of bone loss. So people with epilepsy, they can experience a little bit weaker bones because of the lifestyle. Sometimes the underlying condition that cause epilepsy to begin with, such as stroke or cerebral palsy, those conditions, they will decrease the movements in the body, and that can decrease the strain on the bones and decrease the bone building. So there are seizure medications that they can worsen the bone loss, and those seizure medications are phenytoin, dilantin, phenobarbital, primidone, and carbamazepine. So luckily, all those older medications, they are causing bone loss, especially on the long term, especially in females age more than 50 or 60. So very important to think about that when we put patients on medication that can potentially cause bone loss. And valproate as well, and also to some extent lamotrigine. Most of the old medication can cause this bone loss issue. So what we do with that, we give vitamin D universally and calcium supplements. So every patient who is taking anti-seizure medication. So I want you next time, if you take seizure medication, discuss with your doctor. Doctor, hey, am I taking vitamin D? Am I taking calcium? So always very important to discuss that. And especially in Michigan, the weather is cold and we don't have enough sunlight. So all of us are deficient on vitamin D. So in pregnancy at teratogenicity, this is a very important subject as well. When patients have planning on getting pregnant or they are pregnant, we have to think about medication. So really, we think about the pregnancy ahead of time when we are planning any seizure treatment. So in pregnancy, about 90% of women with epilepsy, they carry completely normal pregnancy whatsoever. So that's a very good news that epilepsy is safe during pregnancy and seizure medication. However, the risk is dose dependent, means that it's different with each medication and different with the dose of the medicine. So this is a very nice illustration from the continuum that discusses the medications and their risk. So the first thing I want you to look at is no anti-epileptic drugs. If you go downtown Detroit and measure all the people that they're walking down the street, if they are pregnant, their risk of malformation, means like have a baby with any malformations, they have a cleft lip or any issue, is 1.6, about 2%. So, and the seizure medications, most of them are around that. So that means that seizure medications are safe and very, very important, because some people are so concerned that they don't want to get pregnant because of their seizure medications. And I want to reassure you that seizure medications are safe during pregnancy. However, there are some medications that we want to avoid at any cost, which are those three medications: valproic acid, Depakote, phenobarbital, and topiramate. Those medications, they can cause much higher risk. And look at the risk is much, much bigger with those medications. They can cause much higher risk of fetal malformations and baby issues. So what we recommend is that ahead of time, plan the pregnancy and make sure that you're not on those medications. So proactively, we don't put any female of childbearing age potential on those medications. So what we do is that we try to avoid them. But if a patient came to me or to any other doctor on those medications, we'll try to wean them off before the pregnancy happens and put them on a safer medication. And the half medications, the carbamazepine, phenytoin, and clozapam, they have risk on the fetus, but it is lower than the others. And the best medications we have for pregnancy are those through lamotrigine, like Lamictal, levetiracetam, the Keppra, and oxcarbazepine, triliptal, and zonisamide. Those medications are considered very safe and the safest in pregnancy, and we are comfortable having patients carry on pregnancy without any issues during those medications. And the risk is very low. So what we do, we universally give every patient who is of childbearing age on anti-seizure medications folic acid. So folic acid is a vitamin that you take every day to prevent those malformations. And we really need the folic acid before pregnancy. I know that every time the patient gets pregnant, they go to the OB-GYN doctor and they start them on folic acid. But really, when you know that you're pregnant, it's sometimes like a month or two in the pregnancy, and the need for those folic acid particles are really at the beginning, the first few days. So you really need to get that prepared in the system ahead of time. So what are the treatment strategies that we use to minimize and decrease those side effects? So the treatment strategies that we always look at is, the first thing is champion with the patient. So you, as a patient, you should talk to your doctor and know. So explaining the possible adverse events, the side effects, will improve the patient compliance. Because let's say that some medications that cause tingling in the hands, which is reversible and goes away, and then you start taking the medicine that's called topiramate, Topomax, and you start having the tingling, and then you freak out, oh my God, I'm having neuropathy, there's something wrong, and you stop the medicine. But if the doctor explained this side effect ahead of time and tells you, look, this medicine can cause tingling the first few days, it will not cause any problem, just will go away on its own, so don't worry. So knowing ahead of time is much better. And then usually we use the lowest effective dose, means that some medicine on a low dose, they will be effective against seizures and will not cause side effects. So we will usually choose the lowest effective dose so that we have the benefit of the medicine without the side effects of the medication. And we maximize current anti-epileptic drugs and seizure drugs before changing it. Sometimes we give up too early on the medicine and use it just in a short time or a small dose. We should really maximize the medicine before changing it. And we use sequential monotherapy. What does that mean? It means that we use one medication, and if the medicine fails, we add another medication and take that one that failed, because we don't want to add multiple medications because they can combine the side effects. And we avoid fast titration. Everything in the brain, if it is given slowly, that will be a very good outcome. So my professor always was telling me that medications are like tight shoes. When you wear the shoes at the beginning, it will be tight the first few days to a week, and then it will loosen up afterwards. And that's exactly what happens with medications for seizures. So when you take the medicine, the body takes a little bit of time. So be patient and know what the side effects, and then usually it will improve with time. So that's why we give slow dose, smaller dose at the beginning and increase with time. And then we know that in newer medications, they have much better side effect profile. And when we combine medication, at the beginning, we talked about how we can attack the nerve from multiple areas. We try to have combination of different mechanism of action. So every mechanism of action has its unique medication effect, and it has unique side effect profile as well. So we try to combine different mechanism of actions. And then at the end, if your medicine is causing you to have side effects, if we switch the medicine, the same medication, to an extended release version, sometimes it can be resolving the side effects. For example, if you're on Keppra and then you have side effects from that, you're like anxious, you have some dizziness, or you have some stomach upset, we switch it to extended release. Extended release the medication slowly into the blood, and that can solve the problem. So it's really a tailored position. So we think about the patient, and then we think about what medicine is best for this patient based on their background. So what we do is that if somebody has bipolar disorder or psychiatric history, we give them the happy medicine, the lamotrigine, valproic acid, carbamazepine, and we always avoid Keppra in those patients. If somebody has migraine headache, we give them topiramate and gabapentin, valproate. Those medications can prevent migraine and help with that. If somebody has a neuropathy, and we give them pregabalin, gabapentin. So every condition you have, you can treat multiple conditions with the same medicine. If somebody has tremor, we give gabapentin, primidone, and topiramate and phenobarbital. If somebody has trigeminal neuralgia, this pain in the face, we can give carbamazepine or carbazepine. That helps a lot with that condition. And one of the things that it is very, very uncovered and lots of people don't know about it, if somebody is struggling with alcohol, there is a medicine that works wonderfully with alcohol abuse. It's called zonisamide or topiramate. So zonisamide, zonogrand, topiramate, Topamax works great with alcohol abuse history because it decreases the craving for alcohol and makes the withdrawal easier. So it's an excellent medication for patients with alcohol abuse. All right, so this is all medication-wise. So now let's talk a little bit about surgery. So epilepsy surgery is one of the most successful treatments for epilepsy. And it is #1 treatment that we go for when medications are not working. So any patient who has seizures that are more than 1 year, they're happening for more than 1 year, they're not controlled with 2 medications, either used individually or in combination, then they should go to the epilepsy center looking for a treatment with surgery, because surgery is very successful in patients when chosen specifically, and then you really need to see the epilepsy center to know if you're a candidate for seizure and what type of surgery you're a candidate for. So resective surgery is that when we have a spot in the brain, we can take it out, and we know that it is one spot in the brain, and we know that it can be taken out safely. Example of successful resective surgery can be when there is an identified scar, such as mesial temporal sclerosis. So if you have mesial temporal sclerosis, if you hear this word from your doctor, that's a very good news that you have a surgical treatment successful epilepsy type, and taking that out will very, very likely render you seizure-free. Focal cortical dysplasia, when the cells are not aligned correctly in the uterus, and they can cause seizures down the line. Tumors, especially the low grades, there's one tumor in one area, you take it out, and that will help the surgery. Cavernous malformation, which is surgery, seizure caused by abnormal blood vessel combination, and we have some adverse event from the surgery itself. So how we can think about the surgical adverse event? So we are sitting in the office for the doctor trying to understand, is surgery good for you? What are the things that you need to worry about if you are having epilepsy surgery? So overall, epilepsy surgery is safe and it is effective. So, but there are always some risk for anything that we can do. So anesthesia and procedure complications. So there are some anesthesia, just being anesthetized and going through a procedure, very, very small risk. Bleeding on any infection, it's also small risk. In our hands, surgeons are excellent, and the risk of bleeding is very, very slow and small now. Weakness or stroke, that can happen at 3 to 6%, and most of the time patients can improve with that. Death is very, 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 very low. So it's 0.14%, and it is much lower than the risk of death from epilepsy itself. So epilepsy surgery is the way to kind of save lives and help people with epilepsy. And there are some psychological side effects. So if we take one temporal lobe, some people can have depression or anxiety, but this is also a low risk, and visual field defects can be low risk. So overall, the risk of epilepsy surgery is very low, but I want you to know all those factors, so kind of just think about it when you are deciding. But we should weigh it with the risk of death from epilepsy, which is unfortunate. All right, so the cognitive changes after surgery. Let's talk about this, because when we are taking the temporal lobe is the workhorse or the workhorse of the memory. And if we take the temporal lobe out, then memory can be affected, and about 25 to 35% of quarter to a third of people can have some cognitive issues after having the surgery done. But luckily, usually the left temporal lobe can cause verbal memory, means like talking or remembering things and names. And then the right temporal lobe can affect the spatial memory, navigation and driving and getting directions. So it depends really what area we are treating. And then usually the good news is that the majority will improve. And we have cognitive rehabilitation programs at our centers that we can retrain the memory and retrain the other areas to take the slack, if you will, on that area that was resected. And lots of times, that temporal lobe that is supposed to work for memory, it is occupied by seizures, and that is causing the cognitive dysfunction. So usually children, they have much less consequences of surgery than adults. Why is that? Because their brain is still maturing, still organizing. So if we take some part of it because of the seizures, then we cure the epilepsy, and then that will help them down the line. And there is plasticity, means it's pliable, it changes and adapts to the future. So we should know that untreated epilepsy and status epilepticus, which is like non-stop back-to-back seizures, it can affect the brain cognitive function, and it can cause cognitive decline over time. So really, when you do treat the epilepsy appropriately, that will decrease the chances of cognitive decline around it. So what are we doing to mitigate that? So now we have much more minimally invasive procedures that we can do, such as laser ablation. So what we do is that we, instead of like taking out the brain, we found that during the procedure, just dissecting the brain and going into the area that we need to take, that can affect the cognitive function, because we're kind of like have some collateral damage because we're going into the brain to take out some areas. And then with this laser ablation, we can just target that small area directly with a laser probe and take it out, and that will very, very much help. And we are currently doing ongoing studies on laser ablation, and we're at Henryford and myself are part of this trial that we're studying this in deep detail and looking at the cognitive functions very closely. So how is the surgery flow here? So in thinking about the surgery, how we decide which surgery technique to go for. So if somebody has a known seizure focus, we know the scar, we know the spot, the EEG showed that, and we see it on the MRI, there is one seizure spot, excellent. So then we go to that route of, is it safe to resect? So we know that there is a scar there. Is it safe to resect the scar? If it is safe to resect it, we'll just take it out, and that will be the best outcome. When we have a scar and we take it out, that will be the best outcome. If we could not, if we identify the scar, but we cannot, or the seizure spot, we cannot take it out because let's say it's in the area where you talk or the area where you move, then at that time we can put a stimulator at that area and stop it. And if we have multiple focus, means multiple spots in the brain causing seizures, or the seizure is affecting from more than one area in the brain and we cannot localize it, then it's a path of stimulation. So if either we can do VNS or we can do DBS, so vagus nerve stimulation, deep brain stimulation. So let's talk about vagus nerve stimulation. So vagus nerve stimulation was the first device approved in 1997, has been on the market for a long time. We have very long experience with that. It helps seizures a lot. It can decrease the seizure frequency by at least 50% in 50% of the patient, and the improvement increase with time. So the longer you have the device, the better it will be. And it will decrease the seizure frequency and also the duration of the seizure itself. So instead of having a big generalized tonic-clonic grand mal seizure, it would be shorter, and the recovery time can be also shorter. So this device works very well. It can respond to the heart. I know that you have magnets for the BNS, but it can also like automatically detect the heart rate increase during the seizure, and that will help the seizure to terminate. And we can do advanced programming. So instead of coming back and forth to the clinic every time, you need to increase the programming of the device and make it therapeutic and treatment dose. We can just set it up to a program itself and increase every two to 3 weeks on its own. And that really helps and cuts down the visits to the hospital and to the doctor. And it also, we can set it up for night and day programming. It is MRI compatible, that means that you can get MRI with that. So we have to think about all of those things when we decide on which device and which treatment to choose. So some adverse event can happen. So it is located in the neck and it is located around the throat. So the nerve is the biggest nerve, and that is the nerve that makes me speak and makes you talk. And if it stimulates that, then people will have vibration in their voice and will have hoarseness. So the most common side effect is hoarseness of voice, throat pain. All of them is kind of like local to the stimulation, coughing, shortness of breath, and sometimes tingling and muscle pain. So all of those are kind of local side effects. We do know how to tweak those side effects by changing the parameter of stimulation. We have lots of parameters that we can change. So definitely we can deal with that. And it also affects the sleep apnea. So if the seizures are like the vagus nerve stimulator is causing you so much trouble, you cannot breathe, you cannot talk, or I have like a singer patient that has a hoarseness of voice whenever the VNS is going off, but he's a very good singer. So what he does is that he puts the magnet just on top of the device, and that will turn off the device, and then he can sing throughout the concert, and at the end he will take the magnet off and he will get the treatment he needs. So yes, if the device is bothering you, stick the magnet to it, it will turn it off, and the minute you take off the magnet, it will turn back on. All right, another device, which is responsive neurostimulation. So responsive neurostimulation is really a smart device that we put in the brain, and the device has a mini computer inside it and studies the brain activity all the time. And we train the device. This is seizure, this is normal brain activity. And when it sees a seizure, it will directly shock the seizure, if you will, kind of like give a small electricity shock that will stop the seizure at its onset. So when we use this device, we cannot take out the seizure focus, means that it's in the area of vision or movement or talking. Or if you have two foci in the brain, so two spots in the brain, we can stimulate both two. More than that, we cannot. And then it has been shown that it can improve mood, it can improve cognitive scores, even it can improve quality of life and risk of death from epilepsy. So it's a very good device that we use. And there are some adverse events. Of course, this is the subject of our talk today. So it can cause surgical complications. Like any device and surgery we do, we have some surgical complications from that, infection, bleeding. Those are very low risk. It does happen, of course, but it is low risk. And the surgeon will do everything they can to kind of mitigate those and like have very good cleaning, everything sterile. And sometimes bone erosion, because it's sitting in the skull, it can affect the bone on the long term. And some patients can have worsening of their seizures if like the network is stimulated at a high dose or kind of like was put in the wrong place. And it can affect like the sleep. All right, so this is for deep brain stimulation. So deep brain stimulation, the third device. As you can see, we have many devices and many surgery options. So you really like need to go to the epilepsy center to choose which one is good for you, because all of those devices and surgeries can help you. And any patient with seizures that are not controlled with medication, they are a candidate for surgery and surgical treatment, and they will get help. But it just decide which one you're best candidate for. So the deep brain stimulation is a device that we stimulate the middle of the brain, the thalamus. So let me tell you how this works. So the thalamus is it's a very interesting area in the brain. So this is the thalamus. It's kind of like deep in the brain. I think of the thalamus as the hub station, the downtown metro station. So the activity comes from the temporal lobe, goes to the thalamus, and then from the thalamus will go to the other side of the brain and will come back. So this is a strategic place that is located in the middle of the brain that all the trains come to and all the trains depart from. So it is very located strategically. So when we do stimulate this thalamus, the electricity will flow throughout the brain and will help a lot. So it decreases the seizures by 50%, and it is MRI compatible, means that we can do MRI if you get that device. And also it has some adverse events. So the first adverse event that I would think about is like surgical, of course, surgical treatment related, bleeding, risk or infection. Those are small, but they are there. Depression, because it affects the mood network, it can cause depression. So depression is about 15%. So definitely if you have depression, you should discuss with your doctor if you are a candidate or not. It is not a contraindication, means like you can get this device if you do have depression, but we learned with dealing with this device that if we stimulate at a lower intensity, you can get the benefit without the side effects. It can cause memory issues because it's also affecting the memory network, and it can cause sleep disturbance. So how can you discuss with your doctor those adverse events? So I have some take-home messages about this discussion, so you can balance the risk and benefit. So every time you should always balance. So what is the risk of me having seizures on my life, on my quality of life, work, driving, all of that, and what are the benefit of the medication? And then I'll ask about the percentages and likelihood of those adverse events to happen to you. So here, if I tell you that this medication or this one will cause a rash, will cause a stomach upset, will cause all of that, and if you go read the insert package that comes with every medicine, you have a long list of side effects, and you will be like scared to death, and you will not take any medication. I mean, like aspirin has a ton of side effects. So what you should discuss with your doctor is like, doctor, how often those are really happening, and what is the chance that this happens to me? Because the medicine is the pharmacy is obligated to write all the potential side effects, even if it happens to 1 in a million or like 1 in 1,000 patients. So what they do is that they tell you everything, but you should discuss with your doctor how often and how likely all of those is going to happen. And then you also ask about alternatives in terms of surgery, in terms of medications, in terms of diet, like what are the alternatives, what are my choices, so that you can choose wisely. And then I want you to do your homework. Look into internet, read about the medication, read about the surgeries, read about the treatments, and really see if this is good for you, and ask your doctors good questions when you go meet them. And I love it when my patient did their homework, read about the condition, read about the treatment, and they come prepared with lots of questions written, because you should write those in your handbook. Because if you don't write them, like the minute you meet me in the clinic or you go to your doctor, you will forget all of that. So I want you to kind of get prepared and go to your doctor with a plan. And then you always consider the risk of untreated epilepsy and your mood and your quality of life and your driving, all of those things. So untreated epilepsy is a problem, and we should treat it with all the tools that we have. As you can see, that we have many medications, many tools for us to treat epilepsy wisely. And it's my dedication to spread the knowledge about epilepsy, about the brain. So what I did is I'm on social media a lot, and I'm on Instagram, Facebook, Twitter, and I'm very active. I have a YouTube channel. I talk about epilepsy, seizures, and other brain conditions. So please, you can check that out. Reach me on Twitter. This month is very active on Twitter. So every Friday I tweet out, ask me any questions you need about epilepsy and epilepsy surgeon. I have lots of discussions with many patients and families. So please feel free to ask me questions and connect with me for more information. And we'll have any questions, I'll be happy to answer them. Thank you all for listening.
Thank you very much, Dr. Danoun. That was very comprehensive and raised a lot of excellent points. So we'll get to questions shortly, but right now I want to introduce Nancy Serrano, who's a person with epilepsy, who will be sharing her story about and her experiences with this topic. Nancy, can you unmute yourself and share your video?
Well, okay. I started having seizures, let's see, about 40 years ago. I didn't know what they were. They were simple seizures. I just knew something strange was going on with my brain. However, at that time, it was the dark ages, I think, and because I had no experience with seizures, and it progressed, I gotta say. I just let it go. I had other things going on. I had a young family. I lived out of state. I had nobody around, aside from my husband, to help me with this. And so I had these odd feelings for probably 10 years. And I went to an aerobics class and I had a convulsion. And that's when I tied everything together and got started on medication. So that was in 1983. And so I continued trying various types of medications, many of which were mentioned in Dr. Danoun's presentation. Some were okay, some were not. A lot of the side effects of weight gain, tremors, hair loss, kidney stones, kind of you're there, but you're not there, a little spacey, tired, went on. And so I had in 2005, I was driving home from work, and I live in northern Michigan. It was December, and I had a different seizure, one I never had, which it was a complex partial seizure. And I continued to drive through town, and and I drove to the pharmacy because I had to go for another reason. And I called for a tow truck, and well, the police were there, and I had to tell them I had a seizure. I had to stop driving, and I called Dr. Barkley that night and said this was a different one. I've never had it before. I better look into surgery, which I had been avoiding for a long time. And so I went through the process of all the testing, and they have to do a carotid angiogram. And so that spot that they thought was scar tissue from a head injury when I was a child turned out to be an aneurysm. So even though I avoided someone digging in my brain for surgery, someone had to dig in my brain anyway. And I was seizure free after that for 4.5 years. They started up again. And so again, time goes on a little bit, and Dr. Barkley had been mentioning CBD as an option, and boy, I didn't want any of that. I've never even smoked any of that stuff, but I did try it. And I've been seizure free now since 2016. So I'm going on 6 years of being seizure free. I still take my medication, but at a much reduced dose. So that's my story. I didn't get it all into all the guts and glory, but.
Great, well, thank you. And again, for any of the questions that are asked, certainly feel free to chime in with your experience as well. And Dr. Danoon, if you want to turn your mic and video back on as well, we'll answer some more questions.
Yeah, thank you. If you can turn on my video because it was turned off by the moderator. Yes, go ahead. So ask a question.
So another question, I'm going to just read this verbatim. What about children, especially when every med we've tried causes mood side effects? It seems like the burden of trying to avoid side effects is higher with children. Our epileptologist doesn't want to consider surgery for him for reasons, but he straddles the fence on being considered med resistant. Not seizure free for more than a few weeks or months, but what he does have is generally shorter, more easily missed focal absence and myoclonic. So
I got it. So yes, it is sometimes common for children, especially teenagers, to have high sensitivity to medications, especially the medications that cause side effects on the mood. So like the Keppra, the Depakote, all of those can cause mood side effects in the children and cause them to have hyperactivity and all of that. And sometimes there are underlying conditions, like there will be ADHD or autism or behavioral issues that are sometimes unrecognized in those patients, and we should really identify and treat them specifically. But sometimes I agree that sometimes the medications can cause side effects, and every single medication we choose, we have side effects. So the hope is to find an alternative medication that can work, or go for surgery. So surgery will, every single patient is a surgical candidate. Any patient can be a surgery candidate, even if they're having generalized epilepsy, or they can have VNS, they can have DBS. If it's a spot focal seizure, they can have RNS or surgical resection. So it depends on which type of surgery, but definitely every patient is a surgery candidate. And sometimes if the kid and child is having lots of issues to be controlled, sometimes we reach to the epilepsy center and the experienced pediatric epileptologist to manage that, because sometimes it's difficult for those sometimes difficult cases of everything that does not work. Sometimes you need to see the specialist who can tweak some medications, have some combinations that can work for the child.
Great. We have a question for Nancy. How is your overall quality of life now? Do you have any limitations resulting from the surgery or adverse side effects or anything like that?
Well, my quality of life is spectacular. I'm seizure free and I can drive. I can do everything that I always wanted to do. Let's say I am getting older, so things are, I'm not on a roller coaster anymore, but it has all changed for the better. And for me, CBD was the turnaround. I know it doesn't happen for everybody, but it happened for me. And so I'm really, really grateful that it can be used to help with seizures. So.
And just as a follow-up, are you using something like an artisanal formulation or the Epidiolex?
I'm
from something from a provisioning center or is
oh,
it
there is a center. It's in Ypsilanti. It's okay. Essential oil.
Okay.
I've gone to various places, and this has worked out the best. So
great. It's great to hear. Another question that we got, Dr. Nour, is about VNS therapy and how extensive the surgery for that is. How involved is that? I believe it's typically outpatient surgery, right? And then the other question, follow-up question for that is how often the battery needs to be changed.
Yeah, excellent question. So the VNS, I want you like to ask those questions. I know all the single details, so that's why sometimes we send you to the neurosurgeon to go all over the procedure before even deciding if this is good for you or not, if you want to choose it. So the surgery for VNS is an outpatient surgery. So you will come in the morning, we'll put in the device in the shoulder, on the left side, and then we tunnel the wire on the neck, inside the neck, and goes on the biggest nerve. And usually we'll come in the morning, we do the procedure, and then in the afternoon you will go home. So it's an outpatient procedure. And then the battery life is getting better, and really the length of the battery life depends on the settings. So the device is not going off all the time. It goes off for like the initial settings for 30 seconds and is off for 5 minutes. And then if we need more control, sometimes if it does not work, we can increase the amount of electricity discharge and decrease the frequency of that. So in general, on the regular settings, it can last from anywhere between 5 to 7 years, and sometimes some patients can reach up to 10 years on that device. But if the battery dies, it is a very simple procedure, even easier than the original one, because you're not going to the neck with just small incision, local anesthesia, even like you take out the device and then you put in the new one, and that's it. So it's a very simple procedure.
Okay, great. So another question, I know that Depakote has mood stabilizing properties, but a person asked, can Depakote actually cause irritability and extreme mood swings in children? And maybe more broadly, can you speak about like, do anti-seizure medications sometimes have the opposite side effects than what you would typically expect in some individuals?
Yes, excellent question. So Depakote is in general mood stabilizer and antidepressant. However, in children, so as we explained at the beginning, there are multiple keys where the anti-seizure medication can latch on and modulate the seizures. And in children, the brain works a little different than adults. And sometimes it can be the opposite. It can cause irritability. So for example, like ADHD is the kids are very hyper, and the treatment is a stimulant. Like you give a stimulant that's supposed to stimulate the brain, but the issue is that like they have like kind of sleep state issue, and then we stimulate them and then they will be on that natural state. So kids' brain works a little different. And sometimes we have the opposite side effect from the medications. So sometimes it needs educated guess, like see which medicine works best based on the child overall psychiatric and other conditions. And we sometimes, yes, if we run into that, we should always watch for it. And then if it happens, we should reverse the medicine and give something else.
Okay, great. Another question, this is a really tough one, but why are some seizures med resistant, and it takes many or a long time to find the right one? Do you have I guess any thoughts on potential mechanisms behind drug resistance?
Yes, there are Yes, unfortunately, 30% of the seizures are drug resistant. I tell them, my patient, there's like a breed of epilepsy and seizures that are just medically resistant, like difficult to control. This is like the bad kid that you have, or like, like some kind of different to control seizures. Why this happens? There are multiple mechanisms why this happens. Sometimes the most important one is that they are having this, the cells are kind of completely disconnected from the system. They are not connected to the normal, and everything they do is just cause seizures. So if they're not busy with normal function, they will just cause noise, and then they will cause seizures. Sometimes the seizure focus, the spot of the seizure, can induce, like, it is very, very like weird mechanism. They can induce channels that can pump out the seizure medicine. So you're giving them the seizure medicine from the right hand, and it will just pump it out from the left. And those are channels that can happen. And then sometimes the epileptogenicity and genetic predisposition, the genes of the body can be excited more, and the channels that are supposed to control the seizures are not well established, and the medicine is not latching on them. So because the medication will just like recognize an area, so and latches on it and kind of tweaks the key and socket. If there is a genetic change, then the medicine will not latch on, and that will cause medication failure. And those are the patients that we want to identify early. I don't want you, if you have seizures that are not controlled, I don't want you to suffer multiple years and just keep, okay, let's try Keppra, let's try Depakote, let's try Lamictal. We did not try this medication. Don't do that. Just directly call the epilepsy center and get evaluated for a surgical treatment, because we know that if 2 medications do not work, the chances of the 3rd to the 5th to the 10th medication is less than 1%. So just wasting time with many medications is not the right way to go. We need to go for the surgical treatments. And we talked about how the surgery is safe and effective.
Okay, great. Another person was taking Depakote and clonazepam for assistance with non-epileptic seizures, presumably for, again, mood stabilizing and anxiety reducing properties, but asked if those can be used for seizures only, and the quick answer is yes, those are commonly used anti-seizure medications. So we'll move on from that one. So
let me just touch on that just quickly. So seizure medications in general are used for multiple conditions, not just for epilepsy. As I was explaining, that the background of the patient is very important. Seizure medication can treat headache, can treat trigeminal neuralgia. Like, it modulates the brain, it can attack multiple brain conditions. So non-epileptic seizures, sometimes there are networks. So non-epileptic seizure is a real condition. It's not just taking it, or like, there are networks imbalance in the brain, and medications can restore the network back to baseline. And I had very good success with Lamictal, which has much less side effects than Depakote, that can help modulate the brain activity and help with those non-epileptic seizures along with therapy.
Great. One other question I have is, because I haven't been able to find this in the literature, is like, overall across all anti-seizure medications, what percentage of people would you say in monotherapy have some sort of side effect? Like, how likely is it that you're going to have a side effect when you start an anti-seizure medication?
Yes. So side effects are dose dependent and time dependent. Means that at the beginning, almost everyone will have some side effects. Like the tight shoe analogy, everyone will have some side effects at the beginning. The majority will go away with time. So if they are on monotherapy, about like 80% of people roughly will have no side effects, and they will be tolerating the medicine very well on the long term. 20% they might have some side effects that are dose dependent. Means that if they are seizure control, you decrease the medicine a little bit, things will be good. And the more medications you have, and the other medications that the patient have, or the other conditions they have, then side effects can accumulate with time.
Okay, great. And one other quick question, what advice do you give patients overall when changing meds?
Yes, very important, because we're talking about medication side effects, and you experience them, you might change. So the advice is that do not abruptly stop any medication. So what the advice is that we have overlap always. So we start the new medicine, we start building it up, and then once we have a reliable dose of the second medication, then we start decreasing the first medication. So there has to be some overlap area. But the thing is that the only time we have to abruptly stop the medicine if we have serious reaction like Stevens-Johnson syndrome or like some reaction on the heart or something on the bone marrow, that we have to stop it abruptly, but always make sure to stop it gradually.
Okay, well, thank you so much. We are out of time, so thank you very much, Dr. Danoon and Nancy, for a really thorough and enlightening conversation. Okay, welcome to the session, Managing Epilepsy and Associated Neurological Conditions. This session is sponsored by Children's Hospital of Michigan. Once again, I'm Russ Derry, Director of Education for the Epilepsy Foundation of Michigan. And we're pleased to have as our presenters today, Dr. Lalitha Sivaswamy, who's a pediatric neurologist from Children's Hospital of Michigan, and Dr. Rohit Marwar, an epileptologist from Detroit Medical Center, Wayne State University. So again, thanks for everyone for joining us. And Dr. Sivaswamy, if you want to go ahead and get us started, that'd be great.
Hello, everybody. Good morning. I am just going to start sharing my screen. And let's see. All right, I think we're in business. So good morning, everyone, and thank you for spending part of your Saturday with us today. I want to thank the Epilepsy Foundation for organizing this really important conference, and especially Mr. Derry and Renee for suggesting this topic, which I think is a very important one for families, for children, and of course for neurologists. So I'm going to start off the session by talking about the comorbidities of childhood epilepsy and how we can address these issues in children who have epilepsy and these associated conditions. I am a child neurologist. I work at Children's Hospital of Michigan, by the way. I have no financial conflicts of interest. I'm not showing any personal photos of my patients. So children can be diagnosed with epilepsy anywhere from the day of birth up to when they're a teenager and of course beyond. And as this graph shows, there's a kind of U-shaped curve to when individuals are diagnosed with epilepsy. It's of course high in the first year of life and the first few months of life, but it remains high almost for the first 5 or 10 years. And then there's a dip in your 20s and 30s. And once again, there is an increase in the incidence and prevalence once an individual reaches the 7th decade of their life. And there are several causes for childhood epilepsy, and just as a little overview, I'm just going to mention some causes just because there can be an association with the condition which causes epilepsy and some of these comorbidities. And by the way, just to talk about the word comorbidity, I just feel that it's worth spending a few minutes talking about it. So basically, comorbidities are two medical conditions that can exist simultaneously in an individual or in a child, but they need not be present simultaneously. They can also follow one after another, and that would still be considered a comorbidity. So in other words, there's not necessarily a cause and effect relationship, but there can be an association. And this association becomes very important when we're trying to address the quality of life for these children, and also for the family, because when a child is affected, the entire family is affected. So going back to causes of epilepsy in children, this is a picture of a child who's got the typical appearance of tuberous sclerosis. Okay, let's see. This is a child who has a brain malformation called lissencephaly. And as we can see, this child's brain doesn't have the typical peaks and valleys, which a brain should have. It's very smooth. So it's a very smooth brain, which predisposes to epilepsy. This is a child who appears to have some type of bleed or some type of lesion over here that's pushing the brain to the other side. This is a child who's had multiple strokes on their MRI, probably predisposing to epilepsy. So as we can see, there are several causes for childhood epilepsy, and sometimes it's obvious, like in these pictures and in these scenarios, but oftentimes it's not. And I have parents who come up to me and say, hey, my child had an MRI and it was normal, and even the EEG was normal. And that's not necessarily a rare situation. So one of the big causes for epilepsy, and we're unearthing more and more of them nowadays, is what we call channel disorders or ion disorders. A classic example is a sodium channel disorder. There's one called Dravet syndrome. Some participants or their children might have Dravet syndrome. And of course, there are many other channel disorders. There are some associated with potassium channels and chloride channels. And nowadays with the with the advance in genetics, we're identifying many more of these disorders. And of course, there are genetic syndromes that predispose a child to epilepsy. A classic example is, of course, Down syndrome. And another example would be autism. And interestingly, even when the etiology or the cause of epilepsy cannot be identified, children with epilepsy do have a higher incidence of these comorbidities that we're talking about. So sometimes it's obvious, for example, you see the MRI and then you say, oh, this baby has a brain malformation, or this child has a brain malformation and she has epilepsy. And one would expect the child to have a learning disability or some delays. But sometimes the MRI looks perfectly normal, and yet there are some comorbidities which significantly impact the child's day-to-day functioning. And that is going to be the gist of my talk today. What are these comorbidities? How can a child and their parent identify them? How can they bring them to the notice of the neurologist or their pediatrician? And how can they be addressed in a manner that would basically make the child function optimally at home and at school and in their social environment? So these are some common comorbidities associated with epilepsy. The top half, with the picture of the kiddos is what I see mostly. The bottom half will be addressed by Dr. Marwar in his talk. So some of the comorbidities that I see are ADD and ADHD. Children with epilepsy do tend to have a higher prevalence of that. And of course, when you have it as a child, it can continue into your adult years as well. I have several fathers who say, you know what, I had the same issues when I was young. I was always busy and restless, and I see that in my son. And I say fathers and sons because it tends to happen more in boys, or at least it's identified more in boys. Other comorbidities can include migraine. Children can have learning disabilities when they have epilepsy. They can have other behavior issues, of course, autism. And, one of the comorbidities is cerebral palsy. And finally, I put SUDEP at the bottom. I will, of course, not be talking about all these comorbidities in the interest of time, but I'll just try to touch on some of the ones which I think are really important for families, children, and neurologists to recognize. So those are the adult ones. So when we talk about, these comorbidities or these associated neurological or psychological or psychiatric conditions, we often say there's a bi-directional relationship. And I just put this to show that, individuals with epilepsy, children with epilepsy have a high incidence of migraine. We know that. We also know that people with migraine have a higher incidence of epilepsy. So again, it's not like one is causing the other. And furthermore, to complicate the picture a little bit more, children who have both these conditions also have a high incidence of anxiety disorder. And vice versa. Those with anxiety, pre-existing anxiety disorder tend to have a higher incidence of epilepsy and migraine. So as you can see, these relationships are fairly complex. It's difficult to pinpoint exactly why a child who has one or the other tends to be predisposed to the third. Nowadays, it's thought to be a network issue. Epilepsy is now considered, not so much of a electrophysiological condition, but it's more not so much a chemical imbalance, but more of a abnormality in the network of the brain. And probably the same networks that predispose you to epilepsy might also predispose the child to migraine or anxiety disorder or some of the other conditions. So the first condition I'd like to touch upon is ADD or ADHD. Interestingly, boys who have epilepsy are often promptly identified when they have ADHD. That's because these children are often, kind of the busy, the restless child, the one who is always running around the classroom, the one who the coach always has to say, Billy, stop doing that, we're now doing this. So, they tend to rise to the surface. So parents, often realize that there may be a problem with the child. On the other hand, when a girl has ADD or ADHD, she may not be identified promptly because girls tend to fall more in the ADD spectrum, the attention deficit spectrum. So they tend to be quiet, they're zoning out, they're not paying attention to the classroom, and they're disorganized, but they're not necessarily coming to the attention of the teacher or the caregiver. So they tend to be ignored rather than be identified. So, when parents say, my child who has epilepsy is struggling at school, one of the things I often bring about is, could your child have ADD or ADHD? And sometimes, the parents will give us a history that's very typical, and they might bring in notes from the teacher or from the piano teacher or, from a neighbor who's watching their child or from a grandma. But many times, it's helpful to have objective measures as opposed to just the, subjective, description of symptomatology. So we will sometimes use the Vanderbilt questionnaire for the parent. There's also another one called the Connors questionnaire. And we also have Vanderbilt questionnaires for teachers. So I will give 3 or 4 to the mom or the dad and say, hey, can you give it to one of each of his teachers? And I find that the lunchroom teacher is often a very important person because, she or he can identify some of these symptoms because the child is in a more informal setting. And the first 8 questions or 9 questions are related to ADD, and the rest of them are related to ADHD. There's a scoring mechanism, you add it up, and you and the mom or dad, the parents can then discuss it with the neurologist or the PCP, in fact. There are several other questions included in the questionnaire, and those are more related to oppositional defiant disorder or conduct disorder. So how do we address it when a child has ADD or ADHD? When it's a young child, I like to start with behavior therapy. And sometimes the behavior therapy can be what we call play therapy. It could be cognitive behavior therapy, CBT, making the child aware of how they need to behave in certain social situations. And sometimes we have to address parenting skills. Oftentimes the parents are annoyed by the child who seems to be demanding so much more attention and time. And I'm a parent and I totally understand how it could be draining and how parents can experience some distress because of that. But sometimes we do have to use medications or drugs as well. As the children get older, beyond the age of 6 years, I sometimes will bring up use of drugs. And the drugs can either be stimulants or non-stimulants. Examples of stimulants can be methylphenidate type derivatives. And examples of other stimulants can be amphetamine type derivatives. And there are several non-stimulants also out in the market. There's one called atomoxetine. There's one called guanfacine. There are different trade names. I'm not going to use them, but there are several options for them. And, when a child is placed on a stimulant, oftentimes there is some anxiety on the part of the parents that maybe the stimulant may exacerbate their epilepsy. And most studies have shown that that's not necessarily true. You can have a child who has epilepsy on a stimulant and be able to tolerate it very well the vast majority of times. So what is the optimal treatment? Again, it's the dialogue between the parents and the neurologist, between the child and the neurologist, especially as the child gets older. And I'd like to point out that about 20% of children who have ADD and ADHD might also have what we call oppositional defiant disorder or conduct disorders. And those are probably best addressed by a mental health professional, such as a child psychiatrist, in conjunction with the neurologist. Now, I'd like to mention that certain epilepsy drugs can exacerbate ADHD type behaviors, and a classic example is levetiracetam in my personal experience, and sometimes phenobarbital, which we're moving away from. Now, this was an interesting paper I saw. It is from 2018, and I would like to make a disclaimer that it was very well written. It is a well-researched paper, but my personal experience doesn't necessarily correlate with this. They made a list of drugs which have negative effect on behavior, list of antiepileptics, and they mentioned, of course, phenobarbital. And then they had valproate, but in my experience, actually, valproate can be a mood stabilizer. It can have a positive effect. And then the second column, they had drugs with a positive effect on behavior, and they said lamotrigine, which I totally agree with. It is a wonderful drug, both for epilepsy and for mood. And finally, in the third column, they had neutral or unknown, and they had levetiracetam, which in my experience actually at least a third of the time seems to exacerbate busy behaviors and aggressive behaviors. But this just goes to show that every individual is unique, and what can cause a negative effect in one child may actually not be bothering another child at all. So, you know, we really have to sometimes, I hate to use the word trial and error or the phrase trial and error, but sometimes it does boil down to that. The second comorbidity I'd like to discuss with the help of this little vignette. This is a 7-year-old who's got benign Rolandic epilepsy. And so she tends to have seizures at night. She wakes up, she's drooling, she has her typical seizures. The parents say, well, we don't want to treat because, you know, the episodes are only happening at night. They never happen during the day. Which is fine. And then the parents come 6 months later and she's got episodes of dizziness. She kind of walks like she's drunk. She's holding on to walls. She looks very pale during the episode. She begins to vomit. And now the mother begins to question whether these episodes, which happen during the daytime, are actually seizures. And that's a very valid question. That brings us to the topic of migraine and epilepsy. So this child probably does not have daytime seizures. Just from what the mom is describing, this actually sounds like a type of migraine. So migraine is, of course, you know, caused by, again, a chemical imbalance in the brain and the release of certain neurochemicals in the brain. And this is a picture of how we used to think of migraine, though now how we think of it is a little bit different. But migraine and epilepsy can often be confused with one another. And physicians, parents, and sometimes even the child may not be able to differentiate. For instance, children with migraine often have a feeling of confusion before the episode or during the episode. And of course, children with epilepsy can feel that way. They can be vomiting during or after a migraine, and so can children with epilepsy. Many times there is slurring of words. The parent may say, the child seems out of it. My child seems confused and vacant during these episodes, which of course can happen during seizures as well. And sometimes the visual changes of migraine or the aura of migraine can be confused with the aura of a seizure. So as we can see, there's a lot of overlap in symptoms, which can of course lead to confusion. But many times children with epilepsy, when they come in, when I ask questions about headache and when I ask some of these associated questions, they say, oh, okay, so maybe that's what it is. Maybe it's migraine. Once again, there's a bidirectional relationship. Children with migraine tend to have epilepsy. Children with epilepsy tend to have migraine. Now, how do we treat that? Well, this is just a schematic representation of the different chemicals in the brain. This is an astrocyte. This is a neuron. So the neurons are what cause seizures. And these are some of the chemicals that can play a role. And I just put this in because, you know, the same drugs that can be used to treat epilepsy are often helpful to treat migraine as well. So for instance, here we have topiramate, valproic acid, great antiepileptics, great migraine meds. Gabapentin, not a very good antiepileptic, but great migraine med. We have lamotrigine, can be used for both. So oftentimes medications that are preventative for epilepsy can also be preventative for migraine. So hopefully we can kill two birds with one stone, but sometimes that's not possible and we have to choose other drugs as well. But the treatment of migraine can greatly enhance quality of life for children and families, and the parents don't have to go pick up the child from school as much. And I think, you know, addressing it is very important. Now we'll go to some of the learning challenges that children with epilepsy can face. And I think this is a really complicated topic, but I just kind of put in some different bubbles as to how I view it. So when a mom or dad comes in with their child, or when the child says, Swami, I'm having a really hard time at school, I try to bring up each of these factors. Is the child attending school, or are they absent so much because, they're afraid they're going to have a seizure, or are they having so many seizures at school that they don't feel comfortable going anymore? Does the child have cognitive impairment? Does the child have sleep issues? Maybe the child has obstructive sleep apnea and is so sleepy during the day that they can't participate in school. Or as we talked about, does the child have autism or ADD or ADHD? Or is it the medications themselves that are making the child feel a sense of lethargy, a lack of enthusiasm for school? Or is the child embarrassed to go down to the office in the lunch break and have to take their seizure medication? So it could be any of those. But I'm just going to talk a little bit about learning disabilities. So learning disabilities are interesting, and they're just something that we've recently recognized, say in the past maybe 30, 40 years. And these are children who have a normal IQ. So when you test them formally, their IQ is, between 95 and 110 or 120, which is the normal range. Some of them actually even have a high IQ, but nonetheless, they seem to struggle with the schooling system. And when the child sits down with the mom or dad at home and they're discussing and doing homework, the mom says, yeah, that's right, he does understand the material. I just have to keep repeating it. But at school, they seem lost because there are 40 kids in the classroom. They don't seem to be able to keep up with the rest of the children. And these children may have a learning disability. So what is a learning disability? A learning disability is when there are specific types. For example, there's one called dyslexia, where letters seem reversed. Numbers seem reversed. Words just seem to run into each other. So for example, they may have difficulty with pronouns on and in. They may have difficulty with genders, he and she. The book is underneath the table, but they're looking for the book on top of the table. And that can translate to difficulties with comprehension. It could be a math disability called dyscalculia, or it could be difficulty with writing called dysgraphia. And of course, there are several other types. But these can all be identified by specific and formal neuropsychological testing. And usually the treatment for learning disabilities is not so much medication, but it's addressing the individual issue, probably having an IEP or a 504 plan at school and discussing it with the teacher so that she understands what the challenges for this child are. And by the way, many successful individuals in the corporate world, in the medical world, potentially do have a learning disability, but they can overcome it by other mechanisms. Now I'd like to talk a little bit about autism in children with epilepsy. And, as we said, children with autism have a high risk of developing epilepsy, and usually their seizures tend to come on at puberty. So I have quite a few boys with autism who are perfectly fine till they were 12, 14, and then the seizures begin to start, causing a lot of anxiety in the child and the parents. But some of my younger children, like, between the age of 2 and 8 who have autism, the parents will say, I think my child also has seizures. And of course, we take that very seriously because we understand the association. But some of the features that the parents are describing, or some of the mannerisms that they're describing, is just that child. It's just unique to that child. It's that child's manifestation of their autistic stereotypies. For example, some children with autism tend to have staring spells. They can have periods of rapid eye fluttering. They can have unusual hand movements, such as hand flapping or, like body rocking type movements. They can have different types of facial grimacing, which a parent may mistake for seizures. I'm very careful when I have a child with autism in the sense that I don't jump into doing EEGs and further testing, because sometimes those tests come back abnormal, not because the child has epilepsy, but just because the child has autism. So it's important that, we kind of differentiate the two and not be over ambitious in terms of treatment. But there are some good FDA approved drugs that can be used in children with autism and epilepsy together. And usually the ones that we try in child neurology are what we call the atypical antipsychotics. So risperidone or aripiprazole. Valproate is a great drug for epilepsy and some of these autistic features. Some children with autism also have ADD and ADHD as another comorbidity to add another layer of complexity. And sometimes I'll talk about stimulant medications. But again, when a child has autism and epilepsy, I'm a little bit more circumspect about starting stimulants just because sometimes it can have a paradoxical effect. The child can become very irritable, moody, emotional, and sad. And of course, you never want the cure to be worse than the underlying condition. Clonidine is another drug that I use quite a bit in my children who have autism and epilepsy together. Finally, in my last few minutes, I would like to just bring up a sobering topic. It's not a topic that neurologists or physicians necessarily like to bring up with families, but I feel strongly about it that we do. I'm always kind of conflicted as to when in the disease process I should bring it up. I feel a little bit sensitive about bringing it up in front of the child when the child is present. So oftentimes I'll just bring it up with the parents first and see if they can discuss it with their child in a, maybe in the home environment, in a nurturing, loving way. And Cameron Boyce was a Disney Channel star who passed away from epilepsy in 2019. And his death was attributed to what we call SUDEP, which is sudden unexpected death in individuals with epilepsy. Fortunately, it's rare. In children, it's probably 1 in 5,000 or 1 in 4,500. So it is a rare condition. But nonetheless, I think it's important to discuss it. And in fact, just recently, I read a very interesting survey. I think it was done in France, where they surveyed child neurologists and adult neurologists, and they said, hey, how often do you bring it up? And I think the response was like 50 to 60% of times. And then they surveyed the parents or the individuals with epilepsy, and they said, hey, there's this condition called SUDEP. How often do you wish that your neurologist had brought it up? And almost universally, all the parents and patients and even children felt that it was an important topic to discuss. So SUDEP is not really related to trauma. So it's not related to the fall, which you can experience from epilepsy. It's not related to drowning or anything like that. Usually these individuals are found face down at home in their bed. And so it was thought to be maybe a arrest of breathing, or maybe it is, their heart stopping just after a seizure or during a seizure. It may be more common in children who have severe developmental issues or children who have underlying conditions, those who have long-standing epilepsy, and maybe those who have refractory epilepsy. So refractory epilepsy is when it's hard to control despite using a couple of different seizure medications. Maybe children who have generalized tonic-clonic seizures are more likely to have it. Again, the literature about this is kind of sparse just because, it appears to be this enigmatic entity that is really hard to study. So just concluding my portion of the talk, I think it's very important that parents and children who have epilepsy bring up some of these comorbidities if they think that it's affecting the child's quality of life. Sometimes I will kind of, directly bring up these topics, ask about school, ask about ADHD, depression, migraine, but sometimes I don't. But I really appreciate it when a parent brings it up and says, hey, I'm noticing this about my child, and, he's not doing as well in school as he should. Is it because of the epilepsy, or is it because of something else? And we're always available to provide guidance regarding treatment options. Treatment doesn't necessarily have to be adding another medication. Sometimes the treatment can just be maybe biofeedback, seeing a psychologist or therapist. And I think what is most important is that we should help our children become aware of these conditions so that they go forth in life becoming confident that they can live life on their own, that they can, rise to their full potential. I think that's really important for every child with epilepsy to feel. These are just examples of the different children's hospital locations. I really love the Lego building in Troy. I will stop at this point, and I will request Dr. Marwar to take over. Thank you.
Hello, everyone. Good morning. Thank you for being here and listening to our talk, and thank you to Epilepsy Foundation of Michigan for providing us this opportunity to discuss these topics with you. So as we mentioned that I am an adult epileptologist, so all the different associated neurological conditions or comorbidities that I will be talking about it's from the perspective of someone who treats adult people, but much of this information is also applicable to children. So we're going to talk about epilepsy and all the different comorbidities and conditions that come with that. And these are all the different things that we will be talking about. Let's start with cognition. So I think it's important to understand what cognition is. Many times we just think of cognition as a loss of memory. That is, misplacing things, forgetting conversations, forgetting tasks. But there is so much more to cognition than just memory. So it also includes different domains such as executive function, which means planning and being able to carry out certain tasks such as cooking. It also includes visuospatial skill, like if you lose that, you might get lost while driving. Attention, like getting easily distracted by something, not able to focus on something. Language, whether it's difficulty comprehending something, something that is being said to you, or having word finding difficulties. And finally, orientation, like being confused about what day it is or where you are and so forth. So as you can see, cognition includes all of these different things and not just memory. Now, with regards to cognition and epilepsy, or cognitive impairment and epilepsy, you could broadly differentiate into two different types. One would be reversible. That is something that can be reversed, that can be improved on. And common causes of reversible cognitive impairment would be medications. So some medications such as phenobarbital, topiramate, and zonisamide, they can cause memory problems or cognitive problems, and stopping these medications will reverse that cognitive impairment. And the second would be anxiety and depression. So if you have uncontrolled anxiety and depression, it will also affect your memory, and treating that will help improve the memory. The more kind of important one is the progressive type of cognitive impairment, and this could be because of the type and frequency of seizures that you're having. So if you're having frequent seizures, if they are intense seizures, if you have temporal lobe epilepsy, all of these are known to cause cognitive impairment. And the more important, I think, the topic to discuss, and which I will discuss in the next few slides, is dementia. Now, dementia is a condition which is a progressive neurodegenerative, and what we mean by that is that the brain gets degenerated because of deposition of abnormal proteins. And there is a bidirectional nature between epilepsy and dementia. There is a lot of evidence now that these are two related very closely with each other. And when I say bidirectional, what I mean is that people with epilepsy are 5 times more likely to develop dementia. Now, dementia are different types. I think the most common one that everyone might have heard is Alzheimer's disease. And so most of the research in this field has been in Alzheimer's disease. So people with epilepsy are 5 times more likely to develop dementia. Conversely, people with dementia have a higher risk of developing epilepsy, and this risk is anywhere from 1.5% to 16%. And that is actually a lot more than what you would see in general population. There is also a lot of evidence now that seems to tell us that when someone has epilepsy and dementia together, the dementia tends to start at an earlier age as compared to someone who does not have concurrent epilepsy. So if the x-axis here is the age and the y-axis is the cognition or memory, at some point in dementia, the memory will become impaired, as shown by the black arrow. And there's a lot of evidence that shows that for whatever reason, the seizures also tend to start around the same time when the memory starts. So there's a very close connection between these two disorders. So someone who has chronic epilepsy and then develops dementia, what are the things that you can do to prevent or manage it? So prevention would be minimizing the seizures. So if we know that having seizures again and again will lead to inflammation in the brain, and that will lead to abnormal protein deposition, and then that will lead to dementia. So preventing dementia in epilepsy, the first thing is to minimizing the number of seizures that someone is having. The next important thing is screening, and screening early. As we discussed, people can start developing symptoms of dementia much earlier as compared to general population. So screening for memory problems early and screening often is important. Treatment, so avoiding medications that can impair cognition further, such as phenobarbital, topiramate, and zonisamide. So these would be the medications to avoid in someone who has epilepsy and dementia together. What about someone who has dementia and then develops or is at the risk of developing epilepsy? To prevent is prevention is done by controlling the vascular risk factors. So these are your diabetes, high cholesterol, high blood pressure. So if you control these vascular risk factors, there is less likelihood of developing epilepsy in dementia. Again, screening is important. And here, this is where the information from the caretakers or the family members is very important. You need close monitoring by family members, because in dementia, sometimes you can have fluctuation, like one day is good, the next day is bad. But if they're having seizures, there will be rapid fluctuation, like the confusion improves and worsens from hour to hour. So if that is something that is happening, then that needs to be communicated to the physician. And in someone with dementia who develops seizures, the long-term EEG, like EEG that is done for a prolonged period of time, is more important to capture the abnormalities as compared to a shorter 20 or 30-minute EEG. Treatment, again, avoid medications that can impair cognition further. We have some recently published evidence that levetiracetam, which obviously is a very commonly used medication for seizures, also might have some disease-modifying benefit in dementia. That is, it actually reverses some of the cognitive changes in these patients. So definitely in my practice, levetiracetam is the first choice medication for someone who has both dementia and epilepsy. As I mentioned, screening is important. And these are a couple of screening measures that we use in our clinic almost on a daily basis. So on the left is something called an AD8 dementia screen. This is a subjective report of the patient or the caretaker about how their activities of daily living are going, how is their thinking and memory. And on the right is a rapid cognitive screen, which the physician does. It's a very quick test about memory. So what we have found, and I kind of specialize in this, is that we, in our unpublished data, and this is patients who have never been diagnosed with epilepsy, dementia, and they are age 55 and older, almost half have subjective complaints of memory, and they have never been, this has never been discussed with them before. And almost 70% actually have objective evidence of having memory problems. And these are not trivial numbers. So these are huge numbers that are still going unaddressed. And actually around half of the people who did not think they had memory problems on the left screen, the left AD8 screen here, actually had abnormal memory on the objective testing. So this is something that is still not completely developed, and something that I'm looking into, but very fascinating and definitely important to treat, because as you might have heard in the news, there is a controversial new drug for Alzheimer's disease called aducanumab, which is possibly disease modifying. That is, maybe it can reverse the changes of Alzheimer's disease, but it can only be used in very mild or early process of Alzheimer's disease. So again, screening is important in these people so that we can identify them early and provide them with a plan for further management. Let's move on to the second topic, which is anxiety and depression. And Dr. Swamy touched on this briefly, but anxiety in general population is around 6%. In people with epilepsy, it's around 20%. Depression in general population is 11%, and people with epilepsy is around 30%. So again, there's a much higher risk of developing anxiety and depression in people with epilepsy. So why does someone with epilepsy have these anxiety and depression? So one cause could be seizures. Just the repetitiveness and the unpredictability of having seizures provides stress. The recurrent act of having seizures changes the neurochemical structure. And as Dr. Sivaswamy mentioned, it actually might be the underlying networks which are responsible for both seizures and epilepsy. It could be because of the cause of the epilepsy. So a common example is someone has a frontal lobe stroke, which is causing epilepsy, but frontal lobe strokes are also known to cause depression. It could be because of the medications. So there are a fair number of medications that can actually worsen anxiety and depression, and these are levetiracetam, topiramate, zonisamide, phenobarbital, and perampanel. And lowering the dose can help, but sometimes you have to stop the medication. Some have a positive effect on these symptoms. So lamotrigine, carbamazepine, and valproic acid. I have sometimes realized that actually when I stopped these three medications for whatever reason, I have unmasked the anxiety and depression that was being controlled by these medications until then. The fourth main reason for having anxiety and depression would be, socioeconomic, loss of driving, loss of job, the stigma of having epilepsy, and being dependent on others. Again, screening is important because I have realized that patients don't really offer that they're feeling sad or anxious. I think the physician has to ask specific questions, and I have to ask them again and again. And it is also imperative that screening is performed at every visit. So these are two common tools that we use, and AAN and American Epilepsy Society both recommend using these simple screening tools for anxiety and depression. On the left is a tool called GAD-7 for anxiety, and on the right is a tool for depression called NDDIE. And both of these are very simple. It takes less than 1 minute for a person with epilepsy to complete these. Well, treatment. So, the gold standard would be, again, a cognitive behavioral therapy. It's a type of psychotherapy, and I think all of us realize how difficult and how much less resources we have for psychotherapy in the community. But I think one silver lining from this pandemic might be that a lot of the psychiatric and psychotherapy practices are not doing telehealth, and the barrier to entry and the barrier to receive this care has decreased substantially. So psychotherapy would be one modality of treatment, and obviously we have medications that can be useful. At least in my practice, I always request the patient to see both the psychiatrist and therapist, because you don't know which one of these two modalities the person with epilepsy might agree with. But sometimes they are resistant to go, and in that case, I will start them on a medication if they are agreeable to that. Third topic is epilepsy and stroke, and again, there is probably a bidirectional nature here. It's very easy to think that stroke will cause epilepsy. In fact, 6% of people who have stroke will develop epilepsy, and in fact, stroke is the commonest etiology of epilepsy in older adults. But there is also now increasing evidence that epilepsy, in fact, might increase the risk of stroke by 2 to 3 times. And the hypothesis behind this is not very well established, but it might have to do with medications. It might have to do with epilepsy causing some kind of vascular inflammation that leads to stroke. So epilepsy and stroke can be broadly divided into 2 kind of types. So early is a seizure that happens within the first week of having a stroke, and late is a seizure that happens after 1 week of having a stroke. With early seizure, the risk of a second seizure is around 30%. So not a huge risk, but not a minimal risk also. And this actually does not fulfill the criteria of having epilepsy or starting someone on a medication. But I see that most of these patients end up being started on an anti-seizure medication anyways. And then these need to be stopped later on as outpatient. With late seizures, the risk of a second seizure, so if you have one seizure more than 1 week after having the stroke, the risk of second seizure is very high. It's 70%. And that does meet the criteria for a definition of epilepsy and also for starting medications. The question is then, which medications to use in someone with seizures and stroke? I think the more important question is which medications not to use, and avoiding older enzyme-inducing anti-seizure medications, which are phenytoin, carbamazepine, and phenobarbital, are very, very important, I believe. And the reason is that these medications decrease the level of medications that are used to prevent stroke. So someone who has had one stroke is at a high risk of having a second stroke. And to prevent that second stroke, they get started on blood thinners, medications for cholesterol, medications for high blood pressure. Now, these older seizure medications can actually decrease the levels of these medications to prevent stroke. And so you can imagine that leads to higher incidence of having stroke. Independently, they can also increase cholesterol level, and that increases the risk of having subsequent strokes. And there is also some evidence that they are less effective than newer anti-seizure medications to prevent seizures in stroke. So all the more reason to avoid these older medications in stroke. The next topic is epilepsy and traumatic brain injury. So again, like stroke, these are differentiated into early, where a seizure happens within the first week of having a traumatic brain injury, and late, where the seizure happens after 1 week. If it's early, the incidence is between 4 to 25%. With late, it's a slightly higher incidence. The risk factors for early are coma, which is equivalent to having probably a severe traumatic brain injury, and younger age. Now, in epilepsy, our goal usually is to prevent the second seizure or the third seizure or the fourth seizure, right? And that's why we start medications. But with traumatic brain injury, we do what's called a primary prevention or a primary prophylaxis. And so a lot of these patients get started on medications to prevent the first ever seizure. And these medications are given only for 1 week. The recommendation is for phenytoin. These are the national or the standard recommendations. But what I see in clinical practice is that most of these patients end up getting started on levetiracetam, possibly because it's easier to use levetiracetam than phenytoin. With late seizures due to traumatic brain injury, the overall management and medication choice is as any other type of chronic epilepsy. Next topic is sleep disorders. And this is especially difficult to diagnose because the person with epilepsy will not be forthcoming about this many times. And they might not even realize it themselves unless it's brought up. So the two main types of sleep disorders are insomnia and sleep apnea in epilepsy. But the person with epilepsy might just say that they are having fatigue and they're tired. And fatigue is such a non-specific symptom. It can be because of so many different things. So you have the physician really has to tease out why they are having fatigue. Regarding insomnia, it can happen because of epilepsy-related stress and anxiety. Rarely, if someone is having frequent seizures during the day, people tend to take a nap after the seizure, and then that will lead to insomnia. Up to 50% of people with epilepsy will have insomnia. That is a big number. And you can imagine not getting good quality sleep will worsen your seizure control. It increases the risk of depression, and it worsens your quality of life. Now, there are a lot of different options for treatment. The simplest option is sleep hygiene, and this is something that I always recommend to my patients. Simple things. So, taking a warm shower before you go to bed, avoiding screens a couple of hours before you go to bed. If you are in bed and not able to fall asleep, get up for 15 minutes or so, get up, do something else. Your brain needs to associate the bed with just sleep, and that's it. And come back to bed only when you're ready to fall asleep. If this doesn't work, then the standard treatment for insomnia, or the gold standard treatment, is cognitive behavioral therapy. And if that doesn't work or is not available, there are always medications that can be tried. With sleep apnea, obstructive sleep apnea is the commonest type. It's again present fairly commonly. For some reason, it's much more common in males as compared to females. It's seen more commonly in older age, and the risk seems to be the same regardless of seizure type or control or the number of anti-seizure medications. Again, screening is important from the physician standpoint, that they have to ask specific questions, why someone might be tired or sleepy, and then that might lead to a possible diagnosis of sleep apnea and referral to a sleep specialist. And CPAP is the treatment for the sleep apnea. This is the last topic I want to talk about, fatigue. Almost 50% of people with epilepsy meet criteria for fatigue. And fatigue is such a common thing that we see in a lot of people with epilepsy, right? I mean, overall, fatigue is probably the commonest side effect across all anti-seizure medications. But it's surprisingly, it's also something that there is not a lot of research on, which is very surprising to me. The risk factors that we think that lead to fatigue are poor sleep quality, which is understandable, uncontrolled anxiety or depression. It's unclear if epilepsy type, frequency of seizures, or anti-seizure medications are risk factors for fatigue. Especially the anti-seizure medication relationship to fatigue is a little surprising, given that it's such a common side effect. So how do we treat or manage this? I think first of all, again, the physician has to be mindful that this can happen and needs to ask specific questions. A screening tool is always helpful. This is the screening tool that we use very commonly in our practice to diagnose or to at least screen for fatigue. And then you can manage. You can ask for further questions about why they might be having fatigue, and there are so many reasons to have fatigue, and manage it accordingly. This is my last slide. So, we talked about a lot of these different topics, right? And there is a clear relationship between some of these. So the traumatic brain injury will lead to epilepsy. Epilepsy will lead to anxiety and depression. Epilepsy and anti-seizure medications will lead to fatigue. I think these are kind of clearly established relationships. We talked about sleep disorders, right? Epilepsy, someone with epilepsy is at higher risk of having sleep. And then sleep can definitely, if you have poor sleep, that can definitely worsen seizures. Then there's a clear bidirectional nature between epilepsy and cognitive impairment, that is dementia, and epilepsy and stroke. However, what we didn't get a chance to talk about, and what actually makes this topic so complex, is the relationship between all of these different comorbidities. And that is where it's very important to talk to your physician, bring up the different symptoms that you're feeling, and then the physician can parse out, okay, what is important, what might be what the fatigue might be because of, what the memory problems might be because of. It's something that, because there's such a complex interplay, this is something that might not be resolved in the first visit. It needs a lot of follow-up. It needs a lot of tweaking of medications or other things to actually improve the overall quality of life. And that is our whole goal at the end of the day, is to improve the quality of life of someone with epilepsy. So I'll stop my talk at this point, and I'm happy to take any questions.
Okay, great. And if you can end your screen share, that'd be great. Sure. And then Dr. Sivaswamy, if you want to put your camera on, just have just a couple minutes, and so if we can give super quick answers, that would be great. One person asked if you had a lacunar stroke. I'm not sure if I'm pronouncing that correctly. Is that something we need to be concerned about versus any other stroke?
So lacunar strokes are much less likely to cause a seizures and epilepsy. So something that involves the surface of the brain, what we call a cortical stroke, that provides a much higher risk of epilepsy.
Okay, great. And then is it common to be able to remember numbers more than words? That apparently happened to someone with their brain tests that they had.
Yeah, I guess I can answer that. So yes, so as we talked about how there are different types of cognitive domains, so people can have selective loss of one or two cognitive domains, but they might be very well or do very well in other aspects of cognitive domains. So that's pretty common, what you described.
Okay, great. And I have a question about when someone has multiple neurological conditions, including epilepsy, how does one decide whether to see an epileptologist and a general neurologist, or just a general neurologist, or just an epileptologist? How would you advise families or patients on that?
Dr. Sivaswamy?
Yeah, I think that's a great question, actually, Russ, because, we're often asked that, well, in pediatrics, as far as pediatric neurology is concerned, I think it's always best to start with a general pediatric neurologist, so we can establish, what is the main diagnosis, what are the, important comorbidities, and, if necessary, then we can transition, a select population of children to see a pediatric epileptologist. Not every child needs to see a pediatric epileptologist, but there are a few rare syndromes homes, in which case they may need to. So that's what I would advise for children.
Yeah. I think for adults, as with all the topics we discussed, it's bidirectional. So many times, when as an epileptologist, if I'm treating epilepsy, if I'm diagnosing with dementia or I have a suspicion of dementia, then I might send them to a dementia specialist. If I think that their stroke the stroke symptoms are weird, it's a rare type of a stroke, I might send the patient to a stroke specialist. It might be just a single visit, but that happens sometimes. So going to providers within the same practice, it's always helpful, because then the providers can talk amongst each other and discuss patient care much easier.
Okay, well, great. We got our questions answered and right in time. So thank you both. You covered such a broad and topic with a great degree of depth as well. So in such a short period of time. So I really appreciate how well you did that. And thank you all for joining us for this breakout session, which is entitled Supported Living Options for Adults with Epilepsy. So this session is generously sponsored by Mercy Health. So we're very grateful for that. And we're pleased to have as our panelists, Dr. Adriana Tanner, who's an epileptologist with Mercy Health Howenstein Neurosciences, and Joanna Lofton, who is the Community Resource Specialist for the Autism Alliance of Michigan. And we hope to have Jan Slattery. Jan is a parent of a young adult with epilepsy and autism, and she will be sharing her perspectives on this topic. So can each of you start by sharing just a little bit about your experience with this particular topic? Dr. Tanner, would you like to start?
Yeah, thanks for having me during this presentation today. I'm Adriana Tanner. I'm an adult epileptologist at Mercy Health Howenstein Neurosciences. And I think my involvement with this topic is as an adult epileptologist, I often get questions about housing and living independently. And so I think it is in my capacity as somewhat as an advisor to patients that I've gotten to be involved in this topic.
Okay, great. Joanna.
Good morning, and thank you also for allowing me to join you guys today. I started this journey primarily as an individual who has always been a helper. And then along with that came my interest in working with families with disabilities, various disabilities. I've had about 30 years of experience in working with families who were working with their children and how to help them become more independent as adults. And from there, I've worked with families, I've worked with other organizations, and along with that part of my journey, I also have a now young adult of my own who has a seizure disorder and is also on the autism spectrum.
Again, thank you so much for joining us. And Jan, can you introduce yourself?
Okay, my name's Jan Slattery, and I have a 22-year-old son. He is on the autism spectrum. And 7 years ago, he developed a seizure disorder. And then also 2 years ago, my husband and Matthew's dad passed away suddenly. So this is a topic that I realize I need to learn more about and start to look into because you never know, so.
Right, great. Well, again, thank you all for joining us. So many young adults with epilepsy follow a typical progression of housing situations. So perhaps living with parents as a teen, maybe going to college or getting a job and living in a dorm or an apartment, possibly with a roommate, and then eventually maybe getting married, buying a house. So while that's possible across the spectrum of epilepsy, many people with drug-resistant epilepsy and or physical or developmental disabilities may have a harder time finding an appropriate living situation outside of their parents' home. Often supports may be needed to make this transition possible. So today we're going to explore some different residential options and the types of supports that might be needed to maximize both safety and self-determination. So Dr. Tanner, let's start by talking about people with epilepsy who have no significant intellectual or physical disabilities, but simply have seizures that aren't fully controlled. In many cases, a roommate or a partner is able to assist someone with seizure response and transportation. But when you have patients with drug-resistant epilepsy who want to live alone, how do you counsel them?
Yeah, that's a really good question, and a question that we get very often. And I think I'd like to start by saying that this is not a cookie cutter type, one size does not fit all, right? And so I wish I had a straightforward answer, and it is not straightforward. I would say that in general, if patients want to live on their own, we start with, like, our first line of discussion is general seizure precautions, right? I mean, you don't want to maybe have someone take baths. Obviously that's a big thing for any patient with epilepsy, but especially if you live on your own, showers are definitely what we want. We talk about heights, talk about sometimes, depending on the seizure type, maybe avoid cooking over an open flame, and then kind of only cook in that situation if there's someone around that can come and help and cook. Like I said, the first thing that we discussed is just general seizure precautions. I think the sort of second line of discussion is having a way to notify others if they have seizures. For instance, if patients have, for instance, a warning sign or an aura or a focal aware seizures, to be able to maybe have some type of an alert button or a connection to their phone that they can help others identify that they're having a seizure. And then, I think the third line is to really think about the seizure types, because believe it or not, I think that can have an impact. I mean, I think we would think about very differently if a patient has generalized tonic-clonic seizures followed by a very long postictal period where they're confused or agitated, versus someone that has maybe uncontrolled, very brief focal seizures. And so I think that's how I think about the discussion, is going through these sort of 3 layers for patients.
Great. And then is it something that you ever discuss with patients and families in terms of location of where they might live in a way that would allow them access to both the community and employment options?
Yeah, that often comes up as part of the conversation. Absolutely. With issues with transportation and patients not always being able to drive, I think living in a community that has some type of transportation available, like a bus system, is ideal. That unfortunately is not true for a lot of communities outside large urban areas, so that can be problematic. I think the next best thing in terms of transportation would be to live nearby friends or family or church family that can help with transportation. And then same with jobs. I mean, I think living close to where you want to work, it's ideal, simply because then, biking, walking, having a ride nearby is definitely easier.
Right. So Jan, what specific supports related to seizures in particular would you want to have in place in order to feel comfortable with your son moving out eventually?
Okay, well, I would want to make sure that the staff, if he's in a, like a group home, that the staff is all trained in seizure first aid. And I would want to make sure that there was a seizure plan that was specific to Matthew. Make sure that his meds are given on time, and that his emergency rescue med would be available at all times. The staff would need to know when to call 911 in what situations, because you don't call 911 after every seizure. And also what his seizures look like, so the staff knows, what type of seizure he's having, since some of them aren't real detectable. My son has all 3 types. So that's what I would want. And then ideally, the place that he lives, ideally 1 floor would be best. because then you would avoid the stairs. And as the doctor mentioned, showers over baths, supervised if he does any cooking, everything, I think, supervision. And also other factors, like for me, is that I do use a seizure monitor on his bed for nighttime seizures. So I would want that to be accommodated. And I think that's off the top of my head, my major concerns or my major supports I would like in place.
Right, and certainly with the use of any kind of seizure monitor or seizure detection and alert device, not only would a lot of people want to have that in place, but you'd also have to have someone that would be notified who is close enough to actually be able to respond to it too. So that's another thing that people often have to consider with using those types of devices.
Right. My son has the MFIP monitor, which has actually worked very well for us. It's a very piercing sound, so it should wake somebody.
Yeah, that's a mattress-based device.
Correct.
So, yeah, Joanna, do you have any thoughts that you want to add to that? Any things that, and what is your son's current living situation too?
Currently, he lives with me. He's 29. He could live independently. I've been able to leave him at home for like a week at a time. We've worked at this in bits and pieces to make sure that he would be capable and be safe. So, excuse me, currently that's our option. There is a plan for him to move out, but we're gradually working at that. What I think some of the concerns are in making sure that the individual is safe once they actually are on their own, and the option to try to live on their own, such as some families I know will go to a hotel for a weekend just to leave their young person at home to practice those skills that they've worked on. Because to truly live independently really should start when they're very, very young, the same way we do with our neurotypical children. But wherever they are on the scale of their disabilities, it's where you start in teaching them those gradual skills so they will, one, be safe, one can, and also can be as independent as possible. Excuse me. When we look at how they're going to be independent, there are many ways of helping them with those daily living skills. And because a large variety, about 1/3 actually of individuals who are on the autism spectrum also have a seizure disorder, they have so much in common for those independent needs that they may have.
Right, and I love the idea of doing kind of a trial period of going to a hotel and trying that out. That's a great idea. So when neurodevelopmental disorders like autism or intellectual disability or mild to moderate cognitive impairments are involved, a variety of different supports may be needed depending on where on the spectrum these disorders fall. So can each of you talk about some of the functional limitations that can act as barriers to independence with these conditions and some of the types of supports that might help with these? Dr. Tanner, would you like to go first?
Yeah, so again, I think it varies definitely between depends on the where patients fall in a spectrum of cognitive or developmental disabilities. And so I think we look at ability to perform activities of daily living, verbal abilities, are patients verbal or not? And so I think we kind of go over the different housing opportunities that patients have. And I think we're going to maybe discuss that later. So anywhere between living with parents or living in a, with roommates on an intentional community or AFC home. I think that really depends on kind of where patients fall and the needs of the patient.
Right. And can you talk a little bit about neuropsychological evaluations and kind of the benefit of that, and kind of identifying some of those functional limitations and also identifying strengths that might support independent living?
Yeah, absolutely. I mean, I think that's a great tool that we have. And in many of our institutions, you know, in epilepsy centers, we do have neuropsychological evaluation. So I think neuropsych evaluations are really critical for two reasons. One is because we want to identify these weaknesses as well as the strengths, right? And that will help us identify the best scenario. And so, for instance, you know, we can identify if a patient would do well, maybe with just a roommate, or maybe independently, but maybe having someone just come for a few hours a day, right? I mean, it could be as simple as that, right? That maybe they need someone that come and check for 4 hours, you know, help maybe with the cooking, make some phone calls, you know, you name it, right? But I think the neuropsych is also critical to provide tools for the patients as they move into a more independent scenario. And so oftentimes we do more than one evaluation, right? And so I think it's important to highlight the fact that a neuropsych evaluation looks at one point in the patient's life. And that's just like that one day, right? Essentially. It's a very thorough evaluation, but oftentimes sometimes I repeat it a few months later, because then you have some dots to connect. And I think that gives us a really clear idea of where someone is. Right.
And ideally, and I don't know how often this is available, but in addition to doing it at multiple time points, being able to do it assessments or observations, at least in multiple settings, is also helpful if you can find a neuropsychologist.
Absolutely.
Do that, like doing it in an actual home assessment or that type of thing. So Joanna and Jan, do you have thoughts on barriers that you're particularly concerned with in your sons or in families that you've worked with, and then the types of supports that you might want when it comes to outside of their seizures, but more related to the autism and or any intellectual disabilities?
Yes, some of the things that when I work with families, we talk about how they actually function, looking at such things as their sensory processing, because I know those can also be triggers not only for the individual with autism, but also some of those sensory, like the lights and the strobe lights and TVs, you know, and the gaming can also sometimes trigger those seizures that they may have. So we talk about those kinds of things and what we need to put in place. And we will also look at the lack of generalization for them. Many of our individuals, especially those with autism, can't do the skills everywhere. For example, I've had an individual who could only tie his shoes on the stairs. And so we look at those kinds of things and helping them learn how to generalize those daily living skills, so that no matter if they're in the home with their parent or if they're in their own apartment, that they can do some of those same skills. The slow processing speed, especially when out in the community. One of the things I am excited about is that the state just issued that for those who either are driving or at least have an ID, that you can actually go in to the Secretary of State and have it listed as a communication disorder, so that if you are out and the police happen to come upon you for whatever reason, that they can look in their system and realize, oh, this individual is not having a bad behavior, not being difficult, that they actually do have an issue with actually communicating because there is a medical issue. That I particularly like. For those who don't drive, the other thing that, especially when Dr. Tanner was speaking about what modes of transportation, we know that they can also get staffing that can help them with driving. And an individual who is getting federal subsidies, thank you, could own a car, even though you can't drive. So at least you have that accessible to you and still have someone that might be able to drive you around. that it doesn't penalize you for owning an actual vehicle. And lastly, are those social skills in particular. So practicing those social skills so that they feel more comfortable getting out in the community, creating those relationships. We look at some of those. That's one of my son's biggest issues, are those social skills, and actually working on training how you behave, how you communicate with one another. So that's a big piece, especially for me.
Right, and those social skills will be valuable regardless of what
Yes.
setting they end up in, whether it's with a roommate or whether it's in a group home or some other situation. So,
or on the job.
Yeah, absolutely. Yeah. Jan, any additional types of supports that you think would be particularly helpful for your son?
Yeah, well, I think in our case, our biggest barrier to the thought of independent living is like the communication. My son's communication skills are pretty limited. And even though like he knows, what do you do in an emergency, call 911, whether he would actually follow through and be able to do that would be an issue. And then also, like he's thinks everybody is his friend. And so, I worry about him being taken advantage of. So that's why for us, it's looking like this independent living isn't going to be an option, but, we'll continue to work. I really like the idea of like the trialing more independence, to see how far it goes is a great idea.
Great. So Joanna, can you talk about some of the health and human service agencies and different systems that assist with supported living options and what types of services they provide?
Sure. The primary form of assistance is with community mental health, where you can get most of your supports. Through community mental health, an individual, one has to have a medical diagnosis and also have a disability, but also have Medicaid in order to get those services applied for. And then through community mental health, although there is a lack of individuals to actually provide the supported living services, what you can get through them is staffing. Even if they're living in the home with you, you can get staffing that can actually, through a treatment plan, a personal plan of service, to actually work on specific skills that you would like them to acquire before they're even moving out of your home, such as helping them learn how to shower safely, helping them to learn how to cook safely, helping them to dress, to get out in the community safely. It's whatever those needs are, you can create in that plan. You can also get respite services for the family just to take a break so they can spend time with them. And those hours that they get are determined basically upon how great the need is of the household. So that's one of the main things they can get. It helps them get out in the community. They can get out with them being their actual transportation. Maybe it's actually getting a job. That staff person can actually be their transportation to going back and forth to work or to school or just for social issues. That is one of the main things you can get through them, along with getting the coordinator or case manager who will help to monitor the services that they get. They can get therapy through them, medication management. That is one of the main agencies. The other agencies you can get connected with are like the ARC, which will help families with doing such things as your will or special needs trust that families should be getting, helping that individual to actually create a kind of life plan for them. And a lot of workshops and trainings. Disability Network is another really good one, because with Disability Network, you can get some of the social interactions. They do some of the job preparation skills. You can actually get some mentoringships with them. Another one is also our community housing network that actually works primarily with Wayne, Oakland, Macomb County. But through them, they can help to partner you with an individual to become roommates. They will also help you with creating that housing plan if you're looking to buy or rent, and connecting you with that housing option. So there are a number of agencies out there similar to that. Another one you might want to also look at is for Michigan Alliance for Families, which for those individuals in particular who are still in school and need some educational assistance. And then there's also, for the legal part, there is also, they just changed their name. I'm sorry, and I lost the name.
Yeah, I know Michigan, it used to be Michigan Protection and Advocacy.
And then Advocacy, yes. And I just lost their new name. Yeah. But they're also there to help you with those legal issues. And that will be another avenue that families will need to be looking at.
Right. I think someone texted in the chat. I think it's Disability Rights Michigan.
Yes, that's it.
Thank you, Kara.
Yes.
So yeah, those are all great resources. And again, in terms of the school system in Michigan, you're allowed to receive services through the school district up to age 26. And a lot of people find that to be very helpful in developing some of those independent skills. Jan, have you accessed any of those services that Joanna mentioned, and which have you found to be particularly helpful?
Well, I like the idea of the community mental health and the respite in the community hours. However, we kind of came up short on that with the lack of workers. We actually have not been able to get anybody. So hopefully that will change coming up. And I am familiar with the ARC as well. I've accessed them, and the Autism Alliance of Michigan, I know, is a good resource too. And I've gone to multiple trainings also through the Michigan Alliance for Families, all good resources.
Great. And I'm actually going to jump ahead to a question, just because you referenced it, the difficulty finding workers, but direct care workers that can include nursing aides, home health aides, personal care aides, and a variety of other frontline workers who provide hands-on care for both older adults and people with disabilities or chronic health conditions. There's unfortunately low pay, lack of benefits, and burnout can all contribute to very high turnover rates, and then also a lack of workers. So often a family will find someone who's a great fit for their loved one, only to lose them and have to go back to the drawing board. So what are some strategies for finding and keeping reliable and well-trained direct care workers, and what needs to change systemically to support direct care workers and the quality of care that they provide?
I can take that one. You're absolutely correct. It is really hard to find a good staffing. A couple of things that families can do is, if you happen to have an individual who wishes to be that care worker for your individual, they can actually sign on with a provider and become that direct care worker. The one thing I tell a lot of families is sometimes it's just, that aunt, that uncle, or that grandma who's helping out anyway. Have them sign on. They make a little additional money, and they're getting paid for what they do anyway, and they're more likely to be around because they're a family or a friend. Check in with your church members that you might have is another good option for finding someone. The third option is talk with your school system. Many of your retired teachers, special education teachers, your parapros, the OTs and speech teachers will often pick up those hours. That's one way of getting someone on your own and interviewing that person yourself to make sure they're a good fit. You're right that one, they do not get paid enough. That is one of the issues that is being worked on, and it is not just a Michigan issue, it's a countrywide issue. There is a plan now within our legislators to actually up the pay scale for them. There is also a plan working on now better training so that it will actually be more of a career path, so that there are steps, so they actually get some college credits for it. So that, along with working on making sure there's consistency within the agencies throughout the state, because there's very little requirement for an individual to actually become a direct care worker. And there's, like I said, very little reason for them to stay. Looking at a tier system, so they also are getting health care and also getting some vacation time. Because currently, many of the individuals who are providing that work, approximately about 70% of those are also on state and federal benefits themselves. So they are constantly leaving, looking for a better position so they can provide better for their families. So it's the hardest job there is, other than being a parent, but there's been the least amount of attention paid to it. So finally, some of the balls are rolling. They've gotten 2 raises in the last 3 years, so across the board. So hopefully the new legislation will make it a lot better.
Great. Dr. Tanner and Jen?
Yeah, I was just thinking this is such a complex issue, and I think advocacy really is what we need to do to support these ideas. You know, we have incorporated advocacy in our teaching curriculum to our residents, and we need to support it at every level, at local, state, and federal level. So I know you guys at the Epilepsy Foundation are doing such a beautiful job at doing this, but I think we all of us have to support this. I mean, we can all call our legislatures, we can all call our people that represent us at the state level and at the federal level. Otherwise, none of these will change. So, I mean, I think advocacy is, we can all put our own effort, however little that might seem, it actually makes a huge impact.
True.
Right. Yeah. And with the aging of the population, we absolutely need to be investing in our care economy and in our care workforce, and anyone, whether it's for older adults or people with disabilities, it's so important to invest in that. And I think there's elements of that in the current that Build Back Better plan, and so certainly encouraging your legislators to support any policies that build our care infrastructure. Jan, did you have any thoughts on that?
Just that I agree, you know, the pay and benefits are definitely an issue, and more training and support of the workers, and then making them feel like they're, you know, like it's a valued job too, and, you know, that they're part of the team and they're respected. And I think those things go a long way too.
So now I'd like to discuss some of the pros and cons of various supported living options. So I'm going to mention an option, and then each of you can kind of chip in with your thoughts on some of the benefits and limitations of each. So let's start by talking about kind of the status quo, which for many young adults, which is continuing to live with either your parents or other family members. And kind of a side option off of that is the idea of living with family, but somehow creating a separate suite or space within the same home or property. Any thoughts on that as an option?
Yeah, I think so. In my mind, the benefits are, you know, fairly clear, right? I mean, you're surrounded by family. Family can help with the seizure plan and administering maybe rescue medications, and being able to call 911 if there's an emergency, help with laundry, you know, activities of daily living, cooking, etc. I think the disadvantages for young adults is that, you know, maybe loss of independence and feeling like they're not kind of up to par with their peers. And I'm talking about maybe the young adult that doesn't have cognitive disabilities, because we really want to encourage young adults to transition. And so that may seen socially, maybe not as ideal.
Yeah. Other thoughts on that?
For the safety factor, it can be a very good option for those who are not only medically not up to being safe on their own, but also for mental health purposes. And many individuals, although they may be young adults, excuse me, developmentally, they are often much younger than their chronological age. So it can be good. It can also give them an opportunity to try out some of those independent skills. But the upside, the downside to that is they are not truly independent. And as families, we try and help as much as possible to take care of them. And so they often don't get the opportunity to really be independent and do as much for themselves as they could if they were on their own, or at least in a different setting. Some families have gone to the point of just creating that suite in the basement, or tiny houses that become popular if they have the property, which is the next best step for still living at home, per se. But it does give them a little bit more independence.
Right, right. And you mentioned, independence, and just wanted to touch on that no one really is ever truly independent. We're all interdependent, and that's, really the goal we're going for is maximizing independence, but realizing that everyone is interdependent, and we all benefit from our connections with others. So
I mean, in the suite or the tiny house or the basement could be also an intermediate step, right? I mean, it could be the first step in
moving out,
like Joanna said, in moving out. And so practice living from home to living in a separate sort of apartment within the house where some responsibilities, and then for a year or two, and then more of a, part of a process. And oftentimes that's also what works, right? It's a stepwise fashion. A lot of times it's not a black and white situation where you go from family to living on your own overnight.
Right. And Jan, for you, what's working well currently, and what do you think what is your son hoping for, or are you hoping for in maybe a transition to a different situation?
Well, I think Matthew probably would want to live at home with me forever, but I don't think that's the best idea for him. Within a few years, probably once school is over, I think like a transition to like another living situation would actually be better for him, because he would be more independent, and hopefully, my vision is for a place where he's safe and supported, yet still, has a lot of activities, a job, outings. And then of course, like, he'll still have me and family. What I kind of hope to create is like maybe, like a circle, especially after I'm gone, of like people who, maybe take one day or 1 month a year, and once or twice that month, check on him, take him to dinner, make sure things are going well. But I think it would actually, be better for him to transition to a different living environment at some point, and kind of create his own life and his own family, and not be so dependent on me.
Right.
That makes sense.
Yeah. And what about the option of living with one or more roommates who may or may not have disabilities in an apartment or any kind of living situation? What are some of the advantages and things you would want to set up to make that successful?
Yeah, that possibly could work too. And again, just to be sure that he's safe, but he has right now, he kind of has a hard time, with time on his own. He kind of is the type of kid that needs somebody constantly some activity or something he doesn't do well with spare time. So if he had roommates that worked, that could be an issue.
Right. Joanna and Dr. Tanner, any thoughts on some of the things that would make that sort of situation successful?
Yeah, I think, oh, sorry, Joanna, go ahead.
No, continue.
Well, I was going to say that I've had a lot of patients that have asked me about that, and I think there's just a little bit of sometimes fear, with roommates that may not have disabilities, that may be uncomfortable living with them, and I always tell them, just interview people and you'll be surprised, right? I mean, a lot of times, this will work very well. And I think obviously the advantage is to have that support system sort of there and then help with some activities. The disadvantage is that, sometimes these relationships, like Janice said, may not work, right? And people may not necessarily get along or may have difficulties with the disability. But I think it's, for some young adults, it's worth trying and we're thinking about living with other roommates with disabilities or not. Sometimes they may really complement each other.
Right.
The strengths and the weaknesses that they may have.
Yeah, absolutely. Kind of matching those up, and I think there are some websites that can help people with disabilities identify roommates who are either who don't have disabilities and are wanting to help people with disabilities, or who do have disabilities and are looking for someone else. So Joanna, your thoughts on that?
Yes, if for those who are at a level of independence that they could function, I think it's really one of the better options, because living with a roommate, one, you can have some social interactions. Also for you, if you also have an individual with a disability, and you both are getting federal and state support, such as SSI and Medicaid, it helps because now you can split the income, the bills, with your income with that other individual. And also it's a situation where if you can find staff, then both of you could have staff. You won't get enough hours as one individual to have constant supervision or even everyday support. But if you have person A has staff could come in on Monday, Wednesday, Friday, and person B staff could come in on Tuesday, Thursday, Saturday. So you would have more coverage. It's one of the ways of managing it. And then the downside is, I think, like with anyone, whether there is a disability or not, that you may not get along. I mean, that happens with roommates all the time. Having an individual with a disability who's on at least the same functioning level or higher can help with helping with some of each one's strengths and weaknesses.
Great. And kind of the evolution of living with a roommate, kind of a more intentional approach, is the idea of either creating or finding an intentional community. And that's a situation where multiple families kind of come together and plan a living situation together. They share costs, they might share supports, and very carefully select the people who will be living in that situation to maximize the chances of success. Has anyone had experience with that concept of intentional communities, and what types of things would you want to see in that sort of arrangement for it to be successful?
I'll jump in and say that I do have a friend who has a daughter with a disability who recently purchased a house with that in mind. It's a large house. Each bedroom has a bathroom. And right now they're living there with their daughter, but their plan is eventually to turn it into, a forever home for their daughter. So in a couple of years, they're going to look into, forming like a board and then start getting the ball rolling. So I do like that idea and hope to be part of that. And again, like was mentioned, can kind of get all the resources together to make it successful, and everybody will have a word or a part in making it happen, making it successful.
Great.
Yeah, there are more and more of those that are coming about, springing up all over the country, actually, with intentional communities. There's one in Farmington Hills that 4 families actually got together, and they're actually living in a regular apartment complex, but because of the location, their young adults can walk to most of the things they would need, such as groceries, the movies, and all of those kinds of things. And what they did was actually develop so that they're all in the same building, and they were getting an individual that could live in the building with them in their own apartment to kind of oversee all of the activities, keep them involved. So there are those kinds of communities that are being developed. There are communities like Acorn in Ann Arbor, which is an inclusive community where families that move into that community are totally inclusive. There's individuals with disabilities, there are families there who have no disabilities, have intergenerational. They've kind of creating their own little community that would look the closest to what a regular community outside would look, and individuals who move in there who do not have disabilities know that I am intentionally moving into a community to be welcoming of individuals who actually do have disabilities. There's that one. There's also Maple Oaks and Great Oaks, or a couple of the others, where you can actually purchase a home, purchase an apartment. They have shared living space for meals and for communing. So there are different options depending upon, one, the level of functioning and the level of financial support that individual may have.
Yeah, I have a couple of families that I know that have created situations like that. And what I think is really interesting is that for at least for one of the families that I'm thinking about, they were able to get really creative, and they match actually people with different levels of disability. So they all have epilepsy, but one patient has a really catastrophic syndrome, or another patient is in the autism spectrum disorder, but then they also have another adult who doesn't have as many disabilities. So you don't have to match exactly the same level of disability, right? In fact, I think that's what got this community. They bought a house, and I think they made it into an LLC, like a corporation. And then they run the house, and the 3 families share the resources. But I think it's really interesting that they also played for with the strengths of these 3 adults. And one of them, actually, the one that has no or very little cognitive disabilities, really enjoys cleaning for some reason. And so it worked. So you have to sometimes just get really creative for these communities.
Yeah, absolutely. And we'll talk about one more option that tends to be one of the more common options, and that's group homes, which are also known as adult foster care homes. Again, just as a, hearing from clients and families, we hear a full spectrum of stories about really successful situations and really horrifying situations, and everything in between. So what are the types of things in a group home setting that tend to lead to a successful outcome?
I can talk some about those. First of all, there are 2 kinds of group homes when you think in terms of the licensed and the unlicensed group homes. The licensed group homes are actually managed, oversaw through community mental health, but the licensed group homes are not, the unlicensed are not. So you have to be careful at what you're looking for, and because they're not as regulated. What can make a group home successful, though, is having enough staffing, making sure that staffing is well trained, and also making sure that there is appropriate individuals within that group home as other group home members. You don't really want to have a group home and where you have your Janice's 22-year-old in the group home and the other member in the group home, one of them maybe 60, maybe 55, those relationships they create are not always the most beneficial. The positive thing around what could be a group home setting is if the individuals that manage the group home are truly certified in understanding how to actually manage the seizure disorder, how to actually teach them. They're not just there to live. They're also supposed to be working on teaching them skills to be more independent within the group home. So it's really about how they're managed. Having the new home and community-based rule has helped because it gives other individuals who live their more rights. Before that rule, they could not have a lock on their door. They could not choose who could come and visit them. They were generally told what to wear. So with that rule, they have a lot more freedom in the group homes if it is managed appropriately.
Other thoughts on group homes?
Yeah, my experience as a physician, the ones that I perceive as being the best is like Joanna mentioned, the ones where you have administrators that are really invested, that have done the training and that are not, that really know how to manage seizures, that are comfortable with seizure plans. So I think if you are a family looking for a group home, I think investigating how they approach this is the first step to really choosing a good fit for your loved one.
Right. I mean, do they have a care philosophy? Do they have like
exactly
a lot of places you might ask about that, and they don't come up with an answer for that. It means they haven't really intentionally thought about that sort of thing. Jan, you were going to say something?
Oh, just basically that you just want to be able to like pop in all the time and make sure, or somebody check in, make sure that things are going well. And with my son, even though he can't communicate well verbally, you can definitely tell with his behavior. So so you want to make sure they're treated well, and like you said, like the good philosophy, what is their philosophy, and what activities, and working on the independent skills to trying to keep the person still learning is all important, all things you would want to look at.
Great. Well, thank you so much. And just looking at the time, we're going to have to wrap up, but I want to thank again our wonderful presenters for sharing your time and your insight with us today. This is a really informative discussion, and hopefully it's given some people ideas of things to explore and things to consider when possibly transitioning a family member to a more independent situation. So
thank you all so much for joining our breakout session entitled Public Policy Forum, the Seizure Safe Schools Act and Driving Regulations. So I'm Brianna Romines. For those that don't know me, I am honored to serve as president for the Epilepsy Foundation of Michigan, and I'll be moderating today's session. We're honored to have our panelists here with us today. We've got Representative Jack O'Malley, who represents the 101st District in Michigan's House of Representatives. Welcome, Jack. We've also got Dr. Barkley, who's an epileptologist with the Henry Ford Comprehensive Epilepsy Center. And it's also of note that Dr. Barkley both sits on our board of directors here at the Epilepsy Foundation of Michigan and also chairs our professional advisory committee. And Henry Ford Comprehensive Epilepsy Center is today one of our leading sponsors. So thank you so much for that. And also we have our wonderful friend, Abigail Burnell, who is a government affairs consultant for RWC Advocacy. She serves as the lobbyist for the Epilepsy Foundation of Michigan. And I have really the honor and pleasure of working alongside all of our panelists today in our public policy efforts. So thank you so much for being here. All right, so let's just jump right in. I'd love it for each of you to share a bit about your connection to epilepsy and your experience with this topic. And Dr. Barkley, why don't we start with you?
So my connection to epilepsy began in 1986 when, as an EEG fellow, Bob Sinkins and I founded the adult epilepsy program at Henry Ford Hospital. And since then, I have spent most of my career taking care of people with epilepsy and trying to help improve their lives both on a personal level and also through public policy initiatives, working with the Epilepsy Foundation of Michigan, the Epilepsy Foundation nationally, the American Academy of Neurology, and other organized medicine groups to make lives better for people with epilepsy.
Wonderful. Thank you, Dr. Barkley. Representative O'Malley, would you go next?
Sure. I am probably the least knowledgeable on this in this group here on the world of epilepsy. But I am about a year ago, my son had a seizure, and obviously that was my introduction to it. And so I started asking a few questions, and I didn't get the answers I liked. So I reached out to the organization to get some answers, and lo and behold, they had ideas, and I had some ideas, and we've kind of brought them together. And Dr. Barkley has been a great source of information. And you know, I look at my role as a state representative as not to necessarily be the expert on a topic, but to be an advocate for a topic. So that's why I'm here.
Oh, and we're so glad you are here. Thank you. Abby, would you like to go next?
Of course, thank you. Like Representative O'Malley, I have learned so much from Bree and the team around epilepsy. I have been working with the foundation since I started my time here at the firm about 2.5 years ago. And so in that time, I've learned a tremendous amount from Bree and her team, and a lot from the advocates that so willingly volunteer their time and share their stories. And I learn more on those calls than anywhere else. And so I have a very strong passion and focus for health policy, which is kind of where my expertise is and my main interest. And so it's really my pleasure to work with the Epilepsy Foundation and represent your issues.
Thank you, Abby. All right, so before we dive into really the specific public policy issues that we're going to cover today on the session, I wanted to get each of your thoughts on why public policy matters and should matter to the epilepsy community, and maybe the different ways that people in our community can get involved and have a real impact. Dr. Barkley, would you like to start with that one as well?
Sure. Thank you, Brianna. I think that public policy matters because it can influence our ability to promote access to things that are important for our lives. It can make our voice heard, particularly when we work together to raise our voices and fight for things that are important for people with epilepsy in this case.
Yeah, absolutely. Jack or Abby, would you like to add to that?
I'll just jump in. I agree. I think that I guess just from my small situation here, people get complacent, comfortable with the way things are looked at. And I think that happened with this organization on some of the topics that I'm working on. And because you can lose, there's so many things. How do you follow them all? I think it's important because things are always changing, and you need to stay up on top of what's happening and how you might be able to. The climate might be able to is different now, so maybe you can move this issue or that issue. And as much as the health part of it is important to everybody here and the good doctor, the policy on how you can implement some of those things is important too. So that's why you can't lose sight of this side of the issue.
Yeah, it's a great point. Abby, would you like to add to that?
Yeah, of course. I think for the Epilepsy Foundation, specifically in the advocacy work that we do, is we bring a voice to conversations that nobody else can. We're the community that represents people with epilepsy. And so others that are weighing in on legislation and policies are insurance companies and physicians and health systems, and their voices are important, but our voice is equally as important to provide that very unique perspective that no one else can provide other than those that are impacted. And so bringing your voice and bringing your perspective to a larger conversation is really important. Not everyone always agrees on the same solution, which is part of the work that we do. But it's important to be at that table, share your concerns, share your perspective so that everyone can see kind of a fuller picture when considering a policy change.
Yeah, absolutely. And I'll piggyback that one of the core roles and functions of the Epilepsy Foundation of Michigan is to do what we can to really elevate that patient voice. We want to make sure our lawmakers, can hear from those living with active epilepsy right now. And that's great. All right, so I'm excited to kick off. Oh, Dr. Barkley, you want to add?
I just want to make one other point, and I think what Jack said right at the beginning was he talked about his son and his own personal experience. And Jack and all other politicians entered the field of politics to try to make lives better for their community, for the people that matter to them. And when people who are in Jack's district speak up to them with their own personal stories, it puts a personal face on any issue. When we're talking about abstract issues such as $10 billion on the infrastructure bill that was in this latest thing that was passed by Congress, $10 billion coming to Michigan, that's a big number that nobody can understand. But when you have a story where Jack told about his son having a seizure and how it disrupted his life and his family's life, suddenly becomes personal. It becomes something that anybody can relate to and take an interest in and say, what can I do to make this better?
Yeah. And Jack, I'd like to know if you want to respond to that in terms of, when you do get reached out to by patients, or let's just say people, right? Maybe not other larger organizations, but just people. Does that grab your attention? And what does that mean to you?
Well, yeah, I think the doctor had it right. I'm not a career politician. I got into this to do hopefully 6 years of public service. And my goal is to make things better. It isn't about, I got into this job, people always say, well, what's your agenda? And I said, I don't have one. My agenda is that of the people, because that's why I'm here. And to the doctor's point too, once I've started talking about this legislation and why I'm doing it, I am amazed at how many people have epilepsy.
Isn't it?
I mean, it's like, well, yeah, I've had it for this amount of years. And it's like, really? So this is, so when you to your point, when you mention it and you bring it out, now all of a sudden these people start coming out of the woodwork. Not that they were hiding by any means, but it's not something you necessarily talk about. So it really has enlightened me there too, that all these people pretty much went through the same things we're trying to fix and make better for others. So it just seems like a pretty smart thing to do.
Jack, I absolutely love that you brought that up, that how when you start talking about it, that others will come forward. It is a reoccurring theme from absolutely everybody in the epilepsy world. As soon as you start having those conversations, people share that, and you really get a sense for how common it is. That 1 in 26 really becomes clear, I think, to us in that point. So let's dive in, perfect segue into our piece of legislation that we're so grateful to have Representative O'Malley as the lead sponsor on, and we really want to see happen and brought to that finish line. So let's start. It's the Seizure Safe Schools Act. And Abby, I'd love to ask you if you could really describe the intent of the Seizure Safe Schools Act and the main primary components of that bill.
Sure, happy to. So Representative O'Malley graciously earlier this year worked with Bree and I to introduce House Bill 4970, which we are referring to as the Seizure Safe Schools Act. And the legislation really has 4 main components to the bill. The first component of the bill is a signs, symptoms, and seizure first aid training for all school personnel. So this would be anyone that has direct supervision over a child during their school day, a teacher, a parapro in a classroom, a counselor, a lunch staff member, a bus driver, anyone that's going to have direct supervision over a child could do this it needs to do this signs, symptoms, and seizure first aid training. And the intent of that is really the promptness in responding to a seizure emergency, being able to recognize it. One thing I learned from Bree more than anything in these conversations is so much of epilepsy goes underdiagnosed. People they don't notice it. They think maybe a child isn't paying attention or is having a behavior issue. And I've learned once the Epilepsy Foundation comes in, they are experts in identifying that. And so we're hoping to train some of our school staff so that they also might be able to recognize that, and we can see an earlier diagnosis as associated with it. The second major component of the bill is a medication administration training. And this training is really dedicated to a school nurse. If there is one at the school, we would love to see a school nurse in every school in Michigan. Recently, the legislature appropriated $240 million in the most recent budget to try to increase the number of school nurses in our schools in Michigan. So if there was a school nurse at your school, they would be trained in the medication administration. These are the regular medications a student would take during the school day, but then also those very important rescue medications to respond when there is an emergency. Because we know that the default right now is typically just to call EMS. And in some areas of our state, that could be a very long drive, not only to where the student is at the school, but then that following visit back to the hospital or the medical facility. And I think I've learned from Bree that that's not always necessary, depending on the situation. It's not always necessary to call EMS, which then a parent has to be called out of work. There's an incurred cost of the ambulance ride and the ER visit, and it can become very expensive for families when maybe it wasn't necessary in the beginning. So training our school personnel on how to administer the medication can alleviate a lot of that. The third component of the bill is something we refer to as a seizure action plan. And this is a plan that's on file with the school, is coordination with the medical professional, the family, and the school so that everyone is on the same page on what the medications are to be taken normally and in emergency, who the physician is, how the medication is administered, what the seizures look like, because we know all seizures look very different. So what to look for, all of those things kind of laid out so that everyone's on the same page and everyone understands what's specific for that one student. And so this already happens in our state for similar disease types, asthma, allergy, diabetes. These action plans already exist for those. And so it just makes very practical sense that we do this for seizures as well. And then the final and fourth component of the bill is a Good Samaritan clause. It's kind of waives liability for those who are responding in good faith to a seizure emergency, providing seizure first aid. We want people to feel really comfortable and kind of harness their training and feel like they can respond, that they've been trained and they can respond without liability to try to really jump in as quickly as they can. So those are the four major components of the bill. And I don't know if Jack or Dr. Barkley have anything to add, but.
Well, I would like to say thank you, Abby, for walking through that so cleanly. And also let me say that the training that she described, as our legislation is currently written, would require that every 2 years. And additionally, 12 other states have passed this legislation. So that's why we're seeing some real momentum behind that. But what I'd like, Dr. Barkley, if you wouldn't mind, can you kind of overview really the key medical arguments as to why a piece of legislation like this is so important to safety?
Well, I think the first thing we have to start out with is we have to recognize that the one thing this terrible pandemic has shown us is how important it is to have our children in school and to have the benefits of a good teacher. While there are a few exceptional students who can probably learn anywhere, there's no doubt that a skilled teacher is so vital to the learning of our children. And to have our children in school, whether they have epilepsy or other disabilities, is extremely important to their overall development to becoming a fully functioning adult. The second thing is that epilepsy and seizures can be potentially dangerous or life-threatening. And so the common sense ways to react to a seizure needs to be taught to the personnel who have supervision of our children while they're in school so they don't do the wrong thing. My first contact with epilepsy was when I was in 3rd grade, and I was going out to recess, and I heard some fellow student came running into the hallway saying, somebody's had a seizure and they swallowed their tongue. And I never actually found out who that student was, but I remember thinking to myself, how do you swallow your tongue? Obviously that can't happen, but that was a prevalent idea back then. So a crisis, the emergency of a seizure has to be recognized by the first aid steps that have to be taken that don't necessarily involve medication. The third thing is that because seizures aren't predictable and some children can have clusters of seizures or prolonged seizures, there is a role for rescue medication for certain children, just as there is a role for rescue medicine for children with asthma or diabetes or these other disorders that are already covered by provisions in our state laws to deal with them safely. And so I think this is a pretty cut and dry case of why this legislation is needed.
Thank you, Dr. Barkley. And now, Jack, we'd like to know really what motivated you to introduce and become the lead sponsor of House Bill 4970, and maybe what components of the bill would you say that you expect other policymakers to join you in supporting?
So my first response is always the smart aleck response. So my common thought is I'm just dumb enough to think I can get it done. No, it made sense. I'm chatting with you good people, and I'm kind of coming with the whole driver side of things. And you explained to me, the legislation. I picture myself in my kitchen at 2:12 a.m. on a Saturday morning with my son having a seizure, and all I really know is roll him on his side and call 911. As I've learned a little bit from you folks, there's all sorts of seizures, and there are different ways to treat. So it makes sense. We've got lots of kids in lots of schools, and if there is a way that we can help, it makes sense. And I knew this was also going to go through the education committee, because I think that's where it's died in past years. I'm on the education committee, so that gave me a little bit more of wiggle room to try and get this done. So again, I'm here very simple. I'm nowhere near as deep into this as all you good folks, but that's pretty much my motivation is let's get her done.
Okay, great. And look, I'll interject here and say that I've had the fortunate opportunity to connect with some of your colleagues, Representative O'Malley in the Education Committee, as well as Abby. And I think it's fair to say we've seen just really an overwhelming support for this legislation. I think a lot of them have been maybe a bit surprised to realize that this isn't already an established training based on the prevalence of epilepsy. We know right now almost 14,000 school-age children have epilepsy. And so it's been, we haven't, at least thus far, seen any opposition come to the bill and or to this effort, and really just a lot of understanding support. Would you say that's a fair statement, Representative O'Malley?
I think so. I will say that the only thing I would add to that is because of this now, I'm kind of paying attention a little closer to similar type folks. And I believe there are quite a few other illnesses that are lining up to get their bills through. And we want to get this through as soon as we can, because at some point, I think there can be an argument of, holy smokes, what are we asking these people to do? How much training do they have to go? What gets bumped? That sort of thing. So I think the sooner we can get this through, the better.
Yeah, that's a great point.
Bree, do you mind if I add a
Absolutely.
quick comment?
Yeah.
I think that's a really intuitive thought, Representative O'Malley. We've had some of those conversations, and one of our parent advocates who works in a school and is trained on all of the different trainings every year, she says, I haven't used the fire extinguisher once and I'm trained on it every year, but I respond to probably 10 seizures every school year because people know that I know how to respond. And so I'm the one that gets called upon. And so we're definitely not opposed to rearranging some of the trainings if that's what it comes to, because we think this is really important. And if it can save just one student's life, then it's probably worth it. We've been having, as you mentioned before, when we've been talking to your colleagues on the education committee, it's no different there. And many times they share that their neighbor has epilepsy, their best friend's daughter or son has epilepsy. And it seems like everyone we have talked to, no one has been unfamiliar with it. They are learning about the components of the bill, but they're not unfamiliar with epilepsy. And it's been really opened our eyes as well, just having those conversations and realizing that they all are becoming passionate about it for some of the same reasons that you are. And when we think of 1 in 26, that could be 1 in each classroom. I think, I don't know what our school classroom sizes are right now. I don't have children, but I believe they're probably around 1 in 26. So that could be one person in every single classroom in the state.
Yeah, I think that's a great point, Abby. And we know that 1 in 10 will have a seizure at some point in their life. So even if they don't have that diagnosis of epilepsy yet, the likelihood that all of us will witness a seizure and want to know what to do to appropriately respond is a reality. Okay, so I want to make one more statement and then we'll move on to the driving portion of today's talk. But just wanted to say to all of those tuning in, if this is something that's important to you and this is something that you want to become a part of our effort on with regards to the Seizure Safe Schools Act, please get in touch with our organization. We are in line to get a hearing before the House Education Committee later this month, and there's action alerts that are going to be going live for that. So please, we encourage you to join our efforts in that way. But with that, we're going to switch gears a little bit. And earlier this year, Representative O'Malley reached out to the Epilepsy Foundation of Michigan to open a discussion about driving law and regulations and as it relates to epilepsy. So the four of us, along with Dr. Zilgit, met and had a great discussion about possible changes to the driving regulations that could both improve independence for some people with epilepsy and maintain public safety. But much of this conversation focused on identifying situations that this flexibility regarding that 6-month blanket law that we could really explore. And so, Dr. Barkley, I'd really love it if you could perhaps review some of the research that's been done in this area, and then the components maybe of the conversation that we shared with regards to some driving law changes that we could move further in discussion on.
So each state is in charge of making regulations regarding driving of all sorts. And in particular, concerning epilepsy, states range from restriction after seizures from 3 months to 12 months for the typical driver and a year or more for a commercial driver. By contrast, the Federal Aviation Authority says for a commercial pilot, you have to be seizure-free off medication for 25 years before you can be a commercial pilot, because obviously there's a different set of risk involved. So what we're really talking about is what is a reasonable risk for someone who's had a seizure to be able to get behind the wheel and drive again. And the state of Michigan has decided that that reasonable risk period is 6 months. If you think about this as a numerical equation, then there are about 500,000 minutes in a year, and a seizure lasts about a minute or so for most seizures. So that means that someone with epilepsy has had to go 250,000 minutes without a seizure, or 1.25 million minutes before they're free to drive without restriction in the state of Michigan. Now, that makes it very impractical for a number of situations. And so one of the things that we have been working with Representative O'Malley is ways that we might be able to have some exceptions to this, some ways to allow people to drive to school or to work, or certain, maybe restricted, they can't drive during certain times of the day where they're at risk for seizures, because we know from the science that we probably are making a reasonable assumption of low risk under certain circumstances.
Okay, great. Now, Representative O'Malley, can you share your thoughts on both the need for driving regulations and the negative impact that those regulations can have on people with epilepsy?
I had to cart my kid all over the place. It was a pain in the neck. You know, that's the number one motivation, I guess. No, he's a 19-year-old kid going to the community college. He's got a job. And for 6 months, I'm looking at, we're going to have to get him a ride, and we don't have public transit in my district like maybe other parts of the state. So I did a little checking because of my position. I called the Secretary of State and I said, hey, what's the rule here? And they kind of go through this mumbo jumbo of stuff. But what I get out of it is, and I'm not saying I'm 100% right here, but what I get out of it is that if the doc signs off on it and says, yeah, Zane can drive, he's on medication, no seizures, he can drive. So I go in with the form from the Secretary of State and I sit down with the neurologist and my son. And I didn't say that I was a state representative, but I said, hey, we can fill out these forms. I'm not filling out anything. That's not how it's done. And I talked to my doctor, regular general practice. And he's like, oh, no, it's got to be 6 months. And I said, well, there are some nuances here. Point being is, what I've come to my own opinion is that this law went into effect how many dozens of years ago. And everybody just assumes that it's automatically 6 months. No ifs, ands, or buts. 6 months. And at the very least, I felt when I came to this great group was, we got to re-educate some people here because there were some nuances. And again, my thought was, because on a totally unrelated moment, I remember a conversation with a constituent who on something else, and he was talking about, yeah, I have epilepsy and I can't get to work. So the point is, and then, again, I'm rambling here, but, I'm told that there's a type of seizure that you can only have when you're sleeping. But now you can't drive. So it's time to look at this again. And my thought was, especially in areas with lousy public transportation, we are taking people and not only having to treat them for epilepsy, but maybe have to treat them for ruining their life. There goes the job. Who wants to hire somebody who can't get to work? My son, who's trying to get an education at the community college, granted, some of it was during COVID, so it was online anyway. But the point is, it just makes it so very difficult. So is there a way to be responsible and reasonable and allow certain folks the opportunity to have restricted licenses? We do it in other areas. The other part of this, I think, and this might even be the harder part, is to re-educate an entire medical community to the fact that you can do this now, if we get it passed. Because I think that this situation has been around for so long and people just assume they know everything about it, that it's just no. So if we get this law passed, I hope that we can sing it from the mountaintops and have quite the education campaign out there, public service announcements, whatever, letting people know that you can have a restricted license. Again, that's if we get this passed. So it just seems like massive common sense. And earlier I said I didn't have an agenda. I would say common sense is my agenda.
Mm-hmm.
So
Dr. Bartlett, I want to know if you want to respond. Yeah.
Sure. So first of all, Jack is exactly right. What most people don't realize is how big the state of Michigan is, and most of it is rural. And we are the motor city in Detroit and the vehicle city in Flint, but the only way to get around up north. is by driving. And in fact, Ironwood, Michigan is farther west than St. Louis. And it takes longer, it's farther to drive from Detroit to Ironwood than it is to drive from Detroit to Washington, D.C., Boston, or New York City. So that just gives you the idea of the size of this state. The second thing is Representative O'Malley was correct that there is a way for the physician to sign a waiver or ask for a waiver of that driving restriction, but it's very ambiguously worded, and the way the words are, it puts the responsibility on the doctor and not the Secretary of State for the signing that waiver. The only time in my life I've been sued for negligence happened because of a driving form. I was in my house on a Saturday afternoon and there was a knock on the door. I answered and somebody said my name, yes, and they served me papers for a person I had not seen in years, who had stopped coming to his appointments, whom I had filled out a form for driving for several years earlier, and who had had a seizure. And the person who sued me wasn't the guy I'd filled the form out. It was the party that he had injured by having a seizure while driving. So part of what we have talked with Representative O'Malley about are ways that just as there's a good Samaritan or good faith aspect to the seizure safe laws, that there has to be a good faith or good Samaritan act that the physician is acting in the best interest of the patient, taking the patient's word for being an accurate representation of what's going on. And so that physicians won't be so reluctant to, be at risk for somebody who may never follow up with them.
Can I just jump in here? I saw a comment. Well, we need better public transportation in other parts of the state. You're damn right we do. The problem is money, and you've got fiefdoms. And you got to understand that the city that I live, or the village I live in, might be 50 miles away from the city that I work in. And and population is so sparse that it's hard to just have buses running everywhere. So I agree with whoever wrote that 100%, and that if I get lucky enough to get a third term, that's one of the things I want to work on is rural regional transportation. But you want to talk about a hill to die on, that is a very tough one because of money and fiefdoms of this community and that community. We're going to have to change the whole world on transportation to do that. So I'm with you. Whoever wrote that, I'm with you, but it ain't that easy. So we'll give it a go.
Yeah, thank you for adding those supportive comments. And Abby, I'm going to have you tune in a second just with regards to like kind of the logistical next steps that we need to take. But Dr. Barkley, I do wonder if you want to maybe give a couple examples of perhaps seizure types or epilepsy types where you think the possibility does exist alongside Representative O'Malley for an exception basically to be made to the driving law.
Sure. There are certain genetic syndromes such as juvenile myoclonic epilepsy that probably makes up 10% of all people with epilepsy. And I'm sure people on this session who have JME, as we call it. And in those individuals, their at-risk time for seizures are in the first hour or two after waking up. So if they had a license where they had to be awake for 2 hours before they drive, they would probably be at a very low risk to have a seizure while driving. That's one example. Somebody mentioned nocturnal seizures, and if we are sure that somebody only has nocturnal seizures, then they are at a very low risk to have a seizure while awake. And so there's another specific circumstance. Now, when talking about this, we have to realize that when we're talking about probabilities of things happening, rare things can occur. Just yesterday, we interviewed 20 medical students as part of our annual interview process to find 6 residents for next year. And one of the medical students, who is from Michigan, told me that the reason she got interested in epilepsy was because when she was a little girl, her cousin died from having a seizure while driving, even though he had been seizure-free for 10 years before that. At least that's what she was under the understanding of. Now, whether he wasn't having any seizures of any sort or not, that was the family story. And so again, if you think about 500,000 minutes in a year, this is a person who went 5 million minutes without a seizure and had one. So you have to say, yes, there's always a risk, but we know far more people who have fallen asleep at the wheel and driven off the road and crashed into a tree than have had a circumstance like that 1 in 5 million that I just talked about. So when crafting state laws, one has to try and say, what are the probabilities? What is a reasonable risk? And recognizing that we can't craft a general law that applies to 11 million people in the state of Michigan that fits every single circumstance.
Yeah. Now, Abby, logistically speaking here, what's involved in changing the Michigan driving regulations?
Yeah, so as Bree mentioned earlier this year, this group of minds, along with Dr. Zilgit, got together and the Representative O'Malley's chief of staff as well, and put some of these ideas down on paper. And the representative staff has been working hard to draft a bill, and Bree and I have been seeking comments from internally as well as the national organization. And I don't want to speak for the representative, but I think he would have liked to introduce this bill yesterday, but probably introduction maybe when they come back in early December, I think might be the goal. I'll let him speak to that. So it would be bill introduction is the first step. And then the representative is quite humble because he did not mention that he is the chairman of the Transportation Committee. So it would most likely go before the House Transportation Committee, where Representative O'Malley is our chairman, and Bree and the team and I, at the representative's request, would meet with some of his colleagues on that committee to discuss the bill and explain the details and the reasons why, just like we're discussing here. They would have a vote in that committee, and then there would be a vote by the full House before the bill would go over to the Senate for a similar vote in their committee and by their full House. And we didn't talk about this in terms of the Seizure Safe Schools Act, but I just want to mention that our legislature has a 2-year legislative session. So I know we had a different bill number before for the Seizure Safe Schools, and we had an end at the end of the year, our bill expired. And that was because that was the end of that legislative session, and a new one started in January of 2021. And so we're not ending our legislative session this December. We have a whole nother year. And so we're not starting over in January like we had to before. And so we have a whole year to get both of these initiatives done. And we're really looking forward to doing the work and making it happen.
Great, Abby. Representative O'Malley, do you want to comment on any of that?
Yes, I would ask for it to come to my committee so that we could have it. But one thing Abby didn't mention, but I will, just for folks who might not know the process. There's an adage in Lansing that anything to get passed, you need to know this number: 56, 20, and 1. You need 56 representatives in the House to pass it. You need 20 senators to pass it, and then you need 1 governor to sign it. So even though our committee may come together and say, yeah, we like it, I've got to convince 56 state representatives and then the Senate, and they can be, ornery as anything. And then we've got to get a governor to sign it. And on that side of things, wouldn't just be Governor Whitmer, it would be her departments. What does the Secretary, or not Secretary of State, the Michigan State Police have to say about this? What do maybe MDOT for some reason? Who are her departments that could weigh in on this? DHHS, some health angle on this that I'm unaware of, could come in and oppose this, and they're referred to as stakeholders. And they can be, when it comes to a committee, they can be approve it, they can oppose it, or they can be neutral. And if they're opposed is bad, neutral is basically a kind of a quiet yes. And so you want them either neutral or on your side. So this is not a given. I think that this is one of those bills that we may have to fight some of the ghosts of the past, the 30 years of, well, heck no, you got a seizure, you can't drive. But to Dr. Barkley's point, we want to focus it on some very specific parts of this. And we also then want to give the doctors who sign off some leeway too. So it's going to take a little bit of negotiating to get this through, because in its crazy own way, it's a controversial bill, because for so many years we've just assumed it was one way, and we've got to change some minds. So let's give it a go. And I will just say too, next year, this is because of the way things work. Next year, I want to get this in and debated and moving, because next year is an election year. Everybody in the House of Representatives and everybody in the Senate is up for re-election. And once the summer rolls around, people are focused on re-election. So if we don't get this done get it started now and talked about in the winter, we could get lost in the shuffle by summertime. And then, it could fall by the wayside, because then you're into that lame duck where, if you will, more important things might need to get done quickly or whatever. I won't get into all of that, but that's kind of the process. That's why I want to get it moving as soon as we can.
Thank you, Representative O'Malley. We really appreciate having kind of that insider knowledge as to how that all comes together and works. Now, Dr. Barkley, with regards to, all of these efforts, we also, and I'd love for you to speak to this, know that there are some folks with epilepsy that even with changes to the driving law, it's very unlikely that they will be able to drive. And therefore, and we've already touched on, some of the challenges that exist in our state with regards to public transportation. So I'm going to probably send this one to all of you to comment on, so then we can take some questions. But Dr. Barkley, I'd love to know, maybe what are some ideas that you have with regards to other creative ways that we can help address public transportation for individuals living with epilepsy that have a low likelihood perhaps of becoming seizure-free or fitting into one of these exceptions in a driving law?
Thank you, Brianna. Well, first of all, I do think that there may be some money for public transportation in the $10 billion that's supposed to come to the state of Michigan, because some of it's allocated for transportation. But I think the bigger picture is, how can we harness changes in technology to make it possible for people with any disability to get to where they want to go in some sort of a personal vehicle? And we are fortunate in Michigan that we have the brain power of the best engineers in the world who are working in the automobile industry, trying to use computer modeling, predictive algorithms to make it safe to have assisted driving. And most of our new cars have some degree of that already. There are cars on the road today that can sense if you start to speed up unexpectedly and will pull your car off to the side of the road. And I think that one of the things that there's an opportunity is to work with the various automobile manufacturers, as well as some of these companies that are engineering companies that are suppliers to the automobile companies, to help try to make sure that the reason they're designing cars that are safer to drive aren't just so people can talk on their cell phones, but because it can make it possible for people with disabilities who can't safely drive to be able to get to work and live a more normal life. The second aspect of this is that the next stage after assisted driving with these various types of cruise controls is that there are fully autonomous vehicles. We were talking before the chat started that both the University of Michigan and Michigan State have some driverless transport buses for low-speed transportation. And General Motors has just launched in the past 2 weeks their first driverless cruise autonomous vehicle in San Francisco. And I had a conversation by email with the chief engineer for autonomous driving at General Motors, who is fully supportive of helping to make this kind of technology possible for people with disabilities such as epilepsy to be able to live a more normal life.
Great. And actually, I'm going to keep you here real quick, because we just had a question come through the chat, Dr. Barkley, which I think is important to cover with regards to what is the original data or substantiation behind the 6 months blanket law that we currently operate under?
Well, the original law, the previous law was 1 year for all drivers. And most of the states are at the 6-month mark because, again, public policy is to try to say, what can we do to do the greatest good for the greatest number of people? And it was decided through the negotiations that Jack was describing that have to take place to get something changed in regulatory language, was that 6 months was a more reasonable wait than a full year. And so this is the scientific fact is that if you draw a curve, how long does it take from if you've been seizure free to the next seizure? There are various types of data that are dependent upon lots of different variables, such as making sure you take your medication and get your good night's sleep and don't get too stressed out, and all those kinds of factors that play into having seizures. And so that's how, as messy as it is, laws get developed.
Thank you. Now, Representative O'Malley, in that you do chair the Transportation Committee, we'd obviously love your thoughts on what Dr. Barkley mentioned with regards to autonomous vehicles, self-driving vehicles, and also maybe if there's any legislation that you have the inside track on that you think will be especially helpful to those living with epilepsy.
Well, I would think just, moving forward into the future, having no idea exactly what and when, because, just from the electrification of automobiles, you read one magazine and we're going to be 100% electric vehicle, by 2030. And well, that's not going to happen. There's gas powered cars out there, right? And they're not millions of them, and they're not going away tomorrow. And I think when you talk to people in the electric world, anybody who's telling you what's going to happen after 10 years, 2030, don't trust them, because technology is changing so fast and so quick. So I don't know what it's going to look like, but it would just seem logical that if we can get to an autonomous world, you're absolutely right. Someone who is a paraplegic could get from here to there in some type of vehicle. So yeah, I mean, the world is your oyster when it comes to autonomy, and we'll see how it all goes. But that's a little ways down the road. I think that the electric vehicle itself is the first, and then even the autonomous people are saying, hey, that's a little down past that, because there's a whole nother type of infrastructure that needs to be put into place for the autonomous vehicle. So, but it's coming. It will be here someday, I'm sure.
Okay. Well, thank you for that. Appreciate that. And Abby, any comments that you'd like to make to that? And then we have a couple questions.
Sure. I think one thing that I learned from you that really sticks in my mind is that phrase that you once said to me that says, what's good for people with disabilities is good for everyone. And that has always stuck with me. And I think you gave the example of the depression in the sidewalks, that was originally created for people that are in wheelchairs, but now I take advantage of it when I walk my dog, that I don't have to step down the curb of the street. Women, my friends with strollers who walk their children, take advantage of that. And so what's good for people with disabilities is really good for everyone. And so creating some sort of solution for transportation, whether it's autonomous or public or whatever it is going to benefit me, even though I like to drive my car to work. So I think that's a really good point and a really good way for us to find partners in this initiative. And I did want to share that I'm a Spartan. I live in the shadow of East Lansing, and just this month on November 5th, MSU announced their first autonomous bus that they're expecting to start on campus in the start of the year. So I think that's we'll see as both Representative O'Malley and Dr. Barkley mentioned, we'll see things pop up, but technology will move so quickly. Who knows what the future holds for us. And one other thing that we have here in the state is non-emergency medical transportation, which provides non-emergent transportation to doctor's appointments and other medical necessary appointments. And I know in Macomb, Oakland, and Wayne County, there's a pilot through the state of Michigan, where if you live in Oakland, Macomb, or Wayne County and you are you receive Medicaid, you get free non-emergency medical transportation. And so, you know, just continuing to find solutions to eliminate those barriers for people to have access to transportation and find ways that are important to them is really great. And I know there's been new partnerships with Lyft and Uber and all of these new like technological apps that are coming into our lives for food delivery and all of those things I have taken far too much advantage of during the pandemic, probably.
Thank you, Abby. Yes. And okay, so I would love to, I've got a couple of questions that have come in. One of them is am I correct in understanding that there is not a current law in place that requires a school or school personnel to do seizure first aid? And so I'll start off by answering that, but the short answer to that is no, that there isn't. Now, not to say that a lot of schools aren't interested in doing that when they do identify that they have a student or students with epilepsy. We get, our organization fields requests like that all the time. There is also a process within the schools called the IEP process, and we have been able to get requiring a seizure first aid training written into that, which would be, I think, the closest thing we have right now to a requirement for that. But that's the short answer to that. Dr. Barkley, do you have anything you want to add to that?
Yes, the Epilepsy Foundation in Michigan has been doing in-services to schools for 30 years to help particular individuals who have epilepsy who are in a schoolroom. And so this is a one-on-one generated request where the foundation has gone in and provided service to educate the teachers and the school nurses and other paraprofessionals who deal with a specific child with a specific problem. The beauty of this bill is that this kind of curriculum would be expanded to provide a background so that every teacher, every parapro, all the school nurses would have a set of training materials and instruction on how to deal with people with epilepsy.
Yes. And also let me piggyback on that to say that we're offering, and I know this was meaningful with Representative O'Malley, but our organization is offering both the trainings and all that come with that at absolutely no cost to the state. So this is something that we've developed and that we're happy to hand over at no cost. And Representative O'Malley, do you want to speak to just how maybe that you feel will go over with your colleagues?
Well, whenever there's somebody else's foot in the bill, that's a plus. Yeah, I think that's definitely a selling point. You know, because with the school budget too, we're not saying that it'd have to come out of that. So that is a definite plus and a selling point. So that's good.
Okay, wonderful.
So I just want to add that when you think about what do your dollars that you donate to the Epilepsy Foundation get for you, these are exactly the kind of services that the foundation provides for free to help benefit the lives of people with epilepsy in Michigan.
Thank you for that, Dr. Barkley. Okay, so in the last minute, I just want to hand it off to our speakers to maybe say any final words and thank everybody for joining us today. So with that, Representative O'Malley, would you like to go first?
Sure. I just say it's been a pleasure and an honor to be associated with these panelists that are across the top of my screen anyway. Dr. Barkley, well, I'll be honest, when I first saw him on the Zoom, I thought, uh-oh, he's going to be like that, that doc. But then when I saw he had a ponytail, I knew he was my kind of guy. So it's been a pleasure, and I just hope that I can deliver and help this fine organization. I don't want to let you down.
Representative O'Malley, yeah.
Yeah, Jack has been a wonderful partner and a wonderful advocate for us. But what I want everybody on this call to realize is that it's 56, 20, and 1. And each of you need to take your personal story to your representative and to your state senator as well as to make the governor's office aware that this is important to you. Because if we speak collectively with our own personal story, our advocacy will have a strong response that will help Jack get the work done that we all hope that we all see how important it is for our community.
Thank you, Dr. Barkley. And those are perfect parting words, but I want to give Abby a chance if you wanted to say anything before we sign off.
I'll just wrap it up and say a thank you to all of those that have already participated. I know we have been pinging you with updates and so teasing you with some action alerts, but we are planning on a hearing later this month, hopefully, and we really encourage you to reach out to your lawmakers. I think they can put in the chat the link to find your representative and find your senator. Those are the best ways to reach out to your local lawmakers and let them know that you live in their district and this is important to you and why. And so I encourage you to keep doing that, but also want to say a big thank you to all of those that already have, and we really appreciate it. We couldn't do it without you.
Thank you so much, Abby. Thank you, Representative O'Malley. Thank you, Dr. Barkley.